हेलो।
So good morning.
Start. Good morning, everyone. First of all, I thank UK Source. Acha, sorry.
Good morning, everyone. So we'll start the session on pan-ophthalmology, and the first speaker of the session is Dr. Vishal Sharma. He will be talking on orbital and periocular trauma.
Thank you. First of all, I would like to thank UK Source for giving me this opportunity to present on this topic, which is generally avoided from the conferences. Orbital and periocular trauma. Orbital and periocular or periorbital region is an important aesthetic region that is formed by complexity of tissues. Periocular region mainly includes the eyelids, canthus, eyebrow, and lacrimal drainage pathway, though the areas in the vicinity also play an important role in maintaining the structural and functional integrity. At the outset, for those who are interested in trauma, I would recommend to go through this article by Sadiq et al. They have proposed newer classification system for periocular trauma. They have specifically emphasized upon consideration of functional as well as aesthetic status at presentation in details. To ease the flow of presentation, I shall present first the immediate post-traumatic scenarios, followed by delayed ones. Life is first, so evaluate the vitals first and secure life. Apart from our routine questionnaires, do ask for history of unconsciousness, ENT bleed, CSF rhinorrhea, headache, nausea, vomiting, even if the patient presents in later dates like a week or 2 months or later, whenever he presents. This will exclude involvement of the CNS. Followed by thorough ocular examination. Pupil and optic nerve evaluation is a must to rule out trauma to the optic nerve. Record extraocular motility limitations, if any, in all 9 cases. Diplopia charting should be done in every orbital trauma. Even though patient doesn't complain of diplopia, do put the red and green filters in front of him and check for diplopia. Haze charting is done to differentiate between restrictive versus paralytic limitation in extraocular motility. As in this case, with glabular fracture and medial wall fracture with hemocyanus that you can see here, had connection with the cranial cavity. Hence, operating in such cases would have been a miss unless I knew that on his charting the limitation of the muscle was because of the paralytic one. FDT is another important test to check any muscle incarceration at the fracture site. Generally, by the time we oculoplastic surgeon come into picture for orbital trauma, mostly after couple of weeks or 2 months, by then it's too late in various aspects. One, that fracture bone gets united, and other thing is that the CT scan done by the neurosurgeons to rule out any head injury or facial trauma are done with larger section cuts, like 5 mm cuts. Hence, this makes our task difficult to diagnose in the orbital fractures. So what we follow is generally we take 1 mm thinner sections. For example, a young female presented with subtle diplopia in down gaze associated with headache, nausea and giddiness. She had a brief history of fall down at home, like on CT scan and orbit and brain, which was done elsewhere, which was reported normal. Why did this happen? This was just because the scans were of 5 mm cuts. Hence, they missed the diagnosis. Here you can see this chip is impinging over the inferior rectus muscle, and if you focus over here, only within that 5 millimeter frame, this fracture was missed by the radiologist. Hence, the thinner section is important, and also getting the link of scans on PACS system on your mobile phone is nothing less than a blessing. Here, the surgeon can have dynamic view of the scans rather than struggling with the selected images that have been selected by the technicians or misdiagnosed by radiologists. Hence, it's boldly written at the bottom of the reports that you always read. Kindly correlate clinically. This stands true. But no hard feelings for radiologists though. Like in this case, a 2-year-old baby with wooden foreign body injury was missed on CT scan, which usually can be missed unless we have a high suspicion to look for. This was additionally removed thoroughly and ensured that the removal is complete with the help of ultrasound B scan done intraoperatively. And this is how after suture removal the patient did well. Coming to the soft tissue injury, simple abrasions are well managed with collagen dressings and postoperative care with sunscreen and scar modulating agents. In this case, a shallow defect was left over to heal by secondary intention at the lid margin over here. Not all trauma requires surgical intervention though. So as in this case, this is a complex ocular and periocular injury with lid margin lacerations and at multiple sites and collapsed globe with prolapsed uveal tissue. He he denied PL in that eye. At 4-week post-op, now he is awaiting for customized prosthesis. Medial canthal injuries are usually seen associated with canalicular transactions. These are repaired with monocanalular stents that can be removed after 6 to 8 weeks. This is how the stent looks like, and this is the result. In this case, with traumatic NLDO, never operate without a scan. Here you can see there is a traumatized cribriform plate over here, which may lead to CSF leak if you are not aware of how far you need to go on the superior aspect. Hence, these cases are always done under general anesthesia and with neurosurgeon backup. Now coming to the case scenarios with delayed presentation, we do tend to see lots of cicatricial ectropion in injuries near to lateral canthus. In early phases, this can be conservatively managed well with the help of steroid ointment or scar modulator massages, or at times fire a few injections at the lesion site. That here you can see this is pre-treatment and this is post massaging with the modulators, and then surgery can be planned further accordingly. But this can be well prevented by adequate mobilization of the local tissue, by doing good undermining before closure and placing traction sutures at the end of surgery so that the wound doesn't contract and cause retraction. Burns cases are quite difficult to manage, that too after being undergone multiple reconstructive surgeries by plastic surgeons. This gentleman had nocturnal lag of ophthalmos due to cicatricial ectropion in the only seeing eye. In this, first we did upper lid cicatricial correction by doing full thickness skin graft, and followed by the lower lid was corrected with the help of tongue-shaped skin muscle flap that was raised from the temporal aspect. Another case of electric burn with cicatricial ectropion and contracted socket. This was managed with full thickness skin graft on both the lids with socket reconstruction, and prosthesis was given. This is a case of coming to the orbital trauma now. 7-month old history of RTA, operated elsewhere for FZ suture.
Sorry to interrupt, Dr. Vishal. If we can, stick to the time. I think 7 minutes has been designated, so otherwise...
Sure, just
okay.
few slides. He complained of diplopia and he wished for cosmetic correction. There was limitation in upgaze. This was the CT scan showing multiple facial bone fracture. We created we imprinted the 3D model, osteo model for this case for surgical planning, and this is how he was finally geared up with the hardwares in the right eye and the mid face to achieve this final result. You can see with no diplopia. You can see the superior sulcus deformity was well corrected. Even the gross enophthalmos was corrected. This is another case with severe enophthalmos. He had gross limitation in upgaze. This was a large orbital flow fracture. Here, to surprise, we found intraoperatively wooden forehead body, which was not evident on CT scan again. This is another case of firecracker injury at 2 years post-op. She is doing good with her good vision. Alkali burn with complete phimosis of the left eye. Socket reconstruction was done at multiple stages, and prosthesis was given to her. This is another case, a mechanic by profession, and he had injury with a metallic rod, and this is how his aesthetic was re-established. Thank you. To summarize, structured preoperative evaluation would guide wise surgical planning and achieve precise primary repair outcomes. Thank you.
Thank you, Dr. Vishal. An amazing collection of cases that you've presented. Any comments or questions from the panelists or the audience?
Dr. Vishal, I just want to ask, like, for the fractures, what material do you use?
Sir, for different age group, I go for different things. Like in pediatric age group, I go for MedPo. Nowadays, absorbable plates are also available in market, but I have not used yet. And for adults, usually I go for titanium mesh. If I need to correct the gross enophthalmos, then wedge implants are also available that impart volume to the orbit to correct the enophthalmos.
And cases like Dr. Vishal has said that most of the times palliative reports kindly correlate clinically.
Yes.
We get such kind of
Yes.
reports.
Yes, ma'am.
So what is the face-saving options that you have available nowadays that you can resort to, or you just have to again trust your clinical
In what sense you are like saying?
The reports, the radiological reports are not very confirmatory, so how do you proceed with the management?
I do ask for CD if they don't have PAC system with them, and I myself go through the scan and correlate with the clinical symptoms and signs of the patient. So that helps me largely.
So live scans, like, they are like more helpful.
Yeah. The dynamic ones are really good.
Thank you, Dr. Vishal.
Thank you.
We'll start with the second talk of the session, Understanding Multifocal IOLs by Dr. Salil Gupta.
So good morning, everybody. So we'll be talking about how the we are nowadays very interesting thing is that we are using multifocal IOLs and we are stepping up into the premium practice. But then the question is how to understand it. sorry, he's put down the wrong slides. This is my next thing.
Do you have your laptop, sir?
I don't have my laptop, I have the pen drive. So can you take the second speaker? I can load my slides.
Sure,
again.
that's okay, sir.
I think upload was done on the main room. I think that's the problem. I'll check it out. So meanwhile, we can take the second speaker.
So we'll do this presentation later on. In the meantime, Dr. Sanjeev Mittal is here. Okay.
I think they're doing.
Okay.
Sorry for this.
Yes.
First. So they are supposed to be in the second session. Okay, sorry for the delay. So multifocal IOL is an attempt to provide both distance, near and the intermediate vision nowadays. So what is the definition? It is a single IOL with two or more focal points. So we have been having different types of multifocal IOLs, refractive, diffractive, or combination of both. And the latest we are having is a wavefront shipping technology. So what are the refractive multifocal IOLs? They had two types. One was the IOLs which have two zone lenses. The central one was the near vision and the peripheral one was for the far vision. But again, this was a pupil dependent IOL, and the main drawback was that if you are in a bright light, then your distance vision is gone. Then came the annulus type or bullseye IOLs, which are the centralmost portion of the distance vision, followed by a ring of near vision, and again followed by a ring of distance vision. But again, marked pupillary constriction when you are working in a very bright light for the near would cause a problem. So the limitations here were the presence of glare, halos, and reduced contrast sensitivity. Bilateral, but in later part of the life, bilateral submission do help to overcome of this. So now came with the diffractive IOLs. This IOL utilizes the principle of diffraction in conjunction with refraction and leads and helps us to create two or more foci. So what is diffraction basically? So diffraction is the bending of the light. Can I have a pointer? So it's it is basically that the light bends when it passes around the round objects. So it depends upon the wavelength of the light and the space between the two objects. So this is how this condition has been used in a diffractive IOLs nowadays. In a diffractive IOLs, in the center we have an annulus. Right. In the center we have an annulus, and on the sides we have these wedges. These wedges, they leads to the refraction, and the central annulus gives us the first order, that is a zero order image, and the diffracted lights, they give us the second order image. So then that is how you get the two foci, one for the far and one for the near. And the light distribution also helps in that way. For the far it comes to the around 40%, for the near it comes to 40%. There is a 20% loss of the light over here. So what is important to understand over here is that so here we have an annulus and we have height. The height, it helps us in the giving us the power, and the width, that leads to the glare and halos problem. So step 1 gives you the height of the add 1, and the step 2 will give the height of around 2 to 3 diopters. So that gives you a near vision and the intermediate vision. So this is the difference between the traditional trifocal IOLs and a multifocal IOL. Boss, it's not moving. So the height of the step gives you the power. The width of the step causes the halos glare, and the number of the steps that helps us to reduce the loss of the light over here. So then came the concept of apodization. So what is apodization? Apodization means that the height of the steps that will decrease from center to the far. So how it helps? It helps in the preserving the light loss for the far vision, which is contributed by mainly the peripheral part of the lens. Then came the concept by the OSHA that the intermediate vision should be about the 60 centimeters for a comfortable computer work. So how this was achieved? This step 2, it was divided into a wedge, so that now we have 3 things, and the image which was formed at the 80 centimeter was combined and pushed towards the 60 centimeter. And that is how now we have a trifocal lens with an intermediate vision which is given around 60 centimeters, a far vision which is around 120, and a near vision which is around 40 centimeters. So now the main concern was that these refractive diffractive surfaces, they also helps to decrease your longitudinal chromatic aberrations. How they do so? If in a refractive surface, the blue light is refracted first, then green, then the red. And when you have a diffractive surface, you have the red which is focus 1. So when you combine both the 2 surfaces, so you get a correction of your chromatic aberrations also. So the combination helps to decrease the chromatic aberrations. Then came the concept of full diffraction and half diffraction. Full diffraction means that the rings are up to the end. So how that helps? That helps in your night vision, because there will be less loss of light in the scotopic vision. But when you have this half thing, the peripheral light is lost. Then the concept of this bulla and ankle kappa. If this bulla is more than 1.64, up to 1.64, even a small angle kappa variation can be compensated. So this bulla is very important. The size of this bulla is very important. So that can help to avoid the decentration. Even if you have a mild decentration, that's large bulla, about 1.16 to 1.64, that will compensate you for the mild decentration of the multifocal IOL. Then the latest lenses nowadays, we are seeing a double loop technology. It helps us in a good fixation and a very good centration. Another technology which has come over, that the haptics have ridges. Now how this helps? This prevents from the sticking of the optic over the haptic over the optic. So your opening is very smooth and quick. Also, there's another concept of putting an edge at the optic haptic junction, which will help to decrease the negative dysphotopsias. So now we are going towards the EDOF lenses, and we have this wavefront technology. In what is happening over here, that we have transition elements, and the wavefront in the periphery and the center is the speed of the wavefront is different, so that you get an elongated vision. So the concept of EDOF lenses is now introduced itself even into the multifocal IOLs. So you have a combination of a trifocal IOL and a EDOF IOL, depending upon whether the patient has more demand for your intermediate vision or for the near vision. So you can introduce EDOF along with a trifocal IOL. So thanks for that. Thank you.
Thank you, sir. So So, wonderful presentation. Could you just give us some practical tips, like, you know, if a patient walks into your OPD and, you know, asks for a multifocal or a trifocal IOL, what IOL would you prefer for what kind of patient?
So as I said, first of all, we need to know the demand of the patient. And as the old learning goes about the profession of the patient. So if professionally he is fit for the multifocal IOL, then I would ask for the demand, whether his demand is more for the intermediate vision or for the near vision. Is he more of a book reader or he is more of a computer worker? So if he is more of a computer worker, I would go for a EDOF along with a trifocal IOL. And if he is more of a near vision person, then I would go for a simple trifocal IOL. And apodization is another good factor which I would consider. And the third would be to decrease the hazes and the glare. Nowadays the companies are introducing, they are truncating the edge of the step. So if an IOL has a truncated step, the halos will decrease down. The concept of angle C, that is the total internal reflection, comes over here. So that the halos are decreased by truncating the thing. So if I have an IOL with a EDOF, with a truncated head, with the apodization, I think that will be one of my choices.
So there is one question. Suppose after some time your eye is to be operated, would you like to go for multifocal or some other type of lens for yourself?
So I would like to go for a multifocal IOL nowadays.
Will it give precise vision for your surgical purpose as well?
So I think so. See, I have been putting these IOLs nowadays, and the patients are very much happy with such IOLs, especially when I am using EDOF with trifocal IOLs. So I think that would be my choice.
I am not talking about EDOF, multifocal. I mean those with rings.
No, I am talking about rings only. Now we have a combination of EDOF with multifocal IOLs. The one like the BVI company has introduced, that is your fine vision Triumph lines, right? So they have a EDOF center along with a trifocality. So both things they have combined. So such a thing, I would definitely go for it.
Right, thank you. Dr. Bhalla, I'd like to have your opinion regarding this. I mean, how good are multifocals for those who need precise vision for distance and near as well?
I think with advancements, all these problems, the main problem with the trifocal and EDOF, to some extent, more with trifocal, multifocal, was the halo and glare. And with this halo and glare part has really come down with the EDOF lenses. But again, if you compare head to head, the trifocals with EDOF, with monofocal, the contrast sensitivity still remains best with the monofocal, because there is no splitting of light between distance, intermediate and near. And like your very leading question, if you are an ophthalmic surgeon, what would you like in your own eyes? I think I'll still go for monofocal, sir. In spite of all the advancements, yes, they are good. If you are not non-operating surgeon, you can go for this thing. But if you really want to operate, I think, sir, this is my personal view. Because monofocal still gives you the best contrast sensitivity of all the three, sir. What's your
Nothing like, because we as a surgeon, latest things like Eyehance type of lens, monofocal plus, I think that's a good thing. With the micro mono, we can add a 0.5 in the other eye, so that intermediate you get a best of both worlds without losing that contrast.
Because it gives you a minimal add also, which takes care of the intermediate part, and contrast sensitivity is also not that much compromised. So with monovision or micro monovision, you can try these monofocal. They are enhanced monofocal.
Yeah, monofocal enhanced.
Yeah,
Basically.
Thank you, sir. Right. So with this, we'll go on to the next topic.
Right, thank you.
High Altitude and the Eye by Dr. Sanjeev Mittal.
Good morning. This topic is today actually related to the patient, people who are standing to the high altitude, and those people who are living in the high altitude. So how come this? There are some changes they are affected in the eyes. So in fact, environmental factors in high altitude, they predispose to various ocular manifestation, and this is due to low barometric pressure low oxygen partial pressure, and due to lower temperature and relative humidity, and high solar ultraviolet radiation. In fact, in general, 3 forms of acute altitudinal illnesses develop at any time from several hours to 5 days following ascent to height of more than 2,500 meters. Acute mountain sickness, high altitude cerebral edema, high altitude pulmonary edema. So today is just to about the effects on the eyes, and they can be divided into short-term effects, which occurs in lowlanders ascending to high altitude, and long-term effects which are seen in natives of high altitude. So short-term effects will be going across like photophthalmia, snow blindness is what commonly we come across with at high altitude, leading to acute keratitis and due to ultraviolet radiation, and that we know that because ultraviolet radiation increases as we go higher up. With every 1000 meters height, 10 to 12% of ultraviolet radiation increases. And symptoms, I think I'm not going to the detail, everyone is well apprised of this all. And the patient, they develop photophobia and due to the keratitis, and then we are covering it. Normally they present at 6 to 12 hours after the exposure, and particularly when it is a snow cap peaks, when we are going to the high hills during the snowy season. And we treat them, basically treat them as a routine, like just lubricant drops and patching the eyes, weak cycloplegics if required. And basic concern here is how to manage the things, how to prevent. So whenever someone is ascending, one should use actually UV protection filtering goggles or sunglasses, CR39 lenses or Crookes glasses or Polaroid glasses with side shields, particularly when we are going to a snowy area. Recurrent corneal erosions are a concern if a person who are having a predisposing factors in the cornea, like pre-existing corneal trauma or epithelial basement membrane dystrophy, or patient who has been recently operated for surface ablation. Due to the lower pressure, the pathophysiology is a compromised blood supply to the visual cortex also, and that leads to cortical blindness. So some people, they can experience transient blindness in both eyes with intact pupillary reflexes. At times, these are actually not that common conditions, but they are reported cases in the literature also. Amaurosis fugax can also occur due to compromised blood supply to the retina due to the vascular spasm of central retinal artery, leading to monocular blindness, and there we may find RAPD. These conditions actually occur suddenly and without prior sign or symptom of acute mountain illness. So the concern is just here, because when you are ascending, like a patient may not be developing acute mountain illness, but this may occur. However, some predisposing factors, systemic form may be there. Treatment is oxygen inhalation or hyperbaric oxygen, rebreathing carbon dioxide. The best treatment in such condition is descent to a lower altitude. Then it is reported that some people develop dysmotility due to 6th nerve palsy. Again, it is a self-limiting, and when the patient come down to lower altitude, it disappears. Now, high altitude retinopathy is reported in some people, and pathological changes occur in the retina in an acclimatized individual who are exposed to hypobaric hypoxia of height more than 2,500 meters, and which presents with hemorrhages and sometimes with papilledema, disc edema as well. In fact, this is a predictive clue that there is a possibility of high altitude cerebral edema, and there is a significant correlation been seen. And the management is that, like the descent, normally it is a self-limiting, resolves within 1 to 2 weeks, and the descent is the treatment, and symptomatic treatment at that time, like which in general we give to the patient, the rest, oxygen, acetazolamide. Prevention, how to prevent like such conditions. Basically, when someone is going to high altitude, they should actually go, there should be slower ascent. 300 meters per day is particularly for mountaineers. So it leads to acclimatization. Like some people are going to Char Dham Yatra here, so they just hire helicopter, they reach directly there. So it's always advisable, you first reach at the base with the helicopter, stay there for a day or two, then you go to Kedarnath. So this is actually what is recommended. And maintenance of higher SpO2, avoidance of strenuous exercise. One should avoid doing any exercises there when they are reached Badrinath or Kedarnath, such areas. And avoidance of Valsalva maneuvers. NS8 should be avoided. Now the eye problems associated with past ocular or medical conditions, mainly basically, if someone is having, and people who are living there, the pterygium, dry eye syndrome, like we know that cataractogenesis is more there, and some people, a very few people, it has been reported, actinic keratopathy, spheroidal degenerations are reported. So dry eye, in fact, can be reported in early as well as late also, and the just lubricants. Another thing is the protective glasses. So those who are using contact lenses, there is nothing like just to, no precaution is required except that proper maintenance. And people who have gone through advanced surface ablation, so it is advised that within a month, one should actually avoid, if someone is going with the protective glasses with lots of lubricant treatment they are taking, there are a little problem of glare to these people. It has been reported in some people they have recently been operated with the intraocular gas after retinal surgery, then it expands, leads to raised IOP. So there are little things like one can avoid. So to conclude, actually, individuals who travel to high altitude may experience some ocular problems, and we ophthalmologists, not ophthalmologists, in fact physicians also should know actually that if someone is going up high up in the mountains, so what are the things to be avoided in general, not only eye, otherwise also what should be avoided. And people who have recently been operated, so those who have undergone surface ablation or those who have undergone through retinal detachment surgery with gas, immediate post-operative period is better to avoid, immediate. And descending to low altitude land is the key to management of all problems. So I need protective glasses are very much required, and this CR39 lenses, or otherwise this hat and felt cap, they also add to it. So this is the end. I just mentioned because in our institution we are having one course of high altitude medicine, DM in high altitude medicine. So in fact the resident actually remains posted 6 months there. So I actually have taken the feedback. Practically that resident has come across is not all these problems of which we have been asking him in the last 6 months. So mainly the dry eye he is just facing, and at times sort of ophthalmia. So not because maybe that he could not detect, but just I mentioned the things which are mentioned in the literature with the mountaineers as well. Thank you very much.
Thank you, Sanjeev. This talk was more of an informative and educative.
Yes, sir.
So if there is any question,
yes, please.
Please go ahead.
So what is the idea behind avoiding Valsalva maneuver? How is it going to?
Actually, that actually raises the, it is at the blood flow circulation actually. That actually, it affects that circulation. So Valsalva actually to accelerate the patient who are developing cerebral edema is basically related to the blood circulation, microperfusion.
People are also advised to take acetazolamide, sir.
Yes, sir.
What is the logic of that?
Actually, it's said actually reduces the intracerebral pressure as well. Na? That's a CSF pressure is also declined. It is said.
And of all the ocular surgeries, you said retinal surgery, and if they have undergone
actually retinal
LASIK,
surgery, this is this is not my personal experience of that. In fact, I consulted to 3, but in the literature cases are reported. And for the refractive surgery, I talked with the refractive surgeons, although I'm not doing refractive surgery, but I talked to refractive surgeons in Dehradun, and I asked their experience. They are, and so they mentioned surface ablation only in like they have this issue, not in LASIK.
Actually, surface ablation, if I can just go.
Yes, you can.
When you ascend to high altitudes, high latitudes, you go to the polar regions, you have all of this exposure to UV light, as you had mentioned,
yes.
sir. So all of these things, I don't know the molecular and cellular basis of this. This is found to enhance keratocyte activity, which increases,
Yes.
the chances of post-PRK haze. So that's
Yeah.
why, post-LASIK, we advise for a few months you wear UV protective gear, till at least 6 months have passed since from the date of the surgery. So probably something of that sort, which we don't encounter with LASIK because you're ablating at a deeper depth. So probably.
In fact, I'm sharing that what practical things I gathered from the resident doctor of DM from high altitude in 6 months duration. He said only the dry eye he noticed, and some patient like photophthalmia, some people. And other thing he said, like mountaineer sickness, that was common. But like people who have suppose hypertension and they are ischemic deficiencies, like they are prone to develop. So like we keep on hearing MI occurs. So those things can be related. Basically it's vascular, mainly vascular.
At a high altitude, usually the blood pressure increases.
Yeah.
So, what is the situation in intraocular pressure? Is it how much?
Actually, it is. I reviewed the literature. Actually, some studies says studies done IOP no change. Earlier study showed there was a slight increase, but recent study I seen in 2023 also no change. In fact, we are planning now, since we have a resident posted there, so we'll put a project with him now in ophthalmology. So I just thought of to share this thing here. So I also get a feedback from everyone.
I myself faced a brain fog actually. Suddenly I was at Khardungla, 17,000 feet. Okay. I was stayed there for half an hour. People advise always take a Diamox before. Sudden high altitude does cause brain fog.
Yes, yes.
It's very scary. It is very scary.
Yes, yes. Even we had gone to Kedarnath this last year. And we went to helicopter considering that till that area base place, and then we stayed there for overnight, 2 days. Then we went up with the helicopter. But after reaching there, 1 hour after, I started developing headache. And since we left in next morning, I kept on having headache. So that is one of the early sign.
So one should take Diamox actually. It's advisable.
In Leh Ladakh, everybody goes with a pack of Diamox.
Yeah.
Thank you, sir. So the next talk will be grief counseling by Dr. Tarannum.
So good morning, everyone. Again, as Dr. Oli said, more of a informative and just an educative talk. But whenever I get an opportunity to talk at any platform, I always take this opportunity to talk about anything related to eye banking, because we don't get so many opportunities to make the general population aware about what it is all about and what are the problems that we are facing. So now today I'll be discussing a very important topic. As far as I feel, it's the backbone of eye banking, grief counseling. We all understand grief counseling is a very basic term we all understand, but when it comes to eye donation counseling, grief counseling related to eye donation, it's a different ball game altogether. So eye donation counselor, just like any other grief counselor, he has to basically connect with the grieving family of the demised. He has to comfort them, but the trick, and rather the game changer, he has to at the same time mobilize the family towards eye donation, which by no means is an easy task. And when I say that, please believe me, because with all my practical experience, I'm talking about it. So even, a good start is the key, but even starting a conversation in that scenario, somebody has lost his near and dear one, and now we start talking about eye donation, it's not a comfortable scenario at all. So we can start with a simple sentence like, sorry to hear about your loss. Can I talk to you for 2 minutes? But even this simple basic conversation doesn't come naturally to most of us. We can keep practicing, but it's not easy. And even the response is very, very expected. Sorry, we don't want to talk about it, please leave us alone. So even if we are in the same, God forbid, if we are in the same situation, nobody would be like to be disturbed or talk about any general awareness program at that moment. But the job has to be done, and the normal human reaction is initially that of shock, followed by grief, and then people just want to be left alone. They don't want to talk about it. So this is the normal human reaction. And we can't afford to talk to anybody and everybody. There'll be a hell lot of people around, in that scenario, in that situation, and we can't afford to talk to anybody we like or anybody whom we are like comfortable talking to. We have to spot the decision maker and the influencer. Decision maker, basically when I say decision maker, it's the next of kin who is going to take the final call. So, but the decision maker is the one who will be like most affected by that situation, and he will be in a position not to talk to you. So what you can do is, you can talk to the influencer, somebody who will be like, the decision maker will be more comfortable talking to. So he might act as the mediator between the decision maker and the counselor. But how do we spot them? How do we spot the decision maker, the influencer? So one is, we can just observe from a distance for some time, and the job might be done. But more helpful in like hospital cornea retrieval program is the paramedical staff. So they all know about the attendants, their nature, their attitude. So they might help you spot this decision maker and the influencer. And ultimately it's going to be a family decision, a group decision, but you don't need to talk to the whole family. That is just going to spoil the things. Just stick to basics and target the influencer and the decision maker, and the whole family will come on board. And it should never be a monologue. When we talk about our cause, we are usually in a rush because time constraints are there, but then we should always give the time to the other party to, to share their mindset, to share their, whatever their opinion is about the subject. So we should be listening, and listening to basically understand and not just to respond. So what is the normal human, again, nature, that we usually listen, we just want to reply, we want to respond back immediately. But we should always take a pause, listen to understand, and then respond, very, very accurately. So that's important. Also, when you want to start the conversation, you don't know in which direction this conversation is going to go. So sharing the positive information first is going to help, because that is at least not going to take the conversation in another direction. So negatives will not help you take the conversation take off at all. So positive things first, always remember that. These little things help. And what are those positive things? What is the positive about eye donation? We can enumerate a number of things, like 2 corneal blind people will get vision. Very simple, very basic, but it helps. So what I've seen in my experience, that this basic information, when we share with the family, they do listen to you. They are suddenly, conscious of the fact that yes, whatever they are doing is not going to go in vain. Then disfigurement is a genuine concern of every family, that disfigurement will happen, so they don't want to disturb the body. So, but when you say that it is only the corneal button, again a very basic information that we are going to retrieve, not the whole of eye globe. So this also has a very positive calming effect over the family. Religious myths, again, a very sensitive issue, but then that barrier has to be that, myth has to be broken, that no religion is basically against any kind of, not only eye, but any organ or tissue donation. So they are all in favor of all these donations. Time constraints, they all have to be shared, that it's a very short procedure, it will not be affected. Then acknowledgement is something which is on the minds of all the family members, that how are we going to basically prove that this donation has happened, they have done, this kind of act. So appreciation certificate, though it will be given in the end, but this again little piece of information should be shared right in the beginning. So this is also very helpful. Then if the time permits, you can, share the general information, indications, contraindications, procedure, documentation. So don't think that this is the only case that I'm talking to. Ultimately, this case is going to act as a brand ambassador in the whole society, in the community, and they are going to share that piece of information with the rest of the community. So that way, the information has to be very accurate, precise, and you should always not refrain from sharing all this information. So this was basically the basic procedure that we have to be careful about, how to start, what to talk about, but how do we conduct ourselves? Even that is very important. How do we ensure that we are being taken seriously by the other person? They are in a mood to listen to us. So your appearance has to be not very formal, not very casual, but yes, it has to be neat. You should not be taking anything for granted. So each thing is going to count, because you are at the end of the day a stranger to the family. So how do they connect to you? How do they give, importance to whatever you're talking to? So that is important. So little things like wearing an eye guard or an apron, if you are in that situation, is going to add gravity to whatever we are saying to the family. And language is important. Usually it's not always possible to talk in the regional language of the other party, but yes, we should not be very off. If the patient is totally a Hindi speaking family and we start talking in things like hi, hello, how are you, things are just going to go in the other direction. So you should try to relate as much to the family as much you want them to connect to you. So if you have somebody in your team who can talk in the regional language, all the more better. So you should put that person forward if that is possible. So these little things are going to be helpful. All that we want is that they should trust us. They should trust to whatever we are, saying, whatever we are quoting. Questions will, come across, and we have to just keep it very simple. If the question is simple, answer should also be simple. But if, yes, it is technical, the answer can afford to be technical as well. Do not give up, because it's not going to come easily. No is going to come instantly. We don't want to just, we don't trust eye donation. We don't want to donate the eyes. But yes is going to take some time. So give the time to the family to discuss. At the end of the day, it's a group decision. So you have given them the information. Give them time to process that information and wait. So yes will take some time. But whatever is the answer, a yes or a no, don't take it too personally. It's going to hurt. Okay? So, but yes, you have to analyze whatever your performance has been in all the cases, and don't be just too enthusiastic of your success or too frustrated of your failures, because it's going to hurt. But yes, you can improvise as per the situation, evaluate each case, and keep on getting better and better. There is no fixed formula actually, because each family is different, their mindsets are different, their situations are different. So we have to basically customize our plan as per the situation that we are in. But again, easier said than done. Sometimes we have to act as counselors in situations when we are not expecting, and some of us are actually inherently good counselors. We can just talk about any topic in a very, very rational way. And some of us are becoming counselors with practice. But then can it be a part-time job? Okay, here and there I counsel some patients and donation happens. So is this going to really work for the eye banking system? No. So again, the message is that we need good, full-time, well-trained, professional, passionate counselors if we really want our eye banking system to work and flourish. Thank you so much.
Thank you, ma'am. I think grief counselors have to have really good interpersonal skills and social skills to talk with a family in such a situation. And all of us corneal surgeons, we bank upon the success of the grief counselors for all our practices. So thank you. Any comments or questions from the audience or the panel?
Thank you.
What's generally the success rate of the grief counselors that you've seen?
Actually, it's very variable, Devesh. Sometimes there are, counselors, if they get into the system properly and they understand the system, they will have a very, very good success rate. And at the same time, if it's not clicking with somebody, they will have consecutive failures, and that's like something which, puts them off. So this is something which requires constant effort, and without dedication, it's just not going to work. No amount of training is going to help you if you are not into this, business with your heart.
Thank you. So the next talk will be on any comments? Dr. Neelima Mehrotra on UG and PG teaching. It's not here. So if she's not here, we can go on to the next talk, PCR management during phacoemulsification by Dr. Vipin Sani. Facts of collagen cross-linking. Dr. Tanvi Soni, please.
Good morning, everybody. So after a very thought-provoking talk by ma'am, I'll be taking to a more theoretical topic, which is corneal collagen cross-linking keratoconus. There are no financial interests. So I'll be briefly discussing upon the principle, indications, and the surgical technique in collagen cross-linking, the thin cornea and its variations, which have come up over last 20 years, and the applications and advances if time permits. So historically, again, like phacoemulsification, collagen cross-linking has been inspired by the field of dentistry, and it was Professor Theosilus' inspiration to use UV light to stimulate cross-linking in the cornea. The first study was published in 2003, and first International Congress for Collagen Cross-Linking was held in Zurich in 2005. So before proceeding on to the surgical technique, understanding the physiological basis of collagen cross-linking, so what happens is that once the intracellular molecule, once the intracellular collagen is prepared in the form of procollagen, it is transported extracellularly in the form of a helical collagen trimer. And then there is a formation of a mature tropocollagen extracellularly. After the formation of the helix, these helices interact with each other naturally under the effect of enzyme lysyl oxidase, and that leads to the formation of cross-links. So this is the physiological cross-linking that happens in the normal human cornea. So that leads to the formation of collagen fibril, and ultimate the aggregation of collagen fibrils leads to the formation of collagen fiber. So cross linkages, what they do is they stabilize and prevent the collagen fibrils in the curved cornea from sliding apart. Normally in diabetes mellitus or in corneal scars, there is increase in corneal cross-linking, and decrease in cross-linkage is seen in syndromes like Ehlers-Danlos syndrome or keratoconus. There are three basic components to collagen cross-linking. One is a photosensitizer molecule, which is riboflavin. It is absorbed adequately by the corneal stroma on topical application, and the absorption peak for UVA rays is 370 nanometers. And then the UVA application, which has the peak wavelength at 365 nanometers, ideal for collagen cross-linking. In the presence of oxygen, these three components interact and lead to a photochemical reaction. The basics of the photochemical reaction is, once the photosensitizer is administered and the cornea is soaked with the photosensitizer, the UVA is applied. Then the riboflavin gets activated, and there are two pathways which lead to the formation of cross-linking. One is the oxidative pathway, where the type 2 pathway, which is oxygen mediated, is the main pathway that leads to collagen cross-linking. The basic surgeon's armamentarium for cross-linking is a cross-linking machine, riboflavin dye, and a patient who needs collagen cross-linking. So types of riboflavin which are available for us are isotonic riboflavin for the traditional conventional collagen cross-linking, which contains riboflavin 5-phosphate with 20% dextran. Then we have Peshke M, or there are other companies also. There are no financial interest. I'm just stating this because I have been using these dyes. So riboflavin 5-phosphate with 1.1% HPMC, which is the standard riboflavin solution without dextran, because of the issue of corneal dehydration, which occurred with the use of dextran. HPMC was introduced. Then hypotonic riboflavin, which has been introduced to thicken the thin corneas, which have a corneal thickness less than 400 microns. So hypotonic riboflavin comes in the form of riboflavin 5-phosphate 0.1% without presence of HPMC or dextran. Then transepithelial riboflavin, rapid, and riboflavin extra for the refractive collagen cross-linking. There are various indications for which collagen cross-linking has been used up in the literature. I'll be sticking to the keratoconus. So there should be a documented progression of keratoconus, advanced keratoconus presenting in the young age group, or a patient having at presentation Kmax of more than 59 diopters. or in CXL plus, which is the refractive modification of collagen cross-linking in keratoconus, where collagen cross-linking is combined with PRK, PTK, ICRS, or a phakic IOL. Contraindications for collagen cross-linking are pregnant or a breastfeeding patient, patient with prior herpetic infection, active ocular inflammation, severe central or paracentral corneal scars, autoimmune disorders, history of poor epithelial wound healing, and a relative contraindication for conventional cross-linking is corneal thickness at thinnest location less than 400 micrometers. The traditional Dresden protocol, which was given in 2003, included a removal of the epithelium using proparacaine drops, followed by riboflavin instillation for 20 minutes, 2 drops every 30 minutes, and that is the soak time, and then UVA irradiation, which included UVA application of 365 nanometers, which included the intensity was 3 milliwatt per centimeter square, which amounted for a dose of 5.4 joule per centimeter square of the total fluence. Riboflavin instillation was continued for 30 minutes. During this UVA irradiation time, 1 drop every 3 minutes, and at the end of the procedure, topical antibiotics are applied and BCL is placed. So this is a brief surgical video showing the surgical technique. So there is a well is being placed, which is a 9 millimeter well, and I am here using 20% ethyl alcohol for delamination, drying the ethyl alcohol and then thoroughly washing off the eye, followed by removal of the epithelium. Alcohol gives you a very good bed for removal of the epithelium, and after that UVA soaking is done, and the soaking is done and followed by collagen cross-linking using UVA. So now CXL has come far from the basic collagen cross-linking to the refractive form of collagen cross-linking. So after it has been well established that collagen cross-linking leads to halting the progression of ectasia when performed in the traditional Dresden protocol. Now the surgeons aim to reduce the treatment time, improving the patient comfort so that they don't have to remove the epithelium and patient is comfortable on post-operative day 1. That led to the evolution of accelerated collagen cross-linking, epithelium on collagen cross-linking. After that, the surgical technique modified in the form of when you halt the progression, how do you improve the visual acuity of the patient? So then came the procedures like CXL plus, where collagen cross-linking was combined with PRK and PTK, and customized collagen cross-linking is being done. So modification in collagen cross-linking in the form of accelerated cross-linking, transepithelial cross-linking in the form of riboflavin delivery, improving the oxygen diffusion in the form of pulsed collagen cross-linking. So is accelerated collagen cross-linking actually better? So there are limiting factors which have come up after, I think, 5 to 6 years of introduction of the accelerated cross-linking, that is the role of oxygen. So collagen cross-linking when done in low oxygen environment failed to yield the biomechanical stability following collagen cross-linking. So that is how the concept of pulsed UV light has come. That involves UV light on and off time so that there is a time for oxygen replenishment in the cornea and the soaking is continued. So I'll be rounding up that there are variations in surgical technique for thin corneas as typically 350 to 400 micron corneas. You can use a hypoosmolar riboflavin. You can alter the corneal thickness by using an epithelial on procedure or contact lens assisted procedure, and a sub 400 protocol, which is the adapted fluence protocol given by Hafezi et al., is still in the preliminary stages. So I'll be just winding up that whenever we see a patient of keratoconus, the aim of the treatment, and we prescribe the surgical procedure in the form of collagen cross-linking, we should tell the aim of the treatment to the patient. The aim of the treatment is halting the progression of the disease and not improving the visual acuity when done in the traditional conventional way. Corneal thickness after removal of epithelium should be considered as the safe limit is 400 micron. The risk factors for healing should be treated like if a patient has an allergic conjunctivitis, vernal keratoconjunctivitis, that has to be treated, and patient expectations has to be set. So patients with a better visual acuity prior to collagen cross-linking are those with the greatest chance of vision loss due to the development of haze after the treatment. So that has to be taken care of. So take-home message from my talk would be conventional collagen cross-linking should be done with the minimum corneal thickness after removal of epithelium, 400 micron. Modification in conventional protocol for thinner corneas is yet to be standardized. Accelerated cross-linking should not be opted for as a procedure for rapid movement from traditional protocol, and its newer studies in the form of pulsed CXL are to be awaited, so that the modification should be shifted to accelerated form. The collagen cross-linking may be beneficial in combination with an ablative refractive surgery for improving the visual acuity, but the best protocol yet remains to be identified. Thank you.
Ma'am, suppose refractive surgery has to be taken along with this. So which procedure will be done first?
So actually there are studies for sequential procedures as well as simultaneous procedures. So 3-year studies have shown that even simultaneous procedures are as effective as sequential procedures. So first thing what they do is do the refractive surgery and do the cross-linking, because it is difficult to ablate a cross-linked cornea. So first is the ablative procedure and then is the refractive procedure. That is what I have studied. I have no personal experience in doing this. This is all theoretical, sir, for me.
LASIK correction has to be done first.
Yes.
Great.
So
Thank
any
you.
difference in the post-op protocol between, a simple cross-linking procedure and versus you do a patient with a topo-guided surface ablation with a CXL? Because post these two procedures, you generally find
Yes.
that there is a lot of corneal haze. So
Yes, sir.
do you modify anything differently post-op?
As I have already said, I have no experience in doing a CXL plus procedure. I have done transepithelial procedures and I have done contact lens assisted cross-linking, but not the plus procedures. But what I have read theoretically is what the people who propagate, they use these surface anti-inflammatory agents like lotepredniol or fluorometholone for a longer time, like for 3 months.
So actually, at least for my patients, I've seen,
Yes.
although the post-op, the vision is definitely better, but you find a lot of corneal haze. Any comments from the audience, like post topo-guided CXL, topo-guided PRK with a CXL, anything different that you do to, reduce the post-op haze in these patients? I would love if anyone can comment on this. Dr. Abha.
So here probably the only difference would be that you want some amount of haze, because that is what is the outcome of a cross-linking. You want that anterior stroma to be strengthened as well. But the other than just undercorrecting slightly, if you are doing a refractive procedure along with a cross-linking, the steroids remain the same. The patient needs to be counseled regarding the haze, because you are doing a cornea strengthening procedure, the outcome of which is that, and considering the regression because of that, yes, you undercorrect. Thank you.
So we'll go on to the next talk, Pearls of Corneal Tear Repair by Dr. R.S. Chauhan.
Where is this? I had given there preview.
Dr. Piyush is present. Okay. Dr. Amit Khosla. Dr. Amit? Okay, okay. Dr. Anjani Khanna. Dr. Anjani Khanna? He's not there. Okay, Dr. Oh, all right.
I told him, he said कि भेज दिया है. Yeah, ये no, ये नहीं है यार. Pulse incontinence repair, ये वाला.
Does anyone else feel that it's a little too chilly over here?
Can you?
Can someone please reduce, can raise the temperature, the AC?
It is too much.
Yeah, I think everyone is sitting very uncomfortably over here.
So, good morning, everybody, and thanks Uttarakhand Ophthalmic Society for inviting me. I'll be talking about the pulse of corneal tear repair, the golden rules. Actually, if we see at the background, the maximum young adults are involved, and the second peak is in the elderly. Children are the third, and then the mainly males. And if there is injury of one eye, the chances of second eye is 3 times. And the commonest cause of unilateral blindness. Now, decision making is very, very important. Whether to operate or not to operate depends upon size, location, vision, and whether it is sealed or not. Whether to operate under GA or peribulbar, facial or retrobulbar, or even topical. When to operate is very, very important, because sometimes if the good OT is not there, then people usually postpone till next day. So who will operate? Most of the time what is happening, this is all because of injuries, all the juniors are operating, and you see the long term effect. If the learner is operating, then what will be the astigmatism of all the patients? So actually, if there is corneal tear repair has to be done, it should be done minimum by the senior resident in the institution, or if by the junior resident, then it has to be supervised by some senior person, so that the astigmatism can be taken care of. The initial approach is that first priority is life. That is very, very important. So next we go on to the cornea. Then initial evaluation, you have to identify the life-threatening injury, and you have to document all the injuries, because all these cases might be MLC cases. And then assess associated medical conditions as well, because most of these patients you might need to give GA. So if there is underlying medical condition, then things can be different. And then history is very, very important, like if some phone body has gone inside, or patient was using the glasses, so that glasses might have gone inside and may not have been seen, so that has to be removed. And some of the material are inert, and some are highly inflammatory depending upon the material and the type of injury, whether it is sharp, blunt, or spontaneous rupture is there. Examination, when? Actually it should be done in OR, and after life-threatening emergency has been ruled out. Normally, in the casualty only the people start to examine the patient. Once there is corneal tear, the patient's eye should be patched and should be examined under microscope. And immediate order should be fasting. That patient should remain fasting, so that we can save time. And the visual acuity you can always assess. Torchlight examination can be done. Fundus, if it is you can see without touching the eye, can be done, and ARPD or pupil should be seen. And the occult sign of globe rupture, these are some of the signs which we should suspect that there is globe rupture also. Sedal test can be done. So imaging is also very, very important. So plain film radiograph should be done, and CT scan, and to detect intraocular phone body. And it can detect up to 1 millimeter of phone body. Ultrasound is reserved basically for follow. At primary level, the patient should be referred immediately, should not try to unnecessarily spend time, and injection TT can be given. All steroid, it is always controversial, but antibiotic can be given, and primary repair has to be done within 12 hours. Now we are coming to the corneal tears. So, management of self-sealed corneal tear, full thickness wound with deep AC, with no iris incarceration, with normal IOP, and after imaging has ruled out intraocular phone body. If it is less than 2 millimeter, conservative. If it is more than 2 millimeter, surgical repair has to be done. If it is lamellar, then bandage soft contact lenses if it is undisplaced. Partial thickness sutures should be applied if it is displaced. If epithelial ingrowth in the late presentation, then debridement with suturing has to be done. Now anesthesia, because most repair requires general anesthesia, and if there is no systemic contraindication, local or topical anesthesia with simultaneous IV sedation can be done. Avoid pressure on the eye. Povidone iodine not to be put in conjunctival fornix. Copious irrigation with saline is adequate, and universal eye speculum is enough. No periodic suture is applied. This is the principle of the repair. One should have the clear plan and adequate preparation of the tissue should be done. And the suturing principle is that you have to conserve the tissue and identify the landmark like limbus and satellite and sharp angle of the laceration. Corneal wound repair greater than 2 mm with tissue loss must be closed surgically. A side port entry is a must as primary entry. Interpreted suture, these are the shape of the sutures that they should be watertight, 10-0 nylon suture should be applied and they should be spatulated microsurgical needle. Bicovered needle with short radius for short and deep bite in central area and needle with large radius curvature around 160° with larger bites and longer passes in corneal periphery, because in the central we need smaller sutures. And it should be up to the 90% of the depth of the cornea, as you have seen in the picture. And these are the interrupted sutures. That suture passes through visual axis may be avoided because they will cause opacity, and if required, short, small sutures wide with no touch technique. Means you don't have to catch the cornea. You can enter with your vertical orientation of the needle and enters, and then it will come out. And the tip of the needle is placed perpendicular to the corneal surface and exiting perpendicular to the cut surface. All knots are trimmed and superficially buried in the stroma. Now the deep passes of equal depth has to be done, and length of the each suture pass has to be equal as per measured from the intersurface of the cornea. And the suture the perpendicular area first. If it is sailed or beveled portion, then suture should be centered on the posterior aspect of the wound margin. And these are the edematous or macerated wound. We have to slightly longer passes may be required and incorporate healthy tissue in bites. Full thickness box suturing if unequal thickness is there, and tighter suture in edematous cornea. Continuous suture actually in laceration with clean cut state as is, they are faster and uniform zone of compression. Problem is that excessive flattening of the cornea occurs and sometimes there is misalignment. There is one of the technique is Rouse-Hay technique, but the aim of the suturing is to provide clear central cornea with uniform spherical contour, and the peripheral tight compression sutures in cornea periphery steepens the central cornea. Longer, closer and slightly tighter suture in the periphery, and shorter, wider and slightly loose sutures in the center. It neutralizes the gross surgically induced astigmatism. In jagged, so these are the types of suture in jagged incision, and satellite laceration pursing suture may be applied. Loose fragment is repositioned and sutured, and overseeing bandage, contact lens and cyanocolate glue is used. In small tissue losses, tight suture. In large tissue losses, the corneal patch graft has to be given. In scleral laceration, 8-0 limbus should be sutured first, and the iris tissue is repositioned with the viscoelastic and the side port. And these are some of the area where you have to apply the suture at sharp ends. And post-operatively, topical and oral antibiotics. Systemic steroid still is very controversial. Cycloplegic 4 to 6 weeks along with the lubricant and secondary complications are treated whenever they occur. So suture should be removed if they are loose suture or exposed suture, new blood vessels to suture, mucus accumulation, suture infection or abscesses, healed wound, graze wound, fibrosis, etc. So carry home message is repair as early as possible. X-ray skull essential, CT preferable in retained intraocular foreign body, slit lamp examination, surgical plane in all cases, operated under GA unless contraindicated, minimum tissue handling, no touch technique and side port is a must. When wound leak persists, bandage, contact lenses, tissue adhesives, patch graft, avoid suture in the visual axis or suture limbs are kept very short. In emergency setting, preserve the globe and avoid enucleation. In emergency setting, repair of laceration is priority and reconstructive surgery planned in second sitting. Prophylactic cryotherapy to prevent RD is not recommended. It is very, very important. Thank you very much.
Thank you, sir.
Like in your oblique partial thickness of corneal bones and where it is attached with the base, so do you always leave it, or if it is only, if it's a small one only? If it's
See, if they are full thickness and AC is formed.
No, not full thickness, partial thickness, oblique corneal wounds. And I mean, do you just use a bandage contact lens, it will heal, or you just give a one stay suture?
Actually, if it is a thin and more partial, like if it is raised, you can see. If it is raised, then you have to suture, because that gives good apposition. But if it is salving and flattening, you can see on slit lamp, it is not raised. Then if you apply the bandage contact lens and advise the patient not to rub the eye, so it will take little longer time to heal, but it will definitely.
Then there are chances that it may not heal, and so I mean just a stay suture, like will it help?
Actually, stay suture, what it causes, because it sometimes pulls, because the uneven and irregular area, so the thinner area will be dragged, and that will cause more astigmatism. The periphery will be little raised, and that central area will be tight. So that is why it will cause astigmatism. It is in the periphery, you can always apply, but in the center, if you can wait for some time, because in my experience, I have seen that if it is a larger tear, then probably you might need suture, and then it should be non-touch technique, because the thinner area, if you catch with the limb forceps, it crushes, and then it causes more problem than. So our idea is to avoid astigmatism at all cost, and corneal opacification. And one more thing I want to stress upon, that all these patients where you feel that probably it is sealed wound, we must look for antechamber if there is hypopyon, the patient is coming after 6 hours. Because I had seen one of the patient where it was sealed corneal tear, and everything was okay except for little hypopyon. So it had to be repaired. And then if you have to repair, because of there are some contraindications, systemic contraindications, if you have to repair urgently, then you can actually repair the corneal tear only under topical or retrobulbar block. And because sometimes the patient is not fasting, and you need to repair patient, and you have to give the intravitreal. If you have to give intravitreal, if there is hypopyon, then the IOP will increase. And the first side port entry is a must, because later, because the eyeball is very soft and the suturing will be very bad. So we have to make the side port, and maybe we might put viscoelastic so that the eye become tight and the suture will be good.
Yeah, point is well taken. So proper depth, stitches should be neither too tight or not too loose, and knots with tenno should be always be rotated. These and no delay, because making a OT ready for emergency surgeries does not take more than 1.5 hours. Am I right? Only cleaning autoclaving your equipment, and linen is already disposable you have. So no delay in surgery. These are the points to be taken home messages. Thank you, sir.
So now we invite our next speaker, Dr. Piyush Kohli. He'll be talking on diabetic retinopathy management. Do lasers still have a role?
Good morning, everyone. I'll be talking about the role of lasers in diabetic retinal management. I have no financial interests. So the treatment of diabetic retinopathy will be lasers, intravitreal injections, and surgery. So the classical role of lasers in PDR was established by the DRS study. The question it answered was, does photocoagulation prevent severe visual loss? When the BCVA was defined as less than 5/200 at 2 consecutive completed follow-up visits, more than 4 months apart. So answer was yes, it decreases the incidence from 15.9 to 6.4, that is 60% decrease at the end of 2 years. So PRP has been the first line of treatment for PDR since more than 4 decades. But it has a lot of side effects. It is painful, it is inherently destructive, it leads to peripheral visual loss, it leads to night vision loss, it can cause foveal burn, lens burn, transient blurring of vision, there can be exacerbation of the pre-existent DME, there can be exudative retinal detachment, and after all, it is not perfect. 5% of the eyes will still go for severe visual loss. So how can intravitreal injections help in PDR? The role was well established in Protocol S. The questions it answered was, is visual acuity using ranibizumab not worse than PRP at 2 years? Not worse was defined as 5 letters. So it was seen that there was no difference. In fact, ranibizumab group fared better, especially if the eyes had pre-line DME. The other questions it answered were, are these the potential benefits of ranibizumab on vision throughout the follow-up? That was seen with the Aryan curve. The answer was still yes. Are the potential benefits on ranibizumab on peripheral vision? It was yes, because with lasers, the visual field decreased, the peripheral visual field, but with ranibizumab, it did not decrease. So are there potential benefits of ranibizumab on macular edema? Yes, because the incidence of central involving DME with laser were 28%, with ranibizumab, it was 9%. It also decreased the incidence of vitrectomy, because with lasers, it was 15%, with injection, it was 4%. Even the patient-centered outcome, word productivity and driving related outcomes were better. So seeing all the rosy side, there was a shift towards the anti-VEGF after seeing the protocol is. So, but if the things were not rosy after that, what we could see that after 2 years, the visual field with lasers stabilized, but with ranibizumab, it started to decrease. Then you see the number of injections that are required. In 6 months, at least 5 injections are required. In the next 6 months, 2 to 4 injections are required. Overall, in 2 years, 10 to 14 injections. And at the end of 5 years, at least 19 injections are required. So this leads to a lot of cost, and there was a lot of difference in the cost, especially if the eye did not have DME. So now the problem came with the compliance, because the duration and the number of injections are unknown. The patients are lost to follow-up. They may become systemically unstable. They may become monetary problems or the lack of caretaker. Even in protocol S, 39% of the patients were lost to follow-up at 5 years. In the study done by Obaid et al., 20 to 30% of the patients were lost to follow-up with either treatment modality. But what we see, the patients that had received PRP came with less incidence of TRD, NVI and NVG. But if the patients were treated with anti-VEGF, a lot of patients came back with TRD, with NVI and NVG. And as a result, the final BCVA was much less than PRP. Then obviously, there's the risk of endophthalmitis. Even though it is less than 0.05, but if you go for 100 injections, the incidence will come for 5%. So the billion-dollar question, anti-VEGF injection or PRP? So we should always consider the cost, compliance and practicality while choosing the best treatment. So PRP still remains an essential therapy in patients with PDR because of the low cost, less intensive follow-up, less frequent or less severe runaway disease in the patients becoming lost to follow-up, and it is not contraindicated in patients who had a recent cerebrovascular accident or MI. Combination therapy is definitely better because it leads to better reduction of the NVE, better visual acuity, and also it reduces the incidence of vitreous hemorrhage. So conclusion, discuss with the patients the financial aspects and the need for irregular follow-up, and if possible, combination therapy is better. So little word about the role of lasers in DME. The classical role was established by the ETDRS study, which answered, does focal laser prevent moderate visual loss, which was defined as doubling of the initial visual angle or decrease of more than 3 lines. The answer was yes, it decreased from 21% to 11.2% at 3 years. However, the role of lasers has been overshadowed by the anti-VEGF injection. But what we have new in lasers is a sub-threshold micropulse laser. The laser is delivered in short or micropulses. There is an on phase in which energy is delivered, and during the off phase, the tissue is allowed to cool down. Like this is the conventional laser. When the laser is delivered continuously, it leads to high rise in temperature, collateral damage, and leading to a scar formation. Whereas if this is a micropulse laser with short pulses are delivered, temperature goes up, cools down, goes up, cools down. So this does not lead to the collateral damage, and there is no scar formation. Although it can lead to the stimulation of the RP. So there is high quality of evidence in the efficacy of micropulse laser that it is much better than conventional laser. Although it cannot be used as a single therapy, but when used with anti-VEGF injections, it can reduce the load of the anti-VEGF injections. Thank you. Yes, sir. Yes, sir. Yes, sir.
The recent lasers like for pan-retinal coagulation,
yes, sir.
Like 532.
Yes, sir.
So, I mean, are they not micropulse?
So micropulse, what I have used is 577, the yellow dye laser. In 532, I have not seen micropulse.
Sure.
Yes, I have not seen, sir. Okay. They may be available, but I have not seen. I have seen only in Iridex yellow laser.
Okay.
Yes, sir.
Need your comment on this.
Right, thank you.
Thank you. Thank you.
Dr. Piyush, excellent talk.
Yes.
I think the need of the hour is to actually do PRP in a combination. Yes. A lot of residents feel that we don't need to do lasers, but lasers is still the backbone of PRP. Excellent talk.
Thanks.
Good morning, everybody. I have a sore throat, so just bear with me. I'll be talking about the role of immunosuppression in uveitis. So we all know that T and B cells are involved. The macrophage release the chemicals, and we have TGF interleukins released, and you have uveitis. Now that we have the new drugs which are affecting the intracellular one, which is called the JAK inhibitors. I won't go into the detail, but one thing I want to say is that uveitis is treated by everybody. And but we accept these complications: maculopathy, hypotony, glaucoma, optic neuropathy, neovascularization. So we have to learn not to accept these complications and try to avoid as much. So you have to learn from the rheumatologist that the mission is remission, not just control. And we learn from the rheumatologist where the drugs have been released. So before 1998, you had only methotrexate and azathioprine. The other drugs have come in after 2000. So the ophthalmologists take 10 to 20 years to accept the drugs which the rheumatologists use. The first guideline came in 2000, and so our goal has to be control and remission. So you have to limit the side effects and prevent vision loss. So you have to create a balance. But unfortunately, steroids create the same problem what uveitis does. So it's important that you limit the use of steroids, systemic, topical, and local. So you have, besides corticosteroid, you have the conventional DMARDs or disease-modifying drugs, or the biologics, the newer one. I won't go into how you should use systemic steroid, but the aim is that avoid complication and try to stop steroid within 3 months of treatment. The guideline for use of non-corticosteroid has come in 2006 called the FOCUS initiative. It tells us when to start, when to modify the drug, which drug to select. So all patients who have acute sight-threatening disease, chronic inflammation, exit detachment, posterior macular disease, binocular disease will require long-term immunosuppression. So at the beginning, you should think of that these patients will not just be cured by steroids. And any patient who has less than 20/100 or has a vitreous haze, has a relapse of CME. So CME by itself is not an emergency, because CME does not lead to vision loss immediately, lead to atrophy of the retina over months. So if you see a patient with CME like intermediate uveitis, you don't have to be aggressive enough at giving intravenous methylprednisolone for macular edema, but yes, you will give intravenous methylprednisolone for disc edema when you have vision loss. In children, you have a separate set of any patient who has chronic features should be on the inhibitors. So we have the T cell inhibitors, cyclosporin, etc., antimetabolites, methotrexate, azathioprine, and mycophenolate, and we rarely use alkylating agents. So one should learn the use of methotrexate, azathioprine, and MMF. Methotrexate is the cheapest drug, given once a week. Then you have azathioprine, which causes low platelets in TLC, and MMF, which is the costliest of all three of them. So when we start a drug, we tend to start late, and you see when you stopping steroids and you're starting the DMARD, there is a small phase when the disease will go. So I tell all my patients, the moment I'm going to shift, I'm shifting to a weaker drug, so you will have activity at 3 months. So initially, a lot of people thought that these drugs cause malignancy. Then the side trial showed that there is no specific risk to malignancy in such patients. And you found that the 3 drugs control about 60 to 70% of the disease. So in 30% of patients, you will require additional steroid, which is less than 10 milligram, for long-term disease control. And they each has a different spectrum of action, but you have to see the cost, the patient, and the disease itself. So there have been the MUST trial and the SIDE trial. So some people feel that the intravitreal steroids give a safer result, but unfortunately uveitis lasts for years. So we only have those steroids which last 3 months, of the Ozurdex. And it's been found that over a long period of time, the disease treatment with systemic treatment gives a better treatment than local injections. Certain diseases which require more than 3 months, you can have a list where you should think on day 1 of starting immunosuppression with steroids. Which drug will depend on the side effects, the risk to malignancy, the fertility issues, pregnancy, the route of administration, the cost, and the efficacy. Azathioprine is started with low dose, and we go up till 2 to 3 milligram per kg body weight. Lower dose in renal failure. The main thing is the bone marrow suppression. Some people use this test TPMT to get an idea whether the risk of idiosyncratic reaction is there. Methotrexate is the safest and used mostly. Start with the low dose, can go up to 25 milligram. Beyond 15 milligram, you will require subcutaneous doses because the absorption is problem. The biggest problem is nausea and GI disturbance. People rarely feel nausea for one day, the day they take the medicine. And then bone marrow suppression is another side effect. MMF causes leukopenia and diarrhea. It is the costliest, but all three are as effective. Cyclosporin is less used nowadays because and the side effects are more. Cyclophosphamide is not used really. So I'll just show you an example. This patient who came to me with somebody had central retinal artery occlusion, had vasculitis, and over 2 years had a full resolution of the inflammation with methotrexate. Here's another child presented with vitritis, retinitis, was diagnosed as Behçet's disease. Initially was used with conventional DMARDs, but when biologics were available, we started the patient on biologics, and the child responded. So see the difference when you don't get a response to conventional drugs, biologics help you, like adalimumab. So when do I start biologics? When the conventional immunosuppression fails me. Or you can use it in very severe patients like JIA or Behçet's as a primary mode. It's a group of drugs which are active proteins. They are monoclonal antibody directed against a specific cytokine inflammatory cell. So basically, whether it's targeted, made from human, mixed or mouse, you will have different names. I won't go to detail what is it. The ones which we have used, one is the TNF, which we have adalimumab, infliximab and golimumab available in India. Among the B cell ones, we have rituximab, which we use for scleritis. For vasculitis, you can use the interleukin 6 tocilizumab, and now we have the JAK inhibitors, baricitinib and tofacitinib. So these are, I won't go into details of biologics, but I'll just show that the adalimumab is a humanized version which is available as a subcutaneous dose, while infliximab is available as an intravenous dose. The visual trial, the Sycamore trial have shown the efficacy of these drugs, but still there are 5% of patients who may not get fully respond to the uveitis. Rituximab is used more for scleritis and for orbital inflammatory disease. Here's a patient who had scleritis with no lung or renal involvement but had sinus involvement, GPA, and with methotrexate and rituximab the scleritis resolved. Tocilizumab is used for arthritis but is now being used for vasculitis. Of all the biologicals, adalimumab is the currently approved drug. So before you start this drug, consult a physician, do these standard tests to rule out any underlying disease and avoid TNF in demyelinating diseases. Rule out malignancy, rule out latent infections, and do family planning. Methotrexate and MMF are contraindicated. Azathioprine is relatively safe in pregnancy, but there are no trials to show the efficacy. And you need to do regular blood work and do a regular follow-up. So an inactive disease is one which you have a full remission and there are minimal cells and there is a step down in the activity. To show this child with 5-year child with CME and disc edema, and you see how the child responds to steroid, methotrexate and adalimumab. This is a patient with VKH. You see how the sunset syndrome came in. We should have given adalimumab early. So sunset sign is a sign of a delayed initiation of treatment. Here's a patient whom you think is normal on the angiograph, but the left eye shows activity on the ICG. So ICG may still be active. So the time to success, azathioprine, methotrexate, MMF take 3 to 6 months to act, while biological takes about 3 months to act. But remember, nothing like steroids, which are the most effective drug. And always plan at least 2 years of relapse-free disease before you start tapering. So it's a combination of ophthalmology and rheumatology. When you use these drugs, you learn from them. And remember that non-compliance may be one of the issues where the patient is not responding or has a mascade or has some infection. So you escalate the dose or switch to another drug if you have poor results. So you have to aim for no vision loss and 6/6, then you will be able to help majority of the patient. Thank you so much.
Thank you, sir. An excellent talk. Just a very basic question. Though we have all the guidelines in place, but still we are not very comfortable when we start with the immunosuppressants. We usually refer our patient to the immunologist to take care of that part. So what is your recommendation?
So the thing is that you start working with them. when I was a resident, there were no rheumatologists to teamwork. Now you have teamwork, and you learn from them. Over the years, you will learn, and the residents will be able to use. It's a transition. Like our generation had difficulty with laptops, the present generation is much more easier. So next generation is going to use it much equally easily.
Thank you, sir. So now we invite our.
I mean, you said that these immunosuppressives should be used for a long time. What is the end point? When should you start?
So when you have a remission, that is less than 0.5 cells, and all your parameters on FA, ICG, OCT do not show any activity for 2 years, then you start to taper every 3 months. The Sycamore trial, which was in JI, they did an abrupt closure of the drug, and you had 50% having recurrence. So those patients which you start early, where you don't have a long-term breakdown of the blood aqueous and retinal barrier, will resolve. Those you start late will require lifelong medication. So it's like diabetes. If the vision is less than 612, you have poor response. It's better than 612. So you have to start treatment early, wait for 2 years of remission, then start to taper. Some patients, my patient required 10 years of treatment, 20 years of treatment, because don't think they will go into remission. Second, the biologics don't cause remission. They just control. So you may require biologics initially 2 weekly, then 3 weekly. So some of them are 42 days gap, but they are on that treatment for 10 years with 6/6 vision. So it's a lifelong treatment. Do not give up and avoid getting cataract or glaucoma. Your target should be, my patient after 10 years of uveitis has no cataract, no glaucoma, you have won the war.
But Dr. Amit, it all depends on the etiology also. Like Harada disease, you need longer treatment, or some other disease.
So you become more aggressive in the, as I said, Behçet's and JI and VKH. But as a standard, 2 to 5 years, minimum 2 years of disease-free before you start to taper.
So 2 years have to be continued even if the patient is having controlled disease.
Yeah, absolutely. Because you are wanting the memory cell to disappear. If you stop it, the memory cell will become active again.
All right, thank you.
Okay.
So we now invite our keynote speaker, Dr. J.S. Bhalla, for his talk on intracameral antibiotics.
It's not coming here. Yeah. At the outset, I'm thankful to Uttarakhand Ophthalmic Society for giving me this opportunity. The topic I'm going to cover is it a fact or fad to give intraocular antibiotics? We all know that prevention is better than cure. And incidence of endophthalmitis after cataract surgery, which used to be just 0.08% in the 90s, suddenly rose in the years between 2000 to 2003 to 0.265%. And this was due to change in shift to the clear corneal incision technique and aging population. What is the reason? What is the mechanism for intraocular bacterial contamination? One is entry of multiple instruments during the surgery, and second is unsutured clear corneal incision may permit retrograde efflux of external surface fluid from the conjunctival fornices after the surgery, if the watertight incision is not there. And it has been reported in this landmark study published by Dr. Vasavada et al. In JCRS that there is, even in uncomplicated cataract surgery, there is a report of aqueous humor contamination to the tune of 5 to 43%, and this was done in an experiment where they had trypan blue stained fluid detected in the anterior chamber up to 4 hours after the cataract surgery. And what are the problem factors? Non-use of povidone iodine, use of lidocaine jelly, increased intraoperative time, and influence of hydrophilic rather than hydrophobic haptics. We all undertake these procedures. Some of us use topical antibiotics 1 to 3 days pre-operatively. Some use every 15 to 30 minutes for 2 hours before the surgery. Some use subconjunctival antibiotics. 5% povidone iodine preparation is universal, but intracameral antibiotics are slowly gaining popularity in Europe and all over the country. If we use only povidone iodine, it reduces the conjunctival flora by 91% for colony forming units. And if we use in combination with intracameral antibiotics, it causes much more. There is synergistic effect. So for ocular surface decontamination, povidone iodine is required, but to deliver ocular protection after the surgery, their povidone iodine effect is not going to last for 4 hours after the surgery. We need antibiotics with favorable pharmacodynamic properties. So perioperative antibiotics have become a mainstay of post-operative endophthalmitic prophylaxis. So it is the route of antibiotic delivery which might be critical in determining the efficacy. So I'll tell you pharmacodynamically, if you use preoperative antibiotics, they are not effective in reducing contamination of the anterior chamber. Post-operative antibiotic drops, of course, they will decrease the surface bacterial load until the incision is healed. Subconjunctival antibiotic injections, abundant. Systemic antibiotic prophylaxis, reserved for only high-risk cases. Antibiotic supplementation of the infusion fluid, it fails to decrease the contamination of the anterior chamber. So intracameral injection of the broad-spectrum antibiotic at the end of surgery has now become a popular practice to prevent endophthalmitis. See, if you use topical antibiotics few days before surgery, what is the aqueous humor concentration you achieve? 2 microgram per ml. Started on the day of surgery, again 1.8 microgram per ml. If you combine pre-operative along with 2 hours before the surgery, again you are able to achieve just 2 microgram per ml of the aqueous humor concentration of the antibiotic. But if you give intracameral injection, you achieve concentration of close to 1000 microgram per ml. Why this figure of 1000 microgram per ml is important, I'll come stress in the subsequent slides. And there is also evidence by retrospective trials. Because of the difficulty in performing large RCTs, a large sample size is required to establish the efficacy of intraoperative intracameral antibiotic prophylaxis so we have taken evidence from large retrospective trials. This was the first large study done on about 16,000 patients by late Peter Barry. It is known as ESARS multi-center trial, and they found that use of intracameral cefuroxime decreased the risk for endophthalmitis by a factor of 4.92 with 95% confidential intervals. The ESCRS study had 5 eyes blinded from streptococcal infection, and there was another landmark study published in 2012 in JCRS by Shoston et al., which had 3 eyes blinded from the streptococcus species, and none of these 5 plus 3 eyes had received intracameral injections, but all these eyes had received pre-operative and post-operative antibiotic drops. Then there was a Spanish group, Singapore study, Swedish study, all significantly established the efficacy of intracameral antibiotics, although the antibiotics used were different in the different studies. We find the ESCRS survey results of 2012, they found that in 2012, 74% were always or usually using intracameral antibiotics and 26% were occasionally. But now this figure in the recent surveys have increased. So there is change in practice pattern in the Europe and US. Since publication of the ESCRS studies, there was ASCRS 2014 online survey found that the increased adoption of intracameral antibiotic prophylaxis compared with the similar survey in 2007, that was 47% compared to 30%. So there in 2011, there was AAO cataract preferred practice pattern guidelines, 2011 ASCRS cataract clinical committee white paper, 2013 ESCRS guidelines, and 2020 Australia came out with surgical antibiotic advisory group on antimicrobial resistance, and all of them are now making use of intracameral antibiotics as a standard practice during the surgery. Once we have established that antibiotics are required, now we have to answer the second question, which antibiotic for intracameral use, because there is neither strong evidence nor consensus as to which medication is superior. These are the various intracameral antibiotics which are being used. There is cefuroxime, there is moxifloxacin, there is vancomycin, and of the moxifloxacin also, which has become more popular, we have various brands which are available. I'll go into the details. This was one drug which, when I compared the various antibiotics, previously we were using some branded antibiotics, but lately I shifted to various other antibiotics, and then I came across this paper where they have stressed on an entity which is known as DMF, that is Drug Master File, which is a very confidential document submitted to FDA, which covers 3 things. One is active pharmaceutical ingredient and finished product dosage form. And what they found was that we have to take into account all these 7 factors, the purity, impurity, materials used to prepare the drugs, excipient, and so it has been published that all drugs may not be same. Some antibiotics may have different bioavailability because of the various factors. We know from endophthalmitis causing organism that according to EVS study, 94% of the culture positive endophthalmitis was caused by gram-positive bacteria, of which 70% were Staph epidermidis. And if we compare the antibacterial activity of various antibiotics like cefuroxime, moxifloxacin, and vancomycin, we find that cefuroxime is not effective against MRSA, and moxifloxacin is effective against both gram-positive, gram-negative, and even atypical mycobacteria. Vancomycin is used only for highly resistant and in life-threatening condition. So cephalosporins, the 3rd and 4th generation, this is bactericidal activity, is concentration dependent, but there are problems with intracameral cefuroxime in the form of the fact that there were no standard preparations which lead to kitchen sink pharmacy approach, leading to dilution errors and TAS. And there was complete lack of activity against enterococci and pseudomonas, and increasing resistance was there. Vancomycin is its choice for serious gram-positive cocci infection when there is resistance to multiple drugs, and it is also very effective drug. But there are 24 cases of adverse effect of intracameral vancomycin which has been reported, and it is a blinding condition in the form of hemorrhagic occlusive retinal vasculitis. And it is also known that since we use this drug for the intravitreal drug as a treatment for endophthalmitis, prophylactic use should be discouraged because it will lead to bacterial resistance, and then will not be left with any antibiotics in our armamentarium. Moxifloxacin has increased efficacy against almost all gram-negative and gram-positive bacteria. Then there is another entity called MIC and MPC. MIC is the concentration of the drug which decreases the bacterial growth by about 50 to 90%, and mutant preventive concentration is the concentration which is 10 times MIC, and it prevents the development of the resistance in these bacteria. So that question is also answered if we give MPC of the drug, that is mutant preventive concentration. Now I'll come back to the entity why we needed 1000 microgram per ml of the intracameral concentration, because MIC of moxifloxacin is 3 microgram per ml, and so MPC becomes 3 into 10, 30 microgram per ml. But we are having 900 microgram per ml of the drug after injecting 0.1 cc of moxifloxacin. Why? Because we want this drug exceeding MPC concentration to stay in the anterior chamber for about 4 hours after the surgery. So this is what happens, that moxifloxacin levels in the aqueous exceeding MICs for relevant species will persist for 5 hours after the surgery if you give 0.1 cc of 0.5% moxifloxacin. So these are the various methods. There is Cesar Espiritu from Philippines who injects 0.1 ml after the surgery after hydrating the clear corneal incisions, and so this is small volume high concentration of the antibiotic is used. There are other methods also by Steve Ashenoff from Canada who uses the diluted, that is the 3 cc, the 30% concentration of the moxifloxacin along with 70% of the BSS is used. Then there is Matsura of Japan who uses different methods. And what are the advantages of moxifloxacin? Easy to prepare, isoosmolar, isotonic, no corneal endothelial toxicity, and it has the lowest MIC for most bacterial endophthalmitis, no TAS, no hemorrhagic occlusive retinal vasculitis, higher potency, and the most important practical thing is, even if infection occurs after giving intracameral moxifloxacin, it will be due to moxi-resistant Staph aureus, which is sensitive to standard endophthalmitis protocol of vancomycin plus ceftazidime. Whereas if infection occurs after intracameral cefuroxime, it is due to Enterobacter, to which we have no answer. There are newer innovations with intracameral moxifloxacin, like in the form of pre-soaked hydrophilic acrylic IOLs, and there is hydration of incisions with diluted moxifloxacin, which is practiced by Steve Ashenoff. So although EVS study indicates that endophthalmitis can be treated and cured, but the best treatment is not treatment, it is prophylaxis. And once we know that cataract surgery is the maximum performed surgery globally to the tune of 20 million, we need to maximize the preventive aspect and safety from the point of view of patients. And so prevention of endophthalmitis with intracameral antibiotics is the most cost effective than treatment. These are the various indications. Then there are Indian studies which have established the efficacy of intracameral moxifloxacin by Haripriya Arvind in JCRS and in ophthalmology, where the study was done first on 3 lakh patients, then on 2 million patients, which is the largest study till date, and they found that the incidence of endophthalmitis really comes down significantly by a factor of 7. So in North America, Europe and Australia, why they are insisting on cefuroxime is because gram-positive organisms are the most common pathogens in those countries, so they are still stuck with cefuroxime. Whereas in India and China, gram-negative bacteria causes more causes of endophthalmitis, so moxifloxacin may be preferred over cefuroxime and vancomycin. So use of safe and effective intracameral antibiotics should permit us to stay one step ahead of the bacteria that threaten our patient's vision. So new ideas can take forever before being accepted. No problem can withstand the assault of sustained thinking, but time has come to shed your inhibition and start the use of intracameral moxifloxacin, which is backed by peer-reviewed published literature. So if you do not want to see red on seeing yellow inside the eye, please start giving intracameral antibiotics. Thank you, everyone. And I take this opportunity to invite all of you to the annual DOS conference, which we are organizing from 10th, 11th, 12th February in New Delhi. Thank you, everyone.
Dr. Bhalla, sir, are you using intracameral moxifloxacin in every case?
In every case since almost now 10 years, sir.
Since 10 years?
Yes.
Do you have seen any incidence of toss?
No, I have not seen.
And what is you are using in decompensated cornea also? The cases which have corneal opacity or decompensated cornea.
See,
do you think moxifloxacin you should use?
The studies which have been published indicate that there is no endothelial toxicity. They have done specular microscopy and they found that there was only the endothelial the decrease in the endothelial count is the normal one which is expected after the phacoemulsification surgery in uneventful surgeries. So I don't think there is any reason not to use preventive antibiotics in patients who have corneal opacity. I'm not saying of decompensated corneas. Decompensated corneas, maybe you won't be doing just phacoemulsification, you may be doing combined procedure. There I think
like
the
phacomorphic glaucoma, like phacolytic glaucoma.
Definitely in all my patients. I use in all my patients. Yes, sir.
Okay, thank you.
What is your formulation of choice that you're using, the unims you're using or the preservatives free?
Moxifloxacin is self-preserved. So all these, initially people started using Vigamox, then came pre-filled syringe preparations also. But lately, no financial interest involved. I have been using this thing, Mahaflox. And what I found is that I have not encountered any. And most of these preparations, whatever brands you are comfortable with, you can use, and there is hardly any incident. Only thing is, you have to use 0.1 ml. Don't exceed. You have to use 0.1 ml. So there you have to just take in the tuberculin syringe and then inject. Don't try to use more than that. Then there are chances.
Thank you.
At which step you are using it?
After finishing the phaco surgery, after hydrating the clear corneal wound, just go through the side port and inject either in the pupillary area, and the best thing is, they say, behind the rexis, if you inject, that is much better. But even if you inject in the anterior chamber, I have told you by pharmacodynamics, the concentration achieved is 952 microgram per ml, which is more than mutant preventive concentration of the drug, and it persists in the anterior chamber for about 5 hours after the surgery. And this 4 to 5 hours is the crucial period when your corneal incision almost seals. After that, there is very little chance of percolation of the fluid from the conjunctival fornix into the anterior chamber, even if your incision is not proper.
Thank you.
Dr. Bhalla, it's an excellent talk. And just one thing, what's your opinion, moxifloxacin is the only drug now left for us for all intraocular surgeries. So to avoid the resistance, do you feel like we all ophthalmologists should avoid using moxifloxacin for just conjunctivitis and other things?
That's a very good question, sir. I mostly this make a earnest appeal. We should preserve moxifloxacin for this use, the intracameral use. Other drugs can be used for conjunctivitis. Please don't use left and right. Particularly, there was epidemic of conjunctivitis just 4-5 months back, and everybody was using moxifloxacin. Use other antibiotics which have better surface. This has good intraocular penetration. We need surface antibiotics, and surface antibiotics can be this thing, tobramycin, even gatifloxacin. Please use those antibiotics which have good surface activity. We don't, in conjunctivitis, we do not require drugs which have good intraocular penetration. So we should preserve this very useful drug for our prophylaxis and intracameral use, sir.
Dr. Bhalla, excellent presentation as keynote address, because this is although going on debate still on, people have started using moxifloxacin as intracameral. And 2-3 years back also in AIOS there was a lot of debate, and that multi-centric study had come. We at RIU Rohtak, we were not using any systemic antibiotic, and we were not using any intracameral antibiotic as well. And I think around 50 to 70 patients are being operated every day. Even now we are not using intracameral antibiotic in more than 5 to 10% of the cases. Some of the surgeons are using. But of course there was a lot of debate and discussion, and in the literature we could see that people are always in favor of intracameral antibiotic, that is, and some people were using Vigamox eye drops or other eye drops. Some people have started using pre-filled syringes, and then you, as you have rightly said, that actually it should be in the bag or underneath. That should be the proper area. But 99.9% of the time the infection is introduced at the time of surgery, and that causes endophthalmitis. If we had been using topical povidone iodine, and it was equally good. But as of now, because all the literature says that we must use moxifloxacin intracamerally, and all people who are in the field, very well known figures like you, or everybody is commenting, and still I am sure that 50% of the surgeons are still not using intracameral moxifloxacin. Another thing is that you have really given a lot of discussion about which drug is to be used, and moxifloxacin came out on the top. And as Dr. Sanjeev Mittal rightly said, that it can cause sometime later that issue of resistance. So in the end, I would also start using now intracameral, thinking that even if it is 1 in 20,000 cases, that is equally important to prevent. I hope that it is not toxic to the endothelium and cornea.
It is not, sir. The studies which I have published, this is not my just an empirical statement. These are the published studies which I have quoted. And secondly, what they recommend is if you encounter more than one in your 10,000 cases, more than one case of endophthalmitis in your 10,000 cases, you definitely have to use. And second thing is what you said is regarding the development of resistance. That's why I briefly touched upon the concept of mutant preventive concentration, not drug concentration exceeding MIC. If you give, this is a microbiological concept, if you give drug exceeding mutant preventive concentration, then you are killing all the vulnerable bacteria. Not even a single bacteria is left which can multiply and then develop resistance.
So I think we are running late, so sorry to interrupt. Yeah. So we'll be just carrying on with the last talk of this session by Dr. Neeraj. We can have this discussion, I think, during lunchtime, sir. It's just going.
Thank you, ma'am. Thank you, Uttarakhand Society, for giving me this opportunity. I'll be discussing on dislocated intraocular lenses, tips and tricks for repositioning, removal and exchange. Dislocated intraocular lenses could be early or late complication of cataract surgery. Even it can happen in a prior vitreal surgery case where the zonular laxity is there, or it could be because of trauma, high myopia, or could be some connective tissue disorder where the zonular laxity is there. Indications for surgery in dislocated IOL is when there is decreased visual acuity or the patient is having monocular diplopia, associated retinal detachment, and even in patient having fluctuating vision because of the shifting IOL. Options what we have, when the capsular support is adequate, you can comfortably position the IOL in the ciliary sulcus. If capsular support is inadequate, then we have three options: putting the lens into anterior chamber, or do scleral fixation IOL, or iris fixation IOL. We had this 20 case in our series with decentered and posteriorly dislocated PC IOLs. Intervention was done in form of repositioning into the ciliary sulcus, where adequate posterior capsular support was available, and rest 16 cases we had the sutureless, glued or without glued fixation of IOL, and more than 85% of the patient achieved 20/40 vision. So I'll be showing just two videos how we manage our cases. So this was a posterior dislocated IOL case who had undergone earlier cataract surgery and had spontaneous subluxation of intraocular lens into vitreous cavity. We are making scleral flaps which are 180-degree apart, just diagonally opposite. It has to be, otherwise if you place the lens, if they are not diagonally opposite, then you can land up into subluxated IOL also. So we are making a scleral groove on the both sides with 26 gauge needle. After making the scleral flaps, you have to be very gentle and it should go just diagonally opposite. Now we are putting a trocar cannula for infusion and making, now we are making a 20 gauge entry on the both sides where we need to take 1.5 millimeter from the limbus, and now corneal section. You can see the IOL was placed over the disc. We brought this IOL into the anterior chamber. It was already a vitrectomized eye actually. So after placing here, infusion cannula is on, we are putting viscoelastic and gently enlarging the section and taking out this intraocular lensing without touching the cornea. Once this is out, then we have to put a 3-piece IOL, and we use Eyecon multi-piece 3-piece, and with 23 gauge forceps, we are just hand-holding this technique of taking out this haptic. And now the trailing haptic is also gently taken out, and the first haptic is held by the assistant, and you have to be very gentle in handling of this haptics, otherwise they may break also. And once it is out, then you can leave both the haptics because it will not go inside. And then you have to place this haptics into the, tuck this haptic into the scleral grooves which you made earlier. So everything is pre-planned, like what you are going to do next. Now closing the section, and you can see the eye is quiet, and we are putting glue. And even if you don't have glue, you can just put one vicryl suture over there to place the scleral flaps in place. So this is how this works. And this is another interesting case where the patient has a decentered IOL, was having diplopia, uniocular diplopia. We are making scleral flaps as we made earlier also, 180-degree apart. And this was a 3-piece IOL. So luckily, as this was a 3-piece IOL, so we thought we're just going to place this IOL, use this IOL, we don't take it out. So after putting the infusion cannula, making side opening, and you can see a lot of cortical matter is there, and we need to free the IOL haptics from the cortical matter, and only then we can place this haptics into the scleral grooves. So once the IOL was down over the retina, then we are just trimming. We need to be very careful not to damage the haptics, otherwise you can cut it with your vitrectomy cutter also. So very gently you need to do these steps, keeping the port of the cutter not towards the haptic. And you can see a lot of cortical matter is there, which was there in the capsular bag. And once this thing is out, you can see the haptics are free. Now we are gently holding the haptic with the 23 gauge forceps and bringing it out. Now my assistant is going to hold it, and other side we are just taking it out with another 23 gauge forceps, gently taking it out. You can see this is beautifully it has come out. Now tucking the haptics and just putting it. So with least of the intervention we could plan it. So the glued fixation IOLs, whether with glue or without glue, you prevent the suture-related complication like suture erosion, suture knot exposure, or dislocation of IOL after suture disintegration or broken suture. And this is quite a rapid surgery. It takes around 30-40 minutes total, and it gives a more stable fixation than any retro-fixated IOL or any other option. Thank you very much.
Thank you, Dr. Neeraj, for a wonderful talk. And I think in the interest of time, we'll just, we can have the discussion during lunch, and we'll just hand over the session to the next chairpersons and panelists. Thank you. And can we all the presenters just join in for a photograph?
So, hello. Hello. Yeah. Without wasting much time, because we are already running 20 minutes late, we are starting this retina session. Good morning, everyone who is attending the session and all the guest speakers here. I'll request my co-chairmen, Dr. Sanjay Mishra, Dr. Neeraj Santuja, Dr. Manisha Agrawal to please come forward, and panelist Dr. Rahul Mayer and Dr. Charu Mittal. Is Dr. Charu Mittal here? No. And our moderator, Dr. Anuj Sharma. So, I must congratulate the organizing committee for designing this very nice session on various aspects of retina, ranging from diagnostics to clinical conditions. Is Dr. Bhawankule here? So can we start with Dr. Sandeep? I think Dr. Bhawankule is here. We can start with the...
Is come.
So I'm thrilled to introduce our keynote speaker, Dr. Prashant Bhawankule. He is chair. Okay. I think Dr. Sanjeev. Dr. Sangeet Mittal will be speaking on oral fundus fluorescein angiography. Is it safer and equally useful?
So good morning, everyone. I'll be speaking on minimally invasive oral FFA. First of all, I'd like to thank Dr. Saurabh and UKSOS for giving me this opportunity to be present amongst you. So oral fluorescein angiography is actually not a new thing. It was first used in 1979 by Kelly and Kincaid, but the picture quality on analog fundus cameras was not good. It was tried on digital cameras, then on SLO, and the quality of the images improved with CSLO. We are doing oral angiography using the broadline imaging with ultra wide field camera. And this study particularly was 445 eyes of 236 patients who underwent oral fluorescein angiography. The dye was given in the dose of 25 milligrams per kilogram body weight. That is 1 ampule for every 25 kilograms. The dye was dissolved in 30 ml of sugar-free juice, which was ingested by the patient, and then it was followed by another 30 ml of juice without the dye. So angiograms were taken at regular intervals every minute for first 5 minutes, followed by every 2 minutes for 5 to 10 minutes, followed by every 5 minutes up to 30 minutes. And good quality images were, good to average quality images were, we got in almost 99% of the eyes. And the earliest images that we obtained was at 1 minute 30 seconds. And the latest was at 26 minutes 25 seconds. The mean that came was around 8 minutes 45 seconds. So it's good, like if in an adult patient you give the dye and start your angiography at around 6-7 minutes so that you get good pictures. The main advantage of oral angiography was the reduction in the complication rate. The nausea and vomiting only in less than 1% of the patients was seen, whereas in IV FFA around 6% of patients had nausea and vomiting. Mild rash was seen in three patients, and the allergy was almost similar in both the groups. But the main difference was that in oral angiography, the allergy did not occur immediately as we see in IV FFA. It occurred a little late. The vasovagal syncope sometimes, which happens with IV FFA, was not seen in oral FFA because no injection was used. So the other advantages were that OFA is safer, less invasive and comfortable. So it's faster preparation and can be performed by technician only. It can be easily repeated at follow-ups because patients are ready to undergo oral angiography again and again rather than an IV injection again and again. And for pediatric patients, it was very useful as children, they are very uncomfortable getting an IV done. It's contraindicated to the patients who are contraindicated to IV injections. And in this case, you can perform multiple procedures simultaneously because there's a huge gap in which you have to take photographs. With the IV FFA, it's a standard procedure, and you get an arterial and choroidal phase. If you want, you will get it better on IV FFA only, and it takes lesser time rather than half an hour. So some examples, some case examples in pediatric, because it's easier than FFA, it's well tolerated, and children usually resist IV injections. So this was a patient of Coats disease, and you can see the ischemic areas, the leaking vessels and the macular edema quite nicely with the oral angiography as well. This was another patient with FEVR, and similar, you can see almost the similar findings you get with the oral angiography. This is the patient of BRAO, just to highlight that though you cannot get the arterial or choroidal phase on an arterial occlusions, but still some features like box carrying and all the other features can be made out on oral angiography also. So comparing it to the OCT angiography, again oral OCT, though it's non-invasive, oral FFA is also minimally invasive only, and it's a dynamic procedure rather than a static procedure. It can pick up microaneurysms. Subtle lesions are picked easily. To extent of disease, again you get very easily. It can be used as in a wide field camera, and it's easier in patients with poor fixation, whereas OCT-A again is very difficult to do in patients with poor fixation, and it's again an additional expense to get a OCT angiography machine. So you can see this is a patient of central serous choroidenopathy, and you can easily make out the leaking hotspot or leaking smokestack appearance of the dye. And this is the patient with an ink blot leakage. Again, with the oral angiography only you can make this out. So in patients of uveitis also, where you need a dynamic study of the angiogram, you can see that there's an early hyperfluorescence followed by the late hyperfluorescence. Again, you can get it easily on the oral angiography. So this was patient of AP-MPP post-COVID vaccination, and again on OCT angiography, though you can make out some ischemic areas in the choriocapillaries region, but oral angiography again will give you the early hyperfluorescence followed by the late hyperfluorescence. And in exudative AMD, though again I will say that OCTA is a standard, is a good tool for having in exudative AMD, but again you can make out that enlarging dot sign again with the early hyperfluorescence again in the oral angiography also. So for retinal macroaneurysms, again you can see the macroaneurysms. For very subtle lesions, you see in this fundus picture you are not able to make there is any NVE, but you do an oral FFA, there are so many NVEs present that you would have mixed. And this is for subtle NVD, and you get a true extent of the disease. You can see the areas of capillary non-perfusion, which just on looking at the fundus picture, you won't be able to get this. And because in OCTA you don't have such wide field pictures now, you may miss out on this features. So again in CRVO and BRVO you can easily take out multiple areas of non-perfusion. Again in this patient of BRVO you can make out multiple NVEs just by doing this angiography. Again, another advantage that I told you was it's a wide field cameras. You can use oral angiography to pick up peripheral lesions also. So you can do oral angiography not only using the CSLO or using the Zeiss Claris or the higher machines, but this is done on a digital fundus camera, and you can again see you can easily do oral angiography with these. The limitations are that very heavy patients, sometimes you need a lot of dye, so you won't get that good images. Patients who had history of recent meal within 1 hour, again the absorption of dye is poor, and patients with significant cataract, you don't get good images. To conclude, OFA is safe, less invasive, well-tolerated procedure with high sensitivity. Quality images can be obtained in more than 99% patients and can be performed in most indications. And to obtain a comprehensive evaluation in common retinal diseases and to reduce risks and discomforts of the IV FFA, oral FFA may be considered for clinical purposes. Thank you.
Any questions?
Yeah. Yeah, so the earliest images, the mean of all these patients were around 8 minutes 45 seconds. But I have seen it in children especially, it comes very early. I've seen this occurring as early as 1 minute 30 seconds, right? So, yeah, for adults I will advise you can wait up to 5-6 minutes and you can start taking, but for children you have to take early images.
Dr. Sangeet, the pictures are very nice. Is it because of the technology of the fundus camera that the oral angiography pictures have improved, or?
Yeah, as I told you, because the analog cameras won't give you such good images. The digital cameras, I showed you in one picture which was taken with the digital camera also, gives you very good quality images. But definitely as you get higher technology, you do it with CSLO or with broadline imaging, you'll get even better images. But it's not that you can't do it with the earlier cameras.
Just make a comment. See, it's almost 20 years back, we did a small study, this was in San Diego, where we compared oral angiography between doing a Heidelberg system and a normal digital system. And we found that Heidelberg system, oral angiography was better.
Yeah.
Saying that SLO systems actually, for an oral angiography, SLO systems are better than a digital one. And that time, what I remember right was that the imaging started at about 3 minutes, and the earliest in adults we used to get at about 4 to 5 minutes. We used to follow up till about 15 minutes.
Yeah. So that's what, as Dr. Puneet was also discussing, the technology definitely helps. But I think oral angiography, we are not doing much these days, but it is, I think, can be done if you have good cameras, it can be done, and it can be done in most of the indications.
I think the problems related to the bolus of injections like vasovagal and nausea can be minimized with this.
And I have done this in patients who had an earlier, patients who had nausea and vomiting in which IV FFA was done. And again, if you have to do a FFA, you do it oral FFA, and the patient really behaves well with that.
Any pathology, Dr. Sangeet, where you felt that this particular technique did not give you, a good quality image, and where you missed upon the regular kind of an FFA?
Not the images, but like as I told you that for the arterial phases and the choroidal phases, this is not a good. So if you want images of that phase particularly, then you don't advise this. Even for exudative AMD, I will say the angio OCT is a better tool to take out the CNVMs exactly. But this also gives you an idea what is there, how big is the membrane and everything.
Even for CSR leak also.
CSR leak, this is better.
Yeah, sure. Like
this is better.
So it was quite consistent, like getting those leaks.
Yes.
Okay.
Yes. Yeah. Yeah, I think I'd seen this a little delayed. It's not that it takes place another day or something like that. Around 1.5 hours, the patient gets the allergic symptoms. And it's very, generally what I've seen is, now I'm doing it in all cases. This 445 eyes is just data which is old. Now I've seen is like whoever gets within 1.5 hours, and the allergy is not severe as you used to get it with IV FFA sometimes. It's just rash or urticaria or something like that. Mostly, yes, mostly. Late phase, generally after, I've seen that on an average after about 30 minutes or so, the dye starts to disappear, and if you delay it further, you won't get good images. So the 1% in which we did not get good images, the patients actually did not have images like up till 20-30 minutes. Then we stopped the procedure there and then only.
Okay. So we have a, thank you, Dr. Sangeet. So we have a keynote talk in this session, and I am thrilled to introduce our keynote speaker, Dr. Prashant Bavankule. He is the chair of ARC at the All India Ophthalmological Society and is a big name in vitreoretinal surgery. I am personally an admirer of his energy and dedication in the field. Dr. Bavankule is always eager to embrace the latest technology in the field, from diving into heads-up vitreoretinal surgery to using newest diagnostic tools. He is going to talk about the recent development in retinal imaging, that is wide field imaging, and we are fortunate to learn about it from him. Dr. Bavankule, please.
Okay, it's not playing over here. I can't see the screen here. I have to see then. And thank you, Dr. Puneet and Dr. Saurabh, for this wonderful invite and for your kind introduction. He's a dear friend of mine. He adds always few adjectives to make me look more glamorous. Thank you for that. So already Sangeet has spoken about the role of fundus fluorescein angiography. Now I would be adding upon to the newer dimension to it, and that is going to be about the wide field of imaging, call it FFA, ICG, and even OCT now has a wide field imaging. So I think we will directly come to the clinical utility. I will be sharing you some of the clinical pictures. So what is wide field OCT? Usually you get a standard slab of 9 to 12 millimeter. In this you get about 16 to 18 millimeter length of the slab. And this is especially important when you are observing a pathology. Concomitant pathologies are two different situations. Now this is, you have peripheral CSR with a PED, you have a choroidal. These are some of the images which I have taken from the literature, but I will share you one of my case now. She is a mother of a pathologist who presented with this particular picture. This was a case where you could see there was a peripheral PCV with some fluid leak into the, on the OCT into the macular area. And in a single photograph you can see the image as well as the lesion, and it helps you in better monitoring of this particular disease. Now look at the OCT. This is wide field OCT where you can see the disc as well as the peripheral lesion in a single slab. And that is the thing. And so once you have a lesion, you get a complete panoramic total view of the lesion as well as the pathology, and that's why you can monitor it in a better way. Now this is subsequently we treated this patient with intravitreal brolucizumab, and how we could subsequently follow up. You can see the lesion very beautifully subsiding over a period of time with the particular injection. So this is how the wide field OCT helps. Now coming to the wide field angiography, this is where one of the indications, diabetic retinopathy is one of the commonest indication where we use fluorescein angiography. But what happens is, this is particular case I will show you. Now this 67 years male was diagnosed to a macular edema, diabetic macular edema, and advised intravitreal injections. When we did wide field OCT, we thought that the sciatic cavities are extending much beyond the macular area, and so it challenged our whole concept. It was no longer a case of a simple diabetic macular edema in a case of a diabetic. It was a case of a retinoschisis in a case of a diabetic associated with macular edema. So this is how a wide field OCT helped us in looking at a lesion in a different way. So we did an angiogram. I couldn't explain why was the vision failing in this case of a retinoschisis where the vision should drop down gradually. And that's why we did a wide field OCT, and I will directly come and show you the reason for it. This is wide field OCT. You can see a telangiectatic response in the periphery. So this is what is classically described in a literature. In a case of a retinoschisis, you have a telangiectatic response in the periphery leading to superimposed macular edema in a case of a retinoschisis. So in this particular case, we just treated with laser, also with anti-VEGF. So treatment of laser, we could pick it up had we because of a wide field angiogram as well as wide field OCT. Now another case, this is a patient who was diagnosed to have partial retinal detachment, advised vitreous surgery elsewhere. We thought in a peripheral photograph we are seeing something different, fibrous tissue in the periphery. So we thought it differently. We did a wide field angiogram, and this is a case of a FEVR bilaterally with a retinal detachment in the left eye. So because of wide field angiography and better index of suspicion, we could pick up this lesion. We treated first the better eye, which was asymptomatic, with laser, and prevented and averted a disaster which has happened in the left eye. Naturally, the left eye underwent a vitreous surgery along with the Ozurdex and all. So this is how it helped us in picking up a peripheral lesion. This is 52 years female who was hypertensive diabetic, floaters since few days, and this was the picture. Patient was diagnosed to have a epiretinal membrane. But look at the wide field photograph, you will see there is some drag of the macula. I thought I am looking at a drag. So we did a wide field OCT as well as thing, and it was another case of a FEVR. So it was not needing just simple vitrectomy epiretinal membrane peeling, but it also needed a vitreous membrane dissection in the periphery along with a tamponade. Now another 48 years old male who had hypertension and hypercholesterolemia, and this was the picture, diagnosed as Roth spot elsewhere. We did a wide field angiograph, and the shutdown of the vessel was classically ahead of the, means anterior to the equator. And this is how which we cannot pick up on and the other eye you can see. So this was the case how a simple angiogram with a wide field angiography you could change the diagnosis. Another case here is a case of a person who had this sclerosed vessel on a wide field photograph bilaterally. We did and it was diagnosed to have a macular hole and suggested surgery elsewhere. We did a wide field angiogram. You could see a half zone disease. Like half zone disease is a terminology which we use in a case of ROP, but you look at the shutdown in this particular case, it's less than a half zone. When we did a systemic evaluation after looking at this wide field angiogram, this patient had a bilateral carotid disease, and so we were the first people to diagnose it a systemic disease and then refer it significantly to the person. This 26 years old female was Mantoux positive, and this was a case of a healed choroiditis but had a progressive loss of vision which we could not explain on a color photo. So we did an angiogram and we could pick up a peripheral ischemic capillary non-perfusion. So this was a case of having a capillary non-perfusion in a healed choroiditis which needed laser, and following that it responded well to our treatment. Now another 48 years old man who was systemically stable, and you can see the lesion over there, vitreous hemorrhage with in a case of a healed choroiditis. And in this particular case, when you do a wide field angiogram, you can see the ischemia or the capillary non-perfusion is quite anterior to the equator. And therefore, we did a targeted laser only in the peripheral area, sparing the posterior pole, and this is how it contributed and helped us in managing this case. Now this is a girl who was diagnosed to have Eales disease and advised vitreous surgery. Naturally, she had a combined retinal detachment, but when we looked at the fundus of the other eye, we thought we are seeing something different. And you can see the classic pruning of the vessel in the periphery. We did an angiogram for this girl, and this was a case of a Takayasu's disease on further evaluation. So importance of this particular case sharing is that you have to look into the other eye, don't rush with the surgery, especially for the young postgraduate fellows sitting over there. And this was a publication on the cover page of Ophthalmology. So another case, this girl had a phthysical eye, one eye. She came for a regular review to us, and we thought we are seeing something. I thought clinically it looked normal. But with this family history, I was not very convinced. So I did a wide field angiogram in this particular patient, and you could pick up multiple angiomas in the periphery which cannot be picked up in a standard fundus photograph or a fundus camera, basically because these are all lesions quite in the periphery. So we treated, we could follow him up with this particular picture. Father was asymptomatic. We asked him to come and we did an angiogram. We could pick up angiomas even in this case. The brother was asymptomatic. We asked him to come and we could pick up the lesions. Similarly, this is how we treated, then subsequent follow-ups was done. We could pick up a gene which was responsible for this particular condition. Now another case of a VKH where you can pick up a wide field OCT where you can see the choroid as well as multiple bullous lesions over there. We'll just run through it, and these are some of the classical clinical cases which show you the importance of wide field OCT as well as the wide field color photography. Now this patient had a CRAO, diagnosed CRAO, but when we did a wide field photography, you can pick up a retinitis pigmentosa as well. So retinitis pigmentosa with superadded CRAO. This is 1 month old baby diagnosed elsewhere as ROP. We could do in a flying baby position, we did a ultra wide photograph where we could see multiple lesions, that is retinoblastoma. This is another triad of leukemia where you can see metastasis, infiltration, rod spot in a single picture. Again, a cover page of the eye journal. This is a boy who was diagnosed to have Berlin's edema following trauma. This is last case. Yeah. So following trauma, when we saw it, we thought we are seeing a horseshoe tear. He was reluctant type of a patient. And when we did a photograph, he was convinced. So such reluctant patients can be showed their own photograph and they can be convinced for it. So these are some of the another cases where you can pick up a lesion and can explain the patients. Yes, definitely this is a SLO base, so no true colors and the size artifact that will be there. But yes, it is the way to go, especially in cases where you can follow up the cases in a better way. And these are some of our cover page contributions to the literature based on this wide field angiogram. Thank you.
The need for buying new technology never ends in retina. Excellent pictures. Which machine is this?
This is by Nidec. This is called Mirante. So this is a wide field angiogram. You get a 110 degrees, 120 degrees, I believe, in a single go. With a montage, you can reach up to almost 180 to 190 degrees.
Any questions from the audience?
Yeah, the quality of image in the optos in the periphery is not that good. It is more of a screening tool in my eyes rather than a thing. The quality of the image which you get with this particular SLO based is much more sharper, which can be help you in understanding the disease per se. For a screening type of a protocols where you want to do rapid screening, you don't want to do indirect, till then optos is okay. Yeah, but still the quality of image in the periphery is not that where you can decipher and understand the disease pathology. That's better. You never get such a good quality images there.
What about the mid-periphery and periphery? Because the main thing with optos is you do have the last line and the inferior lesions are mid-periphery.
Exactly.
But what about the periphery and the mid-periphery? With Mirante?
You could see almost to the aura, except in hypermetropic and a deep set eyes, there is a limitation where you cannot reach out to the periphery. But in other eyes, you can seriously reach out to the aura. Yeah, of course. Those are, see, we get in a single view, we get about 120 degrees. To reach out to the periphery, you need 5 images to be collaged together. It's quite easy. It's not that tough.
Can I say?
Please, Mike.
So actually the image which Mirante takes is 163 degrees. It depends upon from where you measure the angle.
Yeah, sorry.
From where you measure the angle is 163 degrees. Optos gives you an image of 210 degrees. And I have been asking Optos people that how can you get 15 degrees on either side beyond 180 degrees? If you just think of it, you draw a line 180 degrees and you say 210, that means you're getting 15 degrees this side and 15 degrees this side. How do you manage to do that? So they have never been able to optically explain it to me. That is one question which I've asked them. In Mirante, as he said, if you take a peripheral part of a wide field and you want to enlarge it, it doesn't get pixelated. So that is one which is very good.
Thank you.
And you can control the images acquisition by the operator can control it, whether you want to take a particular lesion or not. So in optos it is not possible. The machine itself has to take everything.
What about the macular pathology? I mean, are you able to really pick up the details on this of macular
course.
pathology?
It's a SLO based, and it has
SLO,
additionally one more laser which gives you better quality than the standard Heidelberg.
No, what I was told is that there is some kind of a reflection which comes in the macular area in Mirante, where the details of the macula are lost. So
No.
is that true?
No, if you have to take, see, if you are doing a macular study, you can use just the simple where you get 30 degrees. So in that case, you don't get. And it's only a play of the eye movement and thing when you can have a light reflex over there.
So, Manisha, just to answer your question, the central picture of Mirante takes 89 degrees view.
Yeah.
There are two lenses, 89 and 163. The 89 lens you can magnify. The only problem in Mirante is not a true color. So the hard exudates will not really look like hard exudates. So therefore, on the bottom left of that, there is a chart by which you can actually
Play with the
take
colors.
it next to true color, almost true color, but then that is manipulation of images. It's not like Claris. So the advantage of Claris is true color images, which definitely we are missing in Mirante.
Thank you.
They've come out with a new software also, this Nidec I was telling. They've tried somewhere in Japan or something.
So thank you, Dr. Bankole, for an excellent talk and convincing us to think about it. So now I invite the next speaker, Dr. Abhijat Chaturvedi. He'll be speaking on OCT of retina, basics and clinical applications. Please.
So at the outset, I would like to thank Uttarakhand Ophthalmic Society for giving me this opportunity. So I'll be speaking on the basics of OCT, because while interpreting an OCT, we need to remember the basics, and if we stick to it, I'm pretty sure that we can read and interpret any sort of OCTs. So to begin with, as we all know, there are three types of OCTs: the time domain, the spectral domain, and the swept source, which depending upon the scans gives the better images. So on the first image, this shows a time domain OCT. Though the resolution is not too good, we cannot differentiate many layers here, but yes, we can definitely pick up a gross pathology. So then developed a spectral domain OCT, where we can very easily differentiate all the layers and with a very good resolution of 5 to 7 microns. And finally came in the swept source OCT. Apart from the economic point of view, the OCT is very good and gives a very good resolution images. So here I would like to point out that I personally prefer grayscale images over the colored ones, as it is very easier to appreciate the layers and pick up a pathology. So in order to read an OCT, we definitely need to remember the basic anatomy of the retina, because if we don't remember such layers of retina, then we might confuse that what are we seeing or which layer are we seeing. And I would like to emphasize on 3 layers specifically. One is the external limiting membrane, then comes the ellipsoid zone, and finally this RP and Brooks junction. So again, I will be repeating that this is the photoreceptor nucleus, then came in the external limiting membrane, then comes the main photoreceptor unit, which can be divided into inner segment and outer segment, and the junction, which is the EZ or the ellipsoid zone. There's one more, this green line, which is known as the middle limiting membrane, which comes in the American nomenclature. And what is the significance of knowing this layer? Because it is between inner nuclear and outer plexiform layer. Just remember that. I'll be coming on to this in subsequent slides. So again, this is the nuclear part, and the main photoreceptor unit can be divided in an inner segment, outer segment, and the junction, which is the EZ or the ellipsoid zone. So if we divide the entire OCT on the basis of reflectivity, there are layers with high reflectivity. The first is the nerve fiber layer. Now remember that diagram which I just showed you of the photoreceptor unit. So the first layer was external limiting membrane, which comes, and we can remember this. After that comes the main photoreceptor unit, which is divided into the inner segment. Then comes that ellipsoid zone, EZ, the junction of inner segment and outer segment, and finally the RP Brooks complex. So remembering these 3 is very important, because we tend to get confused that which is external limiting or which is EZ or which is RP Brooks complex. So then comes with moderate reflectivity the plexiform layers, and the low reflectivity the nuclear and photoreceptor layers. What's important to know here is the this outer plexiform layer. It has two parts. One is the dendritic and axonal part. So what is the importance of knowing this? That the arrangement of the fibers is generally parallel, but as we come in the perifoveal area, this becomes a radial one. And if we see an image like this is outer Henle's hemorrhagic maculopathy. So if we see something like this, we should just know that yes, this is the layer where the disease is occurring. So if we summarize everything, the OCT looks like this, and now it becomes very easy to interpret and know that we are seeing which layer and the disease pathology is where. So just remember the basics and the anatomy, and I'm pretty sure you can interpret any OCT. Always keep in mind that the positioning of the patient should be a good one. Never cross the zero delay line while recording an OCT, as it will give you mirror images and artifact scale will be there. Avoid vignetting. Vignetting is shadowing that occurs because of maybe iris or some opacities. And this image is not a good image, as we can see choroid here, but in this area, the image has gone out of range. So here I would like to show one more thing, that if we don't have such a marker or it is cropped out because of certain reasons, we can again know that this is the nasal side because of the nerve fiber there. So now we'll show you few of commonly encountered OCTs. So as we all know that vitreomacular traction is something that occurs and gives a pseudocystic appearance. So when we see it on OCT, we can see these images. So there's some traction here, gives a pseudocystic appearance. This is a very bad case of VMT. Here I would like to point out that this is not cystoid macular edema, but rather a macular schisis. How to identify that? We just see that there are some sciatic or tractional pull present here with a very large outer retinal defect, which can eventually lead to a full thickness macular hole also. Coming on to diabetic retinopathy. Now, OCT is very important in cases of diabetic retinopathy. Why? Because this is a case of moderate NPDR. So if we do an OCT, we can see that there is some cystoid macular edema with hard exudates, giving a shadow, not EZ disruption. Similarly, this looks quite similar to this case. Now comes the importance of OCT. So when I do OCT of the second case, we can clearly see the marked difference in the amount of cystoid macular edema, and there's even presence of some neurosensory detachment here. And similarly the third case, which gives just almost the same picture like these two, but you can see the difference in the amount of edema in all the three cases. So to quantify this thing, OCT is very important. And this thing, the terminology of drill, disorganized retinal inner layers, is also important. And we need to explain this to the patient, as if we inject, the visual acuity will improve, but it will not be totally fine because of the presence of this disorganized retinal inner layers. Again, these are the cases of PDR with TRDs, and again we need to remember here that injection is not the way to go, and the interpretation of such an OCT should not be a very difficult task. Coming on to vein occlusions. So when we do a vein occlusion OCT, you can see that there's lots of pockets of cystoid macular edema with disruption of inner segment and outer segment also. Now comes the importance of that middle limiting membrane which I was talking about. So this is a case of non-ischemic CRVO, and here we see this prominent middle limiting membrane sign. So if we just try to avoid it and we see it on 1 week follow-up, we can see that this has converted into a case of ischemic CRVO, and has gone with a very poor prognosis now. And we all know that this is the new thing, and paracentral acute middle maculopathy should be looked out for, as these patients are prone to have occlusions. So I'll be just rushing through these photographs. This is a case of arterial occlusion which shows inner retinal hyperreflectivity, and as chronicity develops, these go to be thinned out. So these are the cases of CSR where we see some subretinal fluid with pigment epithelial detachments. In cases of ARMD, we can see some drusins which are RP bumps. There are loads of variations in cases of wet ARMD. As depending upon the type of ARMD, we can see that they can be fibrous with geographical atrophy, even some hemorrhagic or exudative causes. So IPCV is very important, as OCT biomarkers are very good for that. You can see the double layer sign, which is a sign of branching vascular network on ICG, a hyperreflective ring under the PED, and a peak notched PED. and this is a full thickness macular hole. Just to point out a lamellar macular hole, just always look out for presence of epiretinal membrane on fundus photography, and this can be very easily confirmed on doing an OCT. So in cases of a lamellar macular hole, we see epiretinal membrane, some macular schisis which may or may not be there. So this is my final case, and this looks pretty normal image to me. But when I did an autofluorescent imaging, I see that there's some activity going in the fovea. Then I started taking the history of the patient, and it came out to be a solar retinopathy. And when we do an OCT, we see a classic EZ disruption just below the fovea, just at the fovea, sorry. So you will have to explain to the patient that your visual acuity is not going to improve much just because of this entity. So the take-home message would be that proper positioning should be there. We should avoid any sort of artifacts. I personally prefer grayscale images as they give a better appreciation. Always remember the anatomy, the basics of the OCT, and the final step is correlation and interpretation of the scan. Thank you so much.
Beautiful presentation with good scans, and showed that middle layer.
Yes, sir.
Sign.
Yes, sir.
So in case you see that sign, it means you should preempt to inject.
So we should.
VEGF.
Rather more than injecting, sir, I think that we should go for evaluation, furthermore evaluation. Like we can do FFA, and also we can send the patient timely for a systemic workup also.
That is of paramount importance in all the cases.
Yes,
actually.
yes,
Yeah.
yes, sir. Yes,
But
sir.
I think considering the scenario what you showed.
Yes, sir. So that was a very drastic change for me also. It was totally unexpected. So that was the time when I actually learned about that, yes, we need to see this middle limiting membrane also. Thank you.
Thank you, Doctor. Now we have our next speaker, Dr. Puneet Gupta, who will be speaking on OCT angiography. Dr. Puneet is one of senior eye surgeon, and he's practicing in Ghaziabad.
Yeah, good morning everybody. OCT angiography is an extension of OCT, and I'll be talking about its clinical implications in relation to age-related macular degeneration. OCT angiography actually is one disorder where this technology is best utilized for its clinical use. I'll be talking about the basic backgrounds of OCT angiography and utility of OCT angiography in diagnosis, management, and also a word about dry AMD. In place of eye with eye, OCT angiography relies on motion contrast to generate the vascular maps. It captures the flowing blood cells and generates maps of and fast maps of various layers of retina, and also in addition to these and fast map, it also generates cross-sectional B scans where the functional flow data is superimposed in a color-coded manner on a structural B scan. So we have en-fast images as well as cross-sectional images with OCT angiography. To generate an image on OCT angiography, there has to be minimal amount of flow within the vessels to generate a differential image. If there is no flow, there will not be any image. This is on the side, these are the various layers of retina, and on OCT angiography, you can see this is the superficial vascular complex, deep vascular complex, this is avascular complex, and this is choriocapillaris and choroidal layer. This, and in addition to these and fast maps, as I have told earlier also, it generates B scan images where the flow data is superimposed. This is the Heidelberg image where you can see these yellow dots are representing the presence of flow in retinal layers. In age-related macular degeneration or any macular degeneration condition, we are concerned with these layers of retina where we see pathology in most of the times. In vascular diseases like diabetic retinopathy and venous occlusion, etc., these are the layer that is superficial and deep capillary plexus where the pathology is present. In age-related macular degeneration, we are concerned with this area. OCT angiography has high sensitivity and specificity in detecting and diagnosing choroidal neovascular membrane. It has ability to diagnose type 1, type 2 or type 3 neovascular membrane. In age-related macular degeneration, the retinal architecture is very much disturbed. So automatic segmentation is not very reliable. You have to use custom slab and scroll it over the suspected lesion on a cross-sectional scan and watch it simultaneously on the NFAS OCTA to correctly diagnose the lesion. Reviewing both these NFAS and cross-sectional OCT together increases the specificity and sensitivity both in detection of sensitivity in detection of CNV lesion if compared with only an NFAS image. The segmentation should be correct to locate the choroidal neovascular membrane. In this picture here, you can see because of the poor segmentation, actually this is picking the choroidal the vasculature, and you are seeing this appearance of neovascularization, which is actually not a neovascularization, but because of the poor segmentation, you are seeing these the flow. This is type 1 CNVM, where you can see the neovascularization below the RP. This is above the RP, type 2 CNVM. This is a picture of polypoidal lesion. The flow at the tip of this thumb-like PED lesion with a double layer sign, where you can see the branching vascular network can be detected. Generally, it is difficult to pick on OCTA due to poor flow in polyps. But if you see these NFAS images with cross-sectional images, you can pick most of the lesions along with the OCTA biomarkers, OCT biomarkers for polypoidal lesions. Although OCT and this ICG angiography is the gold standard. You can detect non-exudative CNVM, that is vascularized drusen, where the CNVMB is there, but there is no fluid, which can only be detected on OCT angiography. Quiescent choroidal neovascularization is also a CNVM, but there is no fluid. These are the flat lesions, whereas drusens are they grow vertically. These non-exudative choroidal neovascularization are important because 20 to 80% eventually convert to exudative CNVM and needs close follow-up, but no treatment until they develop leakage or development of fluid. The fellow eye examination is also important because some of these lesions, they develop exudative AMD and they may eventually develop exudation. This is an interesting patient, 60 years old lady with the 6/9, 6/9 partial vision. There were some abnormalities at these RPE, drusen and drusenoid PEDs. Angiography, OCT angiography showed no flow. This patient subsequently developed visual deterioration to 6/36. There was this hyporeflectivity seen here, and this patient was injected with anti-VEGF injection, but there was no improvement. Rather, there is deterioration in the appearance. This was actually, but if you see the OCT angiography, there is no flow. So this was actually, there was no CNVM, there was no flow. So this was actually adult vitelliform dystrophy, which was misdiagnosed and treated with anti-VEGF. This cavity is because of the collapse of the vitelliform material. So OCT angiography is also a reliable tool for confirming the absence of neovascularization in such patients. This is another patient where the fluid is present but no CNVM. This is a chronic long-standing CSR in an elderly patient. Management, the change in appearance of choroidal neovascularization also helps in managing these patients. By assessing the appearance of neovascularization, you can assess whether the anti-VEGF treatment is responding or not. The maximum resolution takes 2 weeks after the injection, and it may reproliferate after 4 weeks. On OCT angiography, you can define between active and non-active CNVM, which is immature and mature. The active CNVMs are proliferating lesions with extensive capillary sprouting and numerous anastomosis, and whereas the mature ones are larger diameter filamentous vessels with lesser branching. So I'll skip with this dry AMD because of the time. OCT angiography is an excellent technology, especially for patients of macular degeneration. Most of the limitations are that most of the commercially available machines have a smaller area of scanning, except 1 or 2 machines. There are some artifacts which may cause problem, but in spite of that, it has high diagnostic value in detecting the presence as well as the absence of CNVM, and it is a useful and dependable tool in management of neovascular AMD. Thank you very much.
Thank you, Dr. Puneet, for an excellent presentation. So, what percentage of cases you are able to pick up polyps on OCT angiography?
See, if you combine, I don't have facility of ICG angiography.
Correct.
So we mostly depend on OCT and OCT angiography. Before having OCT angiography, I was totally dependent on OCT appearance and angiography, basic angiography. But now with OCT angiography, if you carefully analyze these pictures and sit on the machine, you can detect almost about 70 to 80% of those PCVs. I don't know what.
That is also a good number. Maybe Dr. Sangeet?
BVN is seen very clearly in these patients on OCT angiography. So BVN is picked up in almost 65 to 70% of the patients with PCV. And the PCV depends on it's a low flowing polyp or a high flowing, so that you can make out. You can see the NFAS along with the OCT angiography to locate a polyp in these.
But basically, to do the focal laser to the polyps based only on that is what in that case you have to do ICG angiography. Dr. Sangeet, you wanted to say something?
Yeah, not this thing, but I just wanted to ask Dr. Puneet about the IAMD. Like the patient comes, there is no fluid, but you would pick up a membrane on the OCTA, and the patient is symptomatic with metamorphopsia. Still, you will wait for the injection, or you'll give the injection?
I think if there is some symptom, there is no guideline for this, but I think if the patient is symptomatic, you will consider treatment because of that. But if there is no symptom and there is no fluid, I think we should wait and follow these patients closer interval.
Anyway, thank you, Dr. Puneet. May I call upon Dr. Salil Gupta for his talk. This ultrasound B scan for posterior segment evaluation.
So, good afternoon, everybody. Now, after the Lambogni, I'll take you back to Ambassador. So, so B-scan is the most useful tool when direct visualization of the intraocular structure is difficult. It involves high-frequency sound waves. These sound waves, which are reflected from the tissues differently, and then when you have an interface, you get a image of these ultrasonic waves. So the most important thing is the reflectivity. When sound travels from one medium to another medium, there are different density part of the sound is reflected from the interface between these two media back into the transducer. This is known as echo. Greater the density difference, the greater will be the interface. So the imaging zones can be hyperechoic, hypoechoic, or anechoic. So we have two types of ultrasound waves generally used. The A scan, also called as the amplitude scan ultrasonography. This involves a very thin parallel sound beam which is emitted and passes through a eye and images a very small axis of tissue, the echoes of which are represented by the spikes. The height of the spike will depend upon the property of the tissue at the interface, the regularity of the tissue, the reflectivity, and the sound attenuation will depend upon the density of the tissue through which the scan is passing. So this is a image of a patient who had trauma. So we have multiple things in this. So the first wave we are getting is because of the corneal interface, the reflectivity, high reflective spike from there. Then you have reflective spikes from the anterior and posterior part of the capsule of the lens. After that you have a very flat line. Now that denotes the vitreous. But here, because of the vitreous fluid, you have few low echoic sounds over here, and you can pick up, say, that you have some vitreous hemorrhage over there. The patient has a moderate reflective echo over here, which represents posterior vitreous detachment, but it is not as moderate, it is almost as high because it was a heme line because of the hemorrhage. Now, if you see this wave, The patient already had a choroidal detachment. So this is a bi-peaked wave we are getting. Now this is a very typical of a choroidal detachment. And then you have multiple waves which denotes sclera, the orbital tissue, and then attenuates to the fat. This is the same patient with a B scan. A B scan is an oscillating sound beam which emitted passes through the eye image and gives a slice of the tissue. So here you can very well visualize the dot images which has a moderate reflectivity, which denotes the vitreous hemorrhage over here. The posterior vitreous detachment we saw over there is mildly high reflective membranous echo over here because it's hemline, and then you have a choroidal detachment which you can see a thick membrane over there. So positioning of the probe is very important to know what is the extent of the lesion. If you put up the probe in the transverse, it will let you know the lateral extent of the pathology, and whichever part the probe, the pointer is up, will go up. So remember that the pointer always points up. The axial position means that you are passing the wave through the posterior capsule and the optic nerve head. Then the longitudinal position gives you the extent of the total extent of the lesion. Now these are certain examples of B scan in the vitreous. Now this is a patient who has a very high reflective echoes in the vitreous cavity, a clump of asteroid hallosis, and along with that you can see the patient has a vitreous detachment over there. So in vitreous hemorrhage you can get different type of images depending upon the how long the hemorrhage has been there. Initially the hemorrhage will show you dot hemorrhages. Later on you will see the membranous structures over there. In case of endophthalmitis, now that is a very dreaded thing which all anti-segment people dread about, and they would like to know whether the patient is having just a inflammation or it is endoph actually. So what would the signs over there? You will have moderate reflective echoes throughout the vitreous cavity. You have thickening of the choroid, thickening of the sclera, and sometimes even you can get thickening of the optic nerve head over there. Now some examples in the retina where the ultrasound B scan is helpful to, first of all, to differentiate between a retinal detachment and a PVD, especially in the condition where you have vitreous hemorrhage. So retinal detachment will have the attachment near the aura and at the optic nerve head, and you can see the module movement of the membrane when you ask the patient to move. So you can differentiate between a hemline PVD and a retinal detachment. Sometimes you can pick up large retinal tears or a giant retinal tear which has folded up. So in case of vitreous hemorrhage in diabetics, you would definitely like to pick up these TRDs so that you can prognosticate your surgery, and you can ask the patient to go for early intervention. Now this is a patient who had PHPV, where you could see a moderately thick membrane-like structure going from optic nerve head to the front of the lens. Then this is a patient with retinoblastoma who had calcium deposits in the tissue. Now, choroidal detachment case, you would like to know whether the patient is having hemorrhagic choroidals or you are having a serous choroidals. So you have a moderately active multiple membrane-like structures, and in the serous you will have a hypoechoic or anechoic cavity, whereas in hemorrhagic one you will have hyperechoic cavity. Then to know about the scleritis, in this you will have inflammatory nodule sometimes, or just the thickening of the sclera, and you can have a T sign. Now what is T sign? T sign is the fluid which accumulates in your Tenon's space, and you can also have the thickening of the optic nerve head shadows. In optic disc edemas, you can have optic disc drusen, which is highly reflective, or you can give a sign of a crescent sign when you have a raised intracranial pressures. In trauma, you can pick up intraocular foreign bodies, a dislocated lens, a retinal detachment, choroidal detachments. You can differentiate between, you can pick up cysticercosis, and especially in cases of choroidal tumors, when you want to differentiate and you want to know about the whether the patient is having choroidal tumor or it is just a hemangioma or a melanoma, there you can nicely differentiate with the help of the B scan. In a melanoma, you have a typically button-shaped tumor, and the attenuation of this is very gradual.
Dr. Salil, actually we are running late. Would you please summarize?
So this is the last picture of processtophthalmoma. So in all the phase of the eye, in all the structures of the eye, the B scan helps to differentiate and to lead you to a diagnosis. Thank you.
Thank you, Dr. Salil. Now I call upon Dr. Ajay Arora, and he'll be speaking to us on micropulse laser principles and my experience in CSR, diabetic retinopathy and RVOs. I'll just request all the speakers to stick to their time because we are running late by about half an hour.
I have the connector, just if you can.
Any questions for Dr. Salil?
Try to finish my presentation even before 7 minutes. I'll do whatever best I can. He wanted me to include everything: CSR, diabetic retinopathy, RVO. I do not know if I can do justice. So this is the basic concept. Greater the burn duration, greater the damage. Lesser the burn duration, lesser the damage. And this was a seminal work done by Mainster way back in 1970, that if you could reduce the burn duration, you can specify the damage to a particular layer of the retina, and that is extremely important. If this retinal burn is further split into different pulses, and you can divide it into pulses with the relaxation time, and that's the concept of micropulse laser. So a subthreshold laser is different from micropulse laser. A subthreshold laser, you can demonstrate damage on a fluorescence angiography or in an OCT, but in an OCT you do not have an obvious damage in a micropulse laser. Now the question asked is, what happens? What do I, if I don't see anything, are you doing anything at all? So they did this study on special retinal layers which were similar to an RPE, and they demonstrated on that there's an increase in HSP70 expression after subjecting it to micropulse laser. It has been further said that there are different treatment methodologies for treating with micropulse laser, and what has been found now is a low intensity, high density pattern which is given, which is particularly useful. So if you have a case of CSR, and acute CSR is masterly inactivity, you do not treat it for about 6 to 8 weeks. After that, if the patient is symptomatic, a chronic CSR, we would definitely treat. This is a patient of chronic CSR who had this disease, was treated with lepinezolone for almost 18 months. This is pre-micropulse laser, post-micropulse laser, patient responded well. This is a dentist who came to me, was on 5 years chronic CSR, had taken all sorts of treatment including epinezolone, and then subsequently we did an OCT angio. We found that in the right eye had a secondary CNVM, so I would not discuss this. We treated this also subsequently, but I'll show you for the left eye, had CSR, Treated with CSR 5 days later, actually the fluid had increased, but the patient was not symptomatic, the vision was good, and subsequently flattened off, metamorphopsia disappeared. I have treated him 3 times in last 4.5 years, and he is doing well. He is able to identify the right tooth and do the good dental work. He doesn't misses the teeth, so he is doing good dental work, and he is doing well. This was an ophthalmology resident, so I picked up the cases who definitely require. He was from out of NCR, and during his residency he came to me 3 times, and we have treated him. Every time he had metamorphopsia, we would treat him. He had a pachychoroid, did micropulse laser. He was able to manage. He was under significant stress. The moment he finished his residency, his CSR has actually abated, and he is doing well. So this is the various pictures of various times when he came in, micropulse laser was done, and he is doing well. So now coming to venous occlusion. So this was an Army general who was 76 years old, operated CA rectum, non-ischemic CRVO. He refused to go in for anti-VEGF because he was well versed and well read about anti-VEGF. He did not want to risk it. We treated him symptomatically, and then he agreed for micropulse laser. This is sequential photographs after micropulse laser. It may be that the disease abated and he responded on a natural history, but he responded well on a micropulse laser, and I have now an 8 years follow-up with this gentleman, and he is doing well. This was a patient who had a young girl, an inflammatory branch lateral venous occlusion, was treated with Avastin, then subsequently got a second Avastin after 3 months. We plotted out the areas of capillary non-perfusion. We had an option of doing continuous wave laser here, decided not to do that, decided to go ahead with subthreshold micropulse laser. I was that time not sure, so I marked out the area of capillary non-perfusion and filled it up with micropulse laser. I now have a follow-up of 8 years for this girl. You can see here that in the areas of capillary non-perfusion, there is some element of vasculogenesis occurring. We are not sure, but this is a follow-up. This is 2015, and this is 2018. Now she has come to me in 21. Now she's moved to the UK, and she keeps coming annual basis, and she's doing well. The only thing that has happened is there's a foveal thinning. Her vision is maintained at 6 parts, but she's doing well. So this was one of the first patients, and this slide is from Chandigarh, where we did first micropulse laser way back in 2015. A patient who refused to undergo a normal continuous wave laser. We treated the patient metabolically and did a micropulse laser for the extrafoveal diabetic macular edema, and patient responded. Another patient, you can see here, before cataract surgery, 6 months after before cataract surgery, before we went ahead and did cataract surgery, patient responded well with a good metabolic control and micropulse laser. This gentleman I've been following for last 4.5 years, and we have had a few more cases where we have actually done a micropulse pan-retinal photocoagulation. We treat focally for NVE and rest of the areas, and I'm not showing here the sequential field charting we have done for this patient, and we have been able to actually preserve most of the field by doing the micropulse laser. I think that is an important useful addition when we do a micropulse PRP in these cases. So in conclusion, chronic CSR micropulse laser, we have now treated over 20 eyes and had a long follow-up in these cases. We may have to repeat this every 2 to 3 months. It is a safe, non-damaging to the neurosensory retina. Since we do not have PDT available, I think that's a technique to go by. For venous occlusion and DME, I think initially we reduced the macular thickness to about 450 microns before we do a micropulse laser, and this has allowed us to reduce the number of injections, and maybe in PDR cases selectively we can treat these cases, but a larger study would be required. Thank you.
Thank you, Dr. Ajay. Before we take up questions, I'll request Dr. Rahul to be ready with his presentation. Sir, I had 2 questions. One is that how would you compare, if somebody didn't have a micropulse, how would you compare an ICG enhanced TTT for CSCR versus a micropulse? And the second question was that you showed a case where you have done micropulse in the periphery, where you have a vascular occlusion, and the concept being that probably that is not going to hamper the revascularization of that area. But we do see collaterals forming even after a regular laser photocoagulation and when we have a vascular occlusion.
Yeah, so basic aim there, I'll answer your second question first. The basic aim there is that we do not wish to cause field loss. Micropulse laser does not cause tissue destruction. Since it does not cause tissue destruction, it is likely that the nerve fiber layer bundle is not going to get damaged, and therefore field loss will not occur. The concept of using micropulse laser is because actually micropulse laser works by producing anti-VEGFs. So by producing an anti-VEGF, you are reducing the total amount of VEGF, and therefore the disease gets controlled better as compared to the laser. Also, the target is only to make it more hypoxic or anoxic eventually, so that you reduce the metabolic demand of the retina by doing peripheral laser in these cases, by producing less, by inducing more anti-VEGF production, which is HSP70, which will reduce the amount of VEGF in the eye and therefore probably control the disease better.
I mean, I can understand when we are doing a PRP in a normal retina like a PDR, but in a case where you have a vascular occlusion and there's no vascular supply, I would assume there is already a visual field loss in that area.
Yeah, so the field charting I talked about was the diabetic PDR cases. In a patient with a venous occlusion, we have not plotted fields over a period of time. So I can't really say whether we have saved fields or not saved fields. The concept was to save the fields. I agree with you. And in cases of PDR, I think if we can save the fields, it will probably help us a lot.
ICG enhanced TTT, sir?
ICG enhanced TTT, the only thing I can think of is that micropulse has a pulse mode of delivery. So therefore you have there's a relaxation time in between, but in an ICG enhanced TTT it's a sub-threshold laser. A sub-threshold laser actually does cause damage at the level of the OCT. But a micropulse laser does not cause damage to the OCT. So that I think may be the key between the two cases.
Thank you, sir. We'll move on to Dr. Rahul. And Dr. Rahul will be speaking on multimodal imaging in macular disorders.
So, good afternoon all. Thank you, KSOS and Saurabh, sir. I think I'll be taking less than 7 minutes. So, these are the various modalities what we have for macular multimodal imaging for the macula. I think the details already we've been seeing, and we've all seen the OCT being the mainstay for most of us, and we've seen the evolution of OCT through these years. So I'll try and do it as a case-based approach, wherein we had this patient 5 years back, wherein the patient came to us with the 2-meter vision in the right eye. Clinically, I could see a hemorrhage and a yellowish lesion at the macula. We went ahead, did an angiography for this patient, and what we could see was a lacy pattern in this patient, suggestive of a classic CNVM. For the multimodal imaging, we went ahead with the OCT, and what we could see was the RPCC thickening along with intraretinal fluid. Anti-VEGFs given over a period of time, patient improved. So fundus fluorescein angiography in this patient was important, though OCT was also associated, and they all go hand in hand. I won't go into the details of fundus fluorescein angiography. Another patient who reported to us in 2017, and this was the position what we saw. No point doing an angiography in such kind of patients, as we would not have had any good results with the angiography or an OCT. So what we did was a TPA gas in this patient, followed by an angiography. Angiography though was not very useful for this patient, and we could not get anything specific on an angiogram. There were more window defects seen. This was the OCT we did for this patient at the fovea. We could all see was the RP undulations and maybe a kind of a double layer sign there. So went ahead, did an angiography, and what we could find was these polyps along the superior temporal arcade. did an angiogram, did an OCT at the place where we had these polyps, and what we could see were the classical notched PEDs and the double layer sign. So these are other signs what we see in these patients. So ICG again helped us in this patient to find out the polyps. We went ahead and did laser for this patient later. These are the all indications where ICG is required, gold standard for PCV. These are other patients which we have seen, and we have seen these peripapillary polyps on ICG in these patients. Another patient reported to us with submacular hemorrhage, and what kind of hemorrhage we see. We went ahead, did an angiography in this patient, and what we could see was a hyperfluorescent area where that we could see a nodular lesion. So these are the diagnostic criteria what we see in polyps, and various things what are seen for these PCV patients. Autofluorescence, actually I like doing autofluorescence a lot. So it is a non-invasive technique which allows topographic mapping of lipofuscin distribution along the RPE. We all know hallmark of aging is RPE cells and the they get accumulated of lipofuscin within the cytoplasm, which is not able to come out of the cytoplasm and causes death of the RPE cell. So when we have hyperautofluorescence, it is in cases of RPE dysfunction, and where we have hypoautofluorescence, it is due to the loss of the photoreceptors or the RPE cell death. So this is normal autofluorescence what we see. So this was one paper by Vishali ma'am and group which actually changed my reading of autofluorescence. I do autofluorescence in these choroiditis patients a lot, and like for example, this patient was seen in 2017, and this was the position. What we could see was a hypoautofluorescent area which suggested of a healed choroiditis in this patient. The patient came with diminution of vision later, and what we could see was, how to make this run. Okay, these were the fuzzy margins what we could see, which reflected on autofluorescence as amorphous hyperautofluorescent lesions. These are the serial pictures of the same patient. We started steroids and ATT in this patient after taking a physician referral, and this is how we map these patients. This is on top. What we can see is the autofluorescence, and below is the angiography. And what we compare is these active choroiditis lesions. We can actually see them on autofluorescence. Another condition where I use autofluorescence a lot is these kind of patients where we need to prognosticate in patients with geographic atrophy and these patients. So autofluorescence works well for these patients. OCT angiography, I think, has been talked about in detail a lot. I will not get into the details. Just a small example. I would say that still till date, angiography cannot be replaced by OCT angiography in at least my clinical practice. So just by giving the last example, this was a patient of a CSR, chronic CSR. We watched this patient for 3 months. We did an angiography in this patient, had multiple leaks, what we can see, not willing for laser. This was the OCT of this patient. We started rifampicin. This was in 2019. We started rifampicin. The fluid increased in this patient. Rifampicin was continued, but again he was not willing for laser. The fluid decreased over the past of 5 months. Then again the patient lost to follow-up. We did focal laser also. Patient lost to follow-up after that. The patient came again with this 624 vision from 6/9 partial, what we could see after 8 months. We went ahead, did an angiography again, more of pigment RPE defects, what we could see, a small leak temporal to the fovea. At this point of time, we had actually procured this OCT angiography, and what we could see was a small CNVM line there. So in these kind of cases, OCT angiography works very good, specifically in this pachychoroid spectrum patients. So we went ahead, did an anti-VEGF just to show another patient of a PCV. This was a macular scar in the left eye patient. We went ahead, and this was the polyp, the classical notch what we see temporal to the fovea. So thank you. What I meant was to say that all these investigations work hand in hand, and we should know what works best in what kind of cases. Thank you so much.
need to be combined?
Yes, yes, sir.
Just on the basis of
Yeah, we cannot comment.
And also, I think to be correlated with the clinical presentation. I think that's very important.
Definitely, yes.
So thank you, Dr. Rahul, and we'll move on to the next talk. I'll invite Dr. Saurabh, and he will be speaking on unraveling the masquerades, multimodal imaging to the rescue.
Good afternoon, everyone. I'm sorry for skipping the queue, but I have an oration of ma'am which I have to conduct. So I'll just quickly go through these slides. I'm sorry, these are unedited slides. I was editing a lot of other stuff, so please pardon me. I'll just go through it real quickly. So I'll be talking about some masquerades. So these are the long list of causes for leopard spot chorioretinopathy with PIOL and B dump and choroidal mets. Just show you a few representative cases. This is a 57-year-old female, 11 years back, had low-grade vitritis. Systemic investigations were non-contributory. 2 more episodes of bilateral low-grade vitritis, uveitis panel non-contributory, 6-9 OU, on topical anti-glaucoma therapy, lost to follow-up for 7 years, returned back with vision of counting fingers close to face in the right eye, 6-18 in the left, with vitreous cells in both eyes and advanced glaucomatous cupping with multiple pigmentary changes and intraretinal hemorrhages along the arcades. So this is the pre-treatment ultra-wide field color fundus photo. Not very clear here, but on the swept source OCT, we saw sub-RP hyperreflective deposits with associated neurosensory retinal detachment in the right eye, and the left eye a band-shaped sub-RP hyperreflective area, which you can see very clearly here on the swept source OCT. So on the pre-treatment fundus autofluorescence, there was a granular hyperautofluorescence and hypoautofluorescence, what we commonly call as a leopard spot appearance. You can see here much more clearly in the left eye, where the media is clearer, and this is on the ultra-wide field fundus autofluorescence. So there was peripapillary leakage in the right eye on FFA, and in the left eye again we had a leopard spot appearance on fundus fluorescein angiography as well. So normal peripheral blood smear, ultrasound abdomen was unremarkable, CSF analysis, no atypical cells, on a PET scan, no abnormal hypermetabolic focus or mass lesion, underwent EBUS TBNA and showed just reactive lymphadenitis with ZN stain negative, and histopathology, no evidence of metastatic carcinoma seen. And on immunohistochemistry, no definite evidence of lymphoproliferative disease. A diagnostic vitrectomy was done, which showed in the left eye, which showed B cell was negative. However, T cell markers were positive and was diagnosed as a case of lymphoma. And these are courtesy RP Center. This evaluation was done and the biopsy was done by Dr. Rohan Chawla, and Dr. Seema Kashyap did the IHC for this. And these are confirmatory of a T cell lymphoma. So bilateral primary vitreoretinal lymphoma of T cell origin. Patient underwent intravitreal methotrexate injections, about 25 of them over the next almost a year, and resolved pretty well, and it was in remission, as I shall show you soon. And these are the images post treatment, and all the lesions have resolved in both the eyes. And this is the post treatment FFA and the ultra wide field imaging. Patient's vision also improved to 636 parts. Second case, lumpy bumpy choroidal conundrum, and 82-year-old female, left eye diminution of vision since 20 days, vision of 624 parts in the left eye, 6-9 in the right eye. The fundus doesn't really show much, but the autofluorescence shows this lesion near the supratemporal arcade. FFA shows a speckled hyperfluorescence along the supratemporal arcade. ICGA also shows a hypocyanescent area along the supratemporal arcade, and this is what is the giveaway. It is the OCT which shows the lumpy bumpy choroid, and with speckles and the shaggy photoreceptors, which is the total giveaway for these conditions. And patient was investigated, and on follow-up the patient was initially put on steroids because the patient presented during the COVID pandemic, didn't really want too many investigations which involved close contact. But our differential at this moment was choroidal mets, choroidal melanoma and posterior scleritis. But we went into the history and we got a history of infiltrating ductal carcinoma of the breast, treated with MRM several years back, and patient was on memofen for the last 3 years. Detailed systemic examination showed metastasis, and patient was diagnosed as a case of choroidal mets and treated with palbociclib and letrozole. And this is the follow-up of the remission of this case and the serial follow-up on OCT scan. and this was published recently. So these are the various symptoms and signs and how these METs can present, and various colors have been given. For lung carcinoma, it's pale yellow. For breast carcinoma, it's lobular creamy white. For prostate, it can be an amelanotic mass. For renal carcinoma, it can be a temporal orange color. For lung carcinoid, orange. And the thyroid tumor can present as a subfoveal orange color mass. So fundus photo cannot actually give you the answer in most of the cases, so you have to be on the lookout for these things. History should not be neglected. And this is a case of a rare case, 58-year-old male, which we kind of worked up a few years back, elsewhere seen with 6/9 and 6/12 vision, diagnosed as CSR, and just called for a 6-monthly checkup. And 3 days prior, again was followed up and had vision of 624 parts and 624 in the right eye, this time again diagnosed as CSR. And so this benign, innocuous looking CSR can be quite bad. This is the take home message actually from this talk. If you see here on the angiogram, you can see a starry sky appearance in both eyes. And this is what the swept source OCT, courtesy Dr. Vinod Agarwal at RP Center, and you can see that there is huge amount of choroidal infiltration there and bilateral subretinal fluid with again shaggy photoreceptors and a leopard spot appearance on the fundus autofluorescence. When we went into the past medical history, we see on ultrasound abdomen there was a large solid hypoechoic mass, and he was actually underwent a nephrectomy, left laparoscopic radical nephrectomy 8 years back. Remote history according to the patient, but again presenting now. And at presentation the ultrasound showed widespread metastasis. This was the PET scan, and patient was diagnosed as B-dump, which is basically bilateral diffuse uveal melanocytic proliferation. Refused plasmapheresis, underwent primary chemotherapy with Sutent, which is sunitinib, did not really respond, and the SRF kept increasing, landed up with exudative RD, lost vision in both eyes, was not willing for any kind of treatment, ended up with OU closed funnel RD and with neovascular glaucoma and with increase in metastasis. And patient refused EBRT and was put on second line chemotherapy with everolimus, and finally was lost to follow-up. And this was published again in AJO case reports. So B-dump is a rare entity, paraneoplastic syndrome, ocular signs precede systemic manifestations, and these are the 5 cardinal signs given by Gass et al. So we must be on the lookout for these conditions. Double trouble, yet another lumpy bumpy conundrum, 618 in the right eye, 66 in the left, 58-year-old male. This is what it looked like, and this is what the fundus autofluorescence, you can see that in the right eye above the disc, and in the left eye in the inferior retina you can see these changes very well on the autofluorescence. And again lumpy bumpy appearance on the angiogram, you can see the changes, and on FFA intense leakage at the edges of the mass lesion, and on the ICGA hypocynescence. This is what the B scan looks like. And OU choroidal mets, CT chest, ultrasound abdomen, MRI brain, MRI orbits did not really show much. Patient was referred to higher center in view of the lung carcinoma with mets. PET scan report right pleural effusion, pulmonary mass, locally advanced malignant pathology, extensive lymphatic metastasis. Ultrasound FNAC of the right supraclavicular lymph node showed a metastatic mucinous adenocarcinoma stage 4B. Was put on palliative chemotherapy with paclitaxel, carboplatin and bevacizumab. And this is post treatment. You can see that the lesions are flattening. And finally, I'll just show you towards the end because this is the last case. So this is the serial change in analysis. The lesions responded very beautifully, and this is post 4-5 cycles of chemotherapy. This was managed at PGI Chandigarh, and so it totally flattened out. But then patient came back with a recurrence, and unfortunately we lost this patient just a month back, not even a month back, about 3 weeks back. So these are the the post treatment angiograms, and this is the PET scan. Thank you.
Thank you, Dr. Saurabh, for the wonderful collection of cases, of rare cases, and making us wiser. I think we'll take the questions at the end. And may I please invite Dr. Neeraj Sandhuja, our prolific vitreoretinal surgeon at Gurgaon at the Viana Eye Center.
So I'll be speaking on diagnostic dilemma in postoperative endophthalmitis with few cases. So if you look at this picture on the first post-op day, you have always has that suspicion you're looking at some sterile reaction or some infective reaction. And the differential diagnosis which comes to your mind is, if it is non-infectious, it could be TAS, or it could be some remnant of dislocated lens or nucleus, or it could be tissue reaction to a complicated surgery. So as far as the endophthalmitis is concerned, usually within the first 24 to 48 hours, it is gram-negative organism. Otherwise, mostly it is a TAS reaction, which you see in an initial period of time. And pain is less common in TAS, and visual acuity is mild to moderately reduction is there. And there could be a corneal edema, limbus to limbus, and less of fibrin and hypopyon in such cases. And intraocular pressure is mostly elevated in TAS. So as far as endophthalmitis is concerned, the classical things which you see is a hypopyon, there could be a pupillary membrane, and disproportionate AC reaction and poor media clarity. And in the incision, you can see infiltration. If you put a suture, there could be infiltration. Ultrasound B-scan is not for the diagnosis, but it helps you in prognostication of the case and seeing any other associated pathology in form of choroidal detachment or some retained lens matter or nucleus. If you look at the confirmation with the diagnosis, because it is a clinical diagnosis generally, because the culture and on aqueous tap and vitreous tap is 40 to 70% of cases it is positive, and rest it is negative. So I'll be showing 4 different cases with variation in presentation. So this was the first clinical scenario. On the second post-operative day, patient had minimal pain, vision 624, having hypopyon, aqueous cells 4+, and vitreous was clear. So again, a doubt whether we are dealing with infection or not infection. We started the patient on frequent topical steroid, because whenever you see any undue reaction, you need to put the patient on frequent topical steroid antibiotic drops, say cycloplegic. Observe over first 6 to 24 hours. You can add up some oral steroid and antibiotics along with that, but if it is infectious origin, it will definitely going to worsen. So very close follow-up is important. And if there is worsening, then you give intravitreal antibiotic injection. You see, look at this case, patient was given topical steroids only, and along with the oral antibiotics, and the patient responded well to the treatment, and after 2 weeks, the reaction subsided and it never came back. Another scenario, post-op 4 to 5 weeks after surgery, vision 6/9 to 6/12, and you can see there is a reaction into the anterior chamber. And this time, because the patient was on tapering doses of steroids, having pain and redness, and so the steroids were increased, condition became better, topical steroids tapered, and again the same situation. So we had a doubt, we are dealing with infection case, and patient was taken for anterior chamber tap. And you can see once this tap was done, all the flocculent matter came into the anterior chamber. So much of pus was sequestered in the bag itself. If you look at the upper picture, you can't make out much, but this was done in the OPD, and then we took the picture. Then the patient was taken to the operation theater, and AC wash was done, and intravitreal antibiotics was given, and patient recovered. Another case scenario, 8 months post-op period, had good vision, glasses were given, but again vision blurring. And you can see a fibrinous membrane along the IOL covering the optic and haptic both. So we had a doubt of low-grade endophthalmitis in such case of P. acne infection. And this aqueous step was given and sent for anaerobic culture also, which came out to be P. acne positive, and the patient received intracapsular vancomycin injection, half dose in the bag and half dose in the vitreous cavity, and started on 45 drops. So you can see after 2 days the vision becoming better, and you can see that there was total disappearance of the membrane around the IOL. And luckily this patient didn't have any recurrence. The patient was followed up to the 14 months. Otherwise, generally in such cases, you need to take out the intraocular lens also. But luckily, we could save this. And it is very imperative to understand always infection starts on the bag itself, and you have to hit it over there. In case you can open the capsular bag and put the antibiotics over there, not only into the vitreous cavity. Another case, post-op 4 months, had good vision, sudden blurring of vision. You can see eye was totally quiet, but having a large flocculent matter into the pupillary area with hypopyon. So we thought after so many months of surgery and with no pain. Probably we are dealing with the fungal endophthalmitis case, and we had this option of giving amphotericin B and voriconazole. This patient underwent vitrectomy with the intracameral and intravitreal voriconazole injection into the eye, and you can see the patient recovered well. We didn't have to take out the IOLs. We had 3 cases like this where we could help the fungal endophthalmitis cases with this voriconazole injection only. And sometimes in fungal cases you need to repeat the injection every 2 to 3 days to avoid any recurrence. And if you see little bit of inflammation, you need to give injection. And some people, they alternate between voriconazole and amphotericin B also. So in fungal cases, usually they show apparent response to steroid initially, but they become recalcitrant later. So it is better to hit them hard in the initial go itself. To sum up, any hypopyon should be taken seriously, and we need to look at the section and posterior capsule carefully. And we should always do aqueous tap or vitreous tap for culture. And if you have a doubt, like organism you are not able to identify, you can send it for PCR also. And increasing dose of topical steroid not a great idea. If you have any doubt, don't hesitate to take the aqueous tap and give intravitreal, intracameral injections. Systemic steroid, they do not take care of infection, but under antibiotic cover, they reduce the inflammation. And intravitreal antibiotics can good result. And vitrectomy, if done in time, especially in fungal endophthalmitis cases with the voriconazole injection, they give you good results. So any unexplained inflammatory reaction following intraocular surgery should be considered endophthalmitis and treat as such even if culture is negative. Thank you.
Very nice presentation, very nice cases, sir. Any questions? Okay, now I'd like to call Dr. Kopal Mittal, and she will be talking about infectious versus non-infectious posterior uveitis.
A very good afternoon. So, well, these cases, where the organisms are just eating up the eye or the tissue so precious which can't be replaced, it's practically emergencies, and we are sharing here our data and our cases and our pictures, and it's so much learning. So, this slide please. So, yes, a quick look at some of the cases where we would like to, ask ourselves at the first instance whether it is infectious, non-infectious, although I would say the flow of thought should always be ruling out infectious cases and then assuming that these are non-infectious, sometimes over-treating them with therapies and specific or non-specific antibacterial or anti-tubercular therapies is a good idea before we assume or rule out the infectious nature of the disease. So why look beyond just using steroids? We first have to think of whether the disease is infective, non-infective, and when it is site-threatening, it sometimes can be bilateral later. It can become recalcitrant, as Dr. Neeraj just pointed out about the fungal cases. And as we know that the eye or the retina or the posterior segment is not a very good site, and there's a poor yield of any samples. And so we have to rely on the clinical signs of each of these entities. Most of these patients sometimes are children, young, and as we know that the disease can be bilaterally blind and it can recur, we have to look beyond. We have to find the organism, we have to fight the disease and control it even if there is no organism. So the critical questions for diagnosis is what level of the eye is affected. That would give us a very important cue of the nature of the disease, the organism, and the course of action on our part. Then the part of the eye which is involved, we all know that we even have to go back to our embryology and think what part of the eye arises where, what is the origin, and if we know that multiple parts of the eye of different origins are being affected, unlikely the disease is going to be autoimmune, it's most likely to be infective, and the organisms are spreading in the eye. Then looking at certain syndromes like the Behçet's or the sympathetic ophthalmitis, where things fall in place looking at the systemic condition of the patient and then take on to a fast course of action to salvage the tissues of the eye. So here are some pictures, all look alike in a fashion, they're just dirty yellow lesions in different parts of the eye. So if we see that, if we try and make out what layers are affected, the deep choroid or the chorioretinitis or the retinitis or fungal looking infiltrate or the optic neuritis and the vitreous involved or the vasculitis, that would give us cues on the nature of the disease and the possibility of the organism involved. So the data available is huge, but each case is unique. So it's good to look very carefully, investigate them with investigative tools also, look at the rare organisms and the rare entities also. So it's quickly sharing a array of cases. So this is a 10-year-old male who came with different staged lesions all in the choroid and also affecting the optic nerve. So when the child was looked at systemically, we did not rush into using steroids, although we wanted to salvage the eyes, but we looked at the child systemically and the child had miliary tuberculosis. And so here what to do is precede your steroids with antitubercular therapy. It's not a good idea to rely only on steroids. It's good to look beyond. Then a very common scenario that we look at, and sometimes it is mistaken for something so innocuous as a CSCR, or we simply go in and dive and give steroids. So a focal retinitis, or I would say a chorioretinitis, and so it's good to investigate these cases. I don't have much of imaging in these cases. So what becomes obvious, the most common cause of a focal retinitis, look at the specific possibility of a parasitic infection or a toxoplasma, give them specific therapy followed by steroids, and the resolution is very, very smooth and a good possibility of salvaging vision. So this was a unifocal retinochoroiditis related to toxoplasma infection. Then another case, this was a dilemma. So this is a case of neuroretinitis with optic neuritis, papillitis. So there was really no cue. If you look carefully, no obvious infiltrate is seen. And the rush to treat these patients with a steroid often is the error, because there is no possibility of any tissue being taken or a sampling being done. The time taken for the blood investigations also lead to loss or the threat to the optic nerve going into atrophy. So what to do is investigate them. Of course, sometimes it's good to offer them even steroids if no specific therapies in mind, but what not to do is a depot steroid. So this was a case treated by a resident at my hospital, and so this is a case which was unfortunately given a depot steroid. So we were following the patients with the blood reports until the time the blood reports came, and although everything was negative, the toxo antibodies were also negative, but the patient post depot steroid within 3 days developed a large neurosensory detachment, rapid fall of vision, although the disc edema had reduced. So then on the hindsight and empirically, patient was giving anti-toxo treatment, and that's when the perineural infiltrate was visible. So this was a parasitic infection. The mistake was to give a depot steroid. So it's good to investigate them before diving into steroids, and particularly depot steroids which cannot be taken outside the eye should not be offered at the FERTCO before we offer them specific therapy. So yes, again the talk of what Dr. Neeraj has talked about, the fungal endophthalmitis, which may be endogenous, where the patient has received multiple intravenous somewhere, maybe, or the patient is systemically ill or immunocompromised. So it's these cases which we have to wait before giving in any steroids. We have to sample them, go in, take out biopsies, or do diagnostic and therapeutic vitrectomies, find the organism, hit them with good ample fungal antifungals. Sometimes, as he said, every second day, alternating voriconazole and amphotericin, as the half-life of antifungals inside the eyes are very short, and stay away from steroids as much as possible. Sometimes as high as 50% we lose these eyes because of the hesitation of losing steroids, but the way to stop them from becoming recalcitrant is to get them free of fungus first with adequate antifungal cover, then go on to steroids in a very subtle fashion. So yes, the very non-specific, not so common is the para-infectious necrotizing retinitis. This particularly is seen very commonly in children. The infections can be any. It can be a streptococcal pneumonitis, it can be a typhoid, it can be a dengue, it can be COVID, it can be anything. Sometimes along with the retina necrotizing retinitis, we see perivascular angiitis, and that is very common currently. The scenario of the dengue epidemic happened. So there, specific antibiotics have usually been introduced by physicians. We just have to investigate them further, make sure that the specific antibiotics are in place, or extend the cover with steroids to salvage the ocular tissue, and the results are extremely good. Then the viral retinitis, be it with immunocompromised or competent patients, diseases like ARN, PORN, so these are almost always infective. Of course, the inflammation incited is so high, after adequate antiviral cover, these patients need steroids and salvaging the retina also back, because most of them are necrotizing. Then looking at the other spectrum, where we've offered them adequate cover, anti-tubercular, everything. So these are the cases which go on needing steroids. We have to keep fighting, like the sarcoidosis spectrum, the IOID, where the choroiditis keeps happening and it's recalcitrant, the VKH, the Behçet's scleritis. So these are the cases which are steroids responsive but steroid dependent. Herein comes the immunosuppressants, like this particular case we fought over 2 years with mycophenolate and salvaging, keeping the vision 6/6 after 3 episodes. Then another case, young girl, with a family history, the father also had a similar kind of disease. So these kinds of cases do also occur where they are steroid responsive but steroid dependent. So we have to use steroid sparing drugs. So I have a good series of 9 cases. I've been treating them for last 4 to 9 years, and they are all on immunosuppressants and safe. So looking at the whole spectrum, the takeaway message is rule out infective nature, and after a good specific cover to salvage the eye and its tissues, you'd add adequate steroids as well as steroid sparing drugs were required.
Thank you, Dr. Gopal. That was a wonderful presentation, a plethora of cases. I think we'll take the questions still later. And may I please call upon Dr. Ravinder Mali for her presentation on posterior scleritis.
Yes. Good afternoon. First of all, I want to thank the organizers and especially Dr. Saurav Luthra for inviting me to this wonderful conference. All the cases presented had been very good. All the talks are very informative. So I'll be talking about posterior scleritis, which sometimes, many times act like a great mimicker. So all of you are conversant with scleritis, mostly which present as anterior scleritis with various forms, but the posterior scleritis is the one where the actual diagnostic challenge lies. So it is rare, I will not call it rare, it is a little uncommon but potentially vision threatening condition, and often remains underdiagnosed due to varied presentations. And in this, there is painful inflammation of the sclera posterior to equator, and mostly seen in middle-aged females, accounts for 10% of all scleritis cases. But 50% of these cases have associated systemic disease in the form of can be collagen vascular disorders like rheumatoid arthritis, SLE, Wegener's, and could be sarcoidosis, psoriasis. There could be infective cases like TB, viral, as well as syphilis. So many of these cases present with ocular problem first, but we have to take out history in the form of joint pains and other areas which can be involved. So symptom which is the most important one to diagnose is hallmark is deep severe ache. Patients generally present with severe pain, and most of these patients give history that they have to wake up during night because of pain. So this single factor has been common in all my patients. In some patients, 10% of the posterior scleritis can present with even without pain also. Other features are tenderness, and there could be referred pain, there could be diplopia and orbital signs in the form of ptosis, proptosis, and problem in ocular motility, and vision can be affected depending on the location, and IOP is high in many of these cases. So signs, most important is to look for redness of sclera beyond the interior part, and for that you have to look after lifting the lid and ask the patient to see in all gazes. There could be discomfort on mobility and extraocular movement restriction. There could be anterior segment involvement also in some of these patients, and fundus picture will depend whether there is involvement of disc and associated retinal detachment and choroidal effusion. So workup will need to be done to rule out infective causes first, like TB, syphilis and viral, and other collagen vascular diseases. Workup need to be complete. The most important feature of diagnosing posterior scleritis is imaging on B scan. This is one of the, I would say, the main indication of B scan in present day ophthalmology, where we depend on OCT many a times, but this gives us this T sign, which is pathognomonic of posterior scleritis, where you find fluid in the posterior subtenon space, which is going around the globe and around the optic nerve, giving the shape of a T. There could be incomplete T sign also. So I'll be now taking out discussing some cases. This is the first case who presented. This patient was a 42-year-old female, presented with pain lasting for the last 2 years, with the redness, which was she was never free of redness for the last 2 years, although have been treated with inadequate doses of steroids at various places. And then on presentation she had diffuse redness of anterior sclera, as well as going beyond. You can see when we ask the patient to look in extreme gaze, you can see the redness is involving the posterior sclera as well. And on fundus you can see an amelanotic mass like lesion in the inferior temporal area in the right eye, along with subretinal blood hemorrhage in the inferior nasal periphery. This is the left eye, which is more, and the lesion is more prominent. You can see when we ask the patient to look down, upper nasal part is having severe redness, and just inside that on the fundus in the periphery you can see this amelanotic mass like lesion, which is actually the involvement of sclera with associated choroidal detachment and choroidal involvement and the serous detachment. Now you can see the B scan is giving us the true picture. You can see there is boggy swelling of all the layers, all the ocular coats, with subretinal subtenon fluid in both eyes. And this was the angiographic picture showing irregular hyperpinpoint hyperfluorescence, which increased in the later phases in the area of serous RD. And on investigations, this patient was found out to have positive for ANCA and diagnosed to have granulomatous polyangiitis, and rheumatology consultation was taken and was advised, although we started on oral steroids first and she started responding, but as these patients need long-term treatment and she had severe involvement, so she was advised biologics, but she was not willing because of non-affording, and was treated with IV cyclophosphamide and endoxin 5 cycles. And there is dramatic recovery after starting this treatment, and you can see in both eyes within a month there is improvement, and whole of the scleritis lesions have resolved. At now she has completed almost 3 years on follow-up, and she is doing well without any recurrence. This is my second case. You can see 35-year-old female with the lesion in the posterior pole, which is having a small hemorrhage in the center, which is looking like a tubercular granuloma, but on investigations on OCT you can see the elevation, and on B scan I could find some mild fluid in the subtenon space. This B scan is not very clear. This is angiography, and these are the DDs in such a case. It can be tubercular granuloma or sarcoid, which is less common. It could be subretinal abscess or subretinal cysticercosis or some masquerade. But on investigations, all the infective causes were negative, and she was having positive ACE levels, high ACE levels, and CT chest was normal as well as X-ray was normal, and she was treated with steroids followed by remarkable recovery, and we added azathioprine because of the to decrease the recurrences, and this was a follow-up over a period of 1 year. This is a case 3. Again, you can see there is peripheral.
Dr. Ravinder, can you just
sum up? So I'll summarize. This is a posterior plaque-like involvement of the posterior pole, and you can see the yellow lesion with serous RD, very clear angiographic picture, pinpoint hyperfluorescence, and she was found out to have positive for rheumatoid arthritis and was treated with immunosuppression, followed by a remarkable recovery. Another patient of having limited area of elevation inferiorly, like a mass-like lesion, and fluid again in the subtenon space, and was treated with immunosuppression as well as steroids with improvement, and no cause was found in this patient. Now this is one of the last patients, and this patient presented after a flu-like illness, acute viral illness with fever followed by multiple lesions with severe pain, and on B scan you can see there is marked fluid in the subtenon space, which clinched the diagnosis in this patient. This was most probably post-viral, again treated with steroids and with remarkable recovery. And one of these 2 last cases are having tubercular uveitis, tubercular posterior uveitis with associated scleritis. So they were given ATT along with steroids. So take home message is to have careful examination and detailed history, and timely treatment. After giving timely treatment, they have most of these patients have very good prognosis. Thank you.
Thank you, Dr. Ravinder. That was a wonderful presentation. May I please call upon Dr. Renu Dasmana for her presentation? I think she's not there, and in that case, I'll call upon myself for my last one.
Please.
So at the outset, thanking the Uttaranchal Society and Dr. Saurabh. And today I'll be speaking about the newer advances in retinopathy of prematurity. ROP, we all know, is one of the leading causes of preventable blindness in infants and children. And with the ongoing advances in technology and medical field, ROP has been affected dually. On one side, we are seeing more and more number of tinier babies being saved by the pediatricians, and thus facing a bigger epidemic of the third epidemic of ROP actually. And in India, we have the highest number of premature births. So we are facing the biggest brunt of the third epidemic of ROP here. And if not treated in time, these babies are pushed to a lifetime of darkness and a social and economic burden on the society. At the same time, with this, these advancements, we are also bracing ourselves for a better dealing with this scenario of the storm of ROP that is coming across. These are the few newer advances in ROP, which I'll be taking up one after the other. The ICROP was first published in 1984 and thereafter has been expanded year after later, but the latest revision was made in 2021. So the zones, clock hours and stages we are all aware of. The newer terminologies added were the plus disease spectrum, posterior zone 2, notch, AROP, regression and reactivation. And the stages we all know, stage 1, 2, 3, I would just rush through this and I'll just be focusing on the newer terminologies. The posterior zone 2, we all know that the junction of zone 1 and 2 has always been a more severe disease, but now it has been printed on papers that it is posterior zone 2, which is a 2 disc diameter area around the outer border of zone 1, and any disease present in this area is definitely a more severe disease. Likewise, notch is an intrusion of ROP lesion of 1 to 2 clock hours along the horizontal meridian, and the posterior most extent of this lesion, in which zone it lies, decides the severity of the disease. The plus disease has classically been known as the posterior engorgement and tortuosity of the arteries and the veins, but the ICROP called it a plus disease spectrum, incorporating the iris vessel engorgement, pupillary rigidity and vitreous haze to it. In 2005, the ICROP gave a terminology called aggressive posterior ROP, which they said was a disease in zone 1 in patients with very low birth weight or gestational age of less than 30 weeks. And this disease characteristically progresses very rapidly to severe forms of ROP and RD. And but ICROP3 retermed it as aggressive ROP. They took off the posterior part from that because in especially low and middle income countries like ours, we have larger babies having aggressive ROP, and this ROP may necessarily not be there in only the posterior zone. This may even be in the anterior zone. Thus, to emphasize on the severity and speed of progression of this disease, it was called aggressive ROP. The various diagnostic criteria are presence of abnormal vessels in zone 1 and posterior zone 2, dilated tortuous vessels, closed loop shuntings, these tongue-like lesions that you can see here, and with or without vitreous haze, rubeosis iridosis, or neovascularization. So this disease can progress very, very rapidly without going through the classical stages of the disease within 4 to 7 days, and that is why it is important the emphasis is laid on this. This is a case of aggressive ROP. You can see the baby had the disease only in the posterior pole in zone 1 and 2, and was treated with anti-VEGF followed by laser after 3 weeks, and the baby is doing well with normalization of all the plus component. Sorry. This is another case, a twin 2. These were 2 girls from Haryana. The twin 2 had this aggressive ROP, characteristic tongue-like lesions, and also had stage 3 in zone 2. This baby we gave anti-VEGF and took up the baby a little earlier and for an aggressive laser because the parents had almost given up on the child. So we had to do our best to save. They were totally physically and emotionally drained. They didn't want to come back for many follow-ups. So the crux of it is the most important key factor here is timely screening. As Dr. Subhadra Jalali always says, tees din roshni ke. So the first screening should happen within the 30th day of life because there's a very narrow window of opportunity to avoid lifetime of blindness for these children. In India now there are stricter guidelines that every child who is less than or equal to 35 weeks of gestational age and less than 2 kgs must be screened for ROP. And likewise in developed countries they are facing another challenge of having micro preemies, babies who are less than 750 grams and less than 26 weeks of gestational age. These babies are much more prone to develop aggressive disease, and thus for them the screening must be done at the 3rd week of life earliest. And they need more closer follow-ups, and a B scan may be needed for poor dilating pupils or vitreous haze. So imaging, we've been talking about imaging from the beginning of this session, and it has definitely played a major role in all our retina pathologies. Wide field imaging systems, whether contact or non-contact, does bring about a big difference in ROP because we are able to reach out to the areas which are difficult to reach, and the babies who otherwise would have been lost are at least being saved. At our center we have Forus, which the staff can go to the NICUs, retrieve the pictures, and then later the treatment can be done. Likewise, I find these fundus pictures very, very helpful because these parents of these babies are emotionally and physically drained and economically drained, and they do not want to spend on the disease. They are in a total denial. For them to understand what is happening in the baby's eye give them the whole perspective right, and they are willing for treatment, and they're also able to see the response and makes them happier and better convinced. The wide field angiography and OCT have come in very critical cases or very atypical cases where we can detect the preclinical findings, and the deceptively featureless retina can be picked up with these investigation modalities and prognosticated, monitored, and managed better. Laser photocoagulation, of course, now is the mainstay of treatment for many of us still, but the anti-VEGFs have really revolutionized the outcome and the whole, this disease. And of course, vitrectomy still stays there for the stage 5A and 4B diseases.
So with anti-VEGFs, though the regression is much faster, the disease responds much better, the myopia is much less, it's easy to give, no trauma to the baby, but there's a flip side to it also. There may be incomplete regression happening in babies who are on anti-VEGFs only, monotherapy. So we have to look out for these persistent avascular retina areas and keep them on a closer follow-up, and the treatment may be needed as and when needed. Likewise, reactivation is also much more commoner in anti-VEGF monotherapy patients. They may also be seen in post-laser babies in which there are skip areas, and the reactivation may even happen up till 60th week of gestational age. So we have to be on a lookout, especially on babies who are on anti-VEGF monotherapy, and have to be treated if the baby is growing bigger or the compliance is an issue. So I'll just summarize the classification, newer classifications, the screening criteria, the imaging modalities are making our understanding of this disease much better, and we are able to save the vision for these tiny babies. And of course, anti-VEGF monotherapy has to be taken with a pinch of salt. If compliance is an issue or the babies are growing bigger, then laser does come as a salvage. Thank you.
Thank you, Dr. Charu. Wonderful presentation, comprehensively covered. All aspects are covered. And you have rightly pointed out anti-VEGF monotherapy is not the solution. It has to be supplemented with laser photocoagulation to reduce the number of follow-ups what the baby requires, and to reduce the chances of reactivation of the disease.
Totally agree, sir. Yes, sir.
Yeah, very nice.
Thank you, sir.
Anybody? Okay. Thank you very much.
I think with this, we close this session. It was an interesting session. I think for the first time, I'm seeing so many people sitting in retina session. Thank you very much. Thanks.
Now we'll move on to the next session, which is the anti-VEGF conundrum, demystified. So this will be an interesting session about the anti-VEGFs and the newer anti-VEGFs and the biosimilars. So first we have Dr. Manisha Agrawal. She is a renowned retina surgeon heading the retina department in Soft Charitable Eye Hospital, New Delhi, and she needs no introduction. So she'll be talking about the comparative analysis of anti-VEGF protocol T and real-world experience.
A very good afternoon to all of you, and at the outset I want to thank Dr. Saurabh Luthra, Uttara Eyecon, and Bear for giving me the opportunity to speak on this topic of comparative analysis of anti-VEGFs, protocol T, and the real-world evidences. Now, we all know that anti-VEGFs is the mainstay of treatment for diabetic macular edema, and a few years back when anti-VEGFs were not introduced, apparently laser was the mainstay. So why anti-VEGFs over laser treatment would be because they cause a sustained visual acuity gain which is far more superior in comparison to a laser treatment for diabetic macular edema. And we have several studies including the Protocol I, the Reveal, the Restore and the Response study which have beyond doubt told us that anti-VEGFs are far more superior to laser for the management of diabetic macular edema. So once we are convinced that anti-VEGFs are superior to laser, the question arises that which anti-VEGF to use. And does it really matter which one to use? Well, first we should understand what is an ideal anti-VEGF. So an ideal anti-VEGF would be the one where least number of injections are required with maximum efficacy, less frequent visit to our clinics are required, less need to switch to another drug, and least risk of side effects after giving any anti-VEGF. Now let's come to the protocol T, and basically protocol T was a head-to-on trial which compared 3 anti-VEGF drugs for the management of diabetic macular edema, and these included aflibercept, bevacizumab and ranibizumab, which were given, and the patients were randomized equally in all the 3 groups. So when we compared all the 3 groups, it was very apparent that greater visual acuity gains were seen in the patients who were treated with aflibercept in comparison to those who were treated with Avastin or with eccentrics in year 1. And this was a very significant change that was seen in year 1. But when we went on to compare the results in year 2, the results which were got with aflibercept and with ranibizumab, they were comparable, while the results which were got by Avastin were far more inferior in comparison to ranibizumab and aflibercept. Aflibercept also was associated with a very rapid and a robust anatomical change, and that was found to be superior in comparison to the other 2 drugs, and this was found to be maintained even at the end of year 2. A subgroup analysis was done, and it was analyzed how did the patients with baseline visual acuity less than 20/40, how did these patients react or respond to an anti-VEGF treatment. And this subgroup analysis showed that at year 1, a significantly greater mean visual acuity gain was achieved in those patients who were treated with aflibercept in comparison to those who were treated with ranibizumab or with Avastin. So definitely there is a role of treating these patients of diabetic macular edema who are having a vision less than 20/40 with aflibercept, which apparently behaves much more superior in comparison to the other 2 drugs. But when we were to see the other group where the visual acuity was better than 20/40, there was hardly any difference between the 3 drugs. At year 2, significantly greater mean visual acuity gain was achieved again with aflibercept in comparison to Avastin in patients with baseline vision less than 20/40. So this effect of aflibercept in patients with vision less than 20/40 apparently did remain very consistent even at the end of year 2. And that is where the advantage of using aflibercept lies in comparison to the other 2 anti-VEGF drugs. Now why aflibercept? So if we are saying that at the end of year 2, all the 3 drugs were comparable, then why choose aflibercept? So if aflibercept is superior to ranibizumab at 1 year, but not at 2 years, then why still consider using aflibercept, which is more expensive, rather than using ranibizumab or Avastin? Well, the questions are that are these changes at year 1 or 2 years clinically significant? How can we achieve these excellent outcomes? When to switch to any other drug? And what are the real world evidences? We must understand this concept of area under the curve, and this is important because the area under the curve is going to tell us why it is important to start using aflibercept in these patients in comparison to the other 2 drugs. So what exactly is the area under the curve? Area under the curve basically tells us what is the mean visual acuity gain over a sustained period of 2 years, and also that the visual acuity gain is much faster at every visit in those patients who were treated with aflibercept. So if you see that the area under the curve was the largest for the patients treated with aflibercept, that means that the visual acuity gain is going to be much faster at every visit when the patient comes back to you. At the end of 2 years when you compare, the difference is hardly going to be there. But it is important that the patient is going to be much more happier if the patient is going to be gaining much more vision at every visit in comparison to ranibizumab or to Avastin. So this concept of area under the curve is very important, and also we need to understand that the patients with vision less than 20/40 apparently do much better with aflibercept in comparison to the other anti-VEGFs. Now comparing the proportion of patients who are requiring a laser treatment also showed that the patients who were treated with aflibercept required much lesser secondary additional treatment with laser in comparison to Avastin and ranibizumab. So that is again an additional benefit of treating the patients of DME with aflibercept in comparison to the other anti-VEGFs. A post-hoc analysis was also done of eyes with DME and NPDR at baseline, and they experienced improvements in diabetic retinopathy severity. So we all need to have an understanding that now the talk is that anti-VEGFs can actually cause a reversal of the disease process and may actually reverse the changes which have happened in the fundus. So that is where the concept is that if you are treating these patients with aflibercept, even the severity of the disease process can reduce at the end of 1 year or at the end of 2nd year when we are treating them with anti-VEGFs. And if you compare the 3 anti-VEGFs, probably aflibercept does much better in comparison to the other 2 anti-VEGFs when we were to compare the results. So the decrease in the severity of the disease process was much more in the patients treated with aflibercept. Now DRCR net and anti-VEGF treatment regimen tells us that we have to strive to optimize the treatment outcomes for DME patients. And how can this be done? We have to use 6 monthly injections unless the patient gains a vision of 20/20 or the OCT becomes normal. And after that has been achieved, then we have to continue the anti-VEGFs only if there is an increase in the thickness or the visual acuity is going to decrease. Otherwise, we can just observe the patient on a regular basis. Now, this is an 80-year-old gentleman patient of mine who has a diabetes and hypertension for last 40 years. He's also a known patient of primary open-angle glaucoma, already treated with a number of anti-VEGF injections elsewhere. The vision is, if you compare, the vision is pretty good in both the eyes. If you see the left eye, the vision was 624 N18 in the left eye, and I started treating this patient with Eylea, and after 1 month you see that the vision has improved to 618 N12, and subsequently after I've treated this patient regularly with the anti-VEGF aflibercept, the normal foveal contour has been achieved and the patient has gained a vision of 69 N6. Another post-hoc analysis showed that the prevalence of eyes with persistent DME, these are the patients who were again evaluated, and it showed that again the aflibercept scored over the other anti-VEGF injections in those patients who had a persistent DME, and that is another advantage we get in comparison to other anti-VEGFs. When we don't get the response expected from an anti-VEGF, you please go back to your patient and see if the patient is compliant with the treatment. There is no vitreoretinal interface problem. There is no pharmacological resistance. If you've been treating the patient with an anti-VEGF on a very regular basis, there could be a kind of a resistance which could be developing. And also we should be considering that probably the inflammatory pathway may be playing a more important role than the VEGF pathway. When to switch? It's important for us to know when to switch to steroids. Inflammatory markers, there are defined markers of inflammation on OCT. If you find them more, probably it's time to switch to a steroid. Pseudophakic patients, again you can think of considering to treat them with steroids. Pseudophakic patients, vitrectomized eyes, again they do much better with Ozurdex rather than with anti-VEGF because the washout of the VEGF drugs, anti-VEGF drugs is much faster. And if you have patients with a lot of hard exudates, they apparently do much better with steroids in comparison to anti-VEGF. I'll briefly touch upon the real world evidences which are there. So there are certain expert guidelines which have been issued from Asia, which very definitely tells us that anti-VEGF treatment is far more superior than laser therapy for DME management. EURETINA guidelines have also shown that the use of ranibizumab for patients with poorer baseline visual acuity will most likely result in the same visual acuity results after 2 years of treatment with aflibercept, but the effect reached is slightly slower. So if you start treating these patients with aflibercept, probably the visual gain is going to happen much faster, though the ultimate visual gain can be the same. I'll just skip this, and we also have the FRB registry, which again shows that the patients with vision less than 20/40, they apparently do much better with aflibercept in comparison to other anti-VEGF drugs. A meta-analysis is said to be the most important evidence-based evidence for any one of us as clinicians to follow, and the Cochrane meta-analysis again shows that aflibercept does much better in patients with vision less than 20/40 in comparison to the other anti-VEGF drugs. So I'll just conclude by my talk by saying that anti-VEGFs are the first line of treatment for center involving DME. Early intensive treatment of DME in the first year leads to meaningful vision gain that can be maintained in the long term with a reduced treatment burden. All the anti-VEGF drugs are comparable in patients with 20/40 or better vision, but aflibercept is the treatment of choice for patients with a baseline vision of less than 69 letters, that is equal to a Snellen's of less than 20/40, as demonstrated by Protocol T trial and also supported by a number of real-world evidences that I just showed in my previous slides. So thank you so much for your patient listening.
Thank you, ma'am. It was a nice presentation for aflibercept, I will say. Everybody has gone through the thing. Any questions in the DAC? Thank you very much.
Thank you so much.
I will invite Dr. R.P. Singh sir for his presentation.
Good afternoon, and thank you UKSOS, Dr. Saurav and the team for inviting me for this talk. And as ma'am has nicely said that the aflibercept and the many anti-VEGFs, they are the need of hour for the various eyes which will go otherwise blind. But this is an established fact now over the past 1.5 decades that angiogenesis and the inflammation are involved in the development of and the progression of the disease like DR, retinal vein occlusion, wet AMD, all the diseases. So that is the basic fact. And we all know that NAMD is the major cause of blindness in the developed world. Almost 50% of the blind are because of the NAMD, wet AMD, followed by the diabetic retinopathy in the above age group of 60. And when we talk about the Indian market now, of the population of 1.25 crore, 25 crores, we are dealing with a huge amount of patients and the financial burden for us, for the country. And the country like us, which is so big and have most not that as developed like others, the economy is not as good. People, they fail to follow the treatment because of the poor financial condition. And the facts are like still the 18 to 20% of the population is still below the poverty line, and they cannot afford the Eylea kind of treatment. So we have to look for the alternative which is affordable, cheaper, and every person can get the treatment at least at some cost. And now this is the load of patient which we are dealing with, almost 13.6 lakhs patient of wet AMD, almost 70 lakhs, and we are the world's capital of the diabetes, we all know that. And the major cause of the compliance is because of the high cost involved into the treatment. And now when we talk about any protocol, whether we are DCR-NET or any protocols we are talking, and any disease, like say it is DME, it is PDR, whether it is NAMD, more or less the protocol is same now. It is not on the PN basis, it is still the continuation of the injections, whether it's 3 or 4, 5, 6 or 8, till you get the complete resolution of the disease, visual improvement to the maximum, and then the stabilization dose. So it is not that the end of the treatment, after that still you need to continue with the treatment. So there is a need to build on the successes in the care of retinal, vascular and proliferative disease and continually innovate to prevent the blindness. So the ultimate aim is to provide the service to the all people, not to the select ones, so that we can eliminate the blindness factor from the world. That is what we aim as an ophthalmologist. Because earlier what we had, pre-1980, vision loss because there is no treatment. Then later on we have the laser treatment, in which we always to say we are going to halt the progression of the disease. And then we started talking about the improvement of the vision as well as the reversing the disease. At present, we are not talking about that. We know that we are going to stop the disease, but we are going to optimize the treatment. And what is the optimization? Optimization is not only, as ma'am has said in one slide, that it has to be a good compliance, improvement of the vision, less frequent visit to the doctors, as well as the less cost involved into the patient and the long-term solution. So this is the optimization actually, and that is now any forum we are talking about the optimization of the treatment to the patient. Now, we all know the approved anti-VEGFs in the ophthalmology. We are there. Earlier the Macugen came in 2005, new generation may not know about it, but it went out of work very soon. Then we have the ranibizumab, which was developed in 2006, and the various indication like wet AMD, DR, macular edema because of rain occlusion, and myopic. This was the indication it was using for in the initially 2006, and then aflibercept came in 2011, and that has a bit. Now the difference between the aflibercept and the ranibizumab, the other Avastin and the anti-VEGF is basically the aflibercept is the only one which is the broad spectrum anti-VEGF, which attacks the all forms of VEGF-A, VEGF-B and all other factors, whereas the other ones they are limited only to the VEGF-A factors. So that's why it shows much higher results affinity as compared to the other anti-VEGF which are available. So it of course has the select group of patients in which it does wonders, and so is the boluzumab which was introduced in 2019. So we have the wide spectrum of anti-VEGF available, and we can choose according to the patient requirement, whether I am dealing with the IPCV or the severe form of subretinal hemorrhage, or a severe macular edema in the like a CRVO with the 600 and above, where you want to give a good response initially and then to take on to the anti-VEGF. So of course then you need a better, then the cost factor doesn't come into the play, there comes into the play which is the best for the patient. But by and large we are dealing with the volume of the patient which consists of the diabetics or the RVOs or the DMEs. So there the choice of the anti-VEGF can be anything which gives the response, and any anti-VEGF is there which gives the response, with no doubt about that. And now there's so many various data and the studies in the US which is conducted that the level of blindness has gone down by 50 to 72%. The various studies has now showed that by the good with protocol use of this medicines, the actual rate of blindness is going down, because in the developed countries most of the patients are covered with the insurance, which is not in the fact true in the or the other developing conditions like the South African countries, African countries, the developing countries. But in Western world, they are covered with the insurance, and now the data is coming very positive that there is a reduction in the blindness by almost 50 to 72%. But that is not the case in here, what you are talking about. And like various studies have shown, if you give the continuous doses, there is a significant improvement of the vision as well as the reduction in the stabilization of the disease. So what are the biologics? These are the anti-VEGFs targeting the disease, reversing the disease pattern, but what is happening? It is at the same time putting a huge financial burden on the healthcare system. In 2019, the US had the budget of almost $54 billion. Out of that, $11 billion was taken up by the anti-VEGFs, by the ophthalmologists. So that is the amount of financial burden, and now the Indian government is also covering most of the patient into the insurance factors, and you will find under 2 years that the whole entire budget of the government is gone into the anti-VEGFs. And that is the visual gain, and now this is giving is the high expectation of the patient. So what we need an alternative. So is the biosimilar is the alternative to that? More or less that has been going into that, and now to the ranibizumab we have the biosimilars, various biosimilars available to us. Almost more than 1 million people have been injected with that, 10 million people have been injected, and the safety pattern and the efficacy is all we have observed. And I think very soon the biosimilar to the aflibercept is, because the patent is going to over in a year, and we are going to get the biosimilars for the aflibercept and the other drugs as well. So what are they? They are basically not the innovator molecule, they are the near identical copies of that. So we cannot say they are the exact biological material, but they are the near identical copy. But there is a difference. In the innovator, if something goes wrong into the same bacteria where they are developing, the whole batch can go wrong. But in the biosimilars, that is not the possibility, because it is based on the DNA recombinant technology. So the chances of error are much less in that. and they have the potential to reduce the treatment cost factor almost about 30%. So the advantage of the innovator is they are the treating the respective disease, but biosimilar they lower the drug cost. There is a global coalition of regulators in the world, various countries has involved, and now they have shown the confidence in the biosimilars, and now they have also started pitching to go for the biosimilars instead of the innovator drugs, because as long as the efficacy parameter is concerned, that is. Because why biosimilar? Because the most of the health authorities has now moving towards, the only reason is to lower the price and at the same time maintain the same efficacy. And since India is a developing country and very few people are covered with the health insurance and the government sectors, so almost 70% of the Indian population they pay from their own pocket, and there is the one we need to have the biosimilar. So the various biosimilars now in India which are available, we all know that these are the like Vizumab, Ecentrix, which is there. So if you compare the cost, there is almost a 30%. This is the actual MRP cost of the different biosimilars which are available, and price to a doctor is little different. So if you say in the actual terms of the financial cost, it will almost reduce between 30% to 50% of the financial cost is reduced by this. So if you see the Eylea, which is costing almost 56,000 as compared to, but of course the indications are different. Like the ma'am what I have shown, they are the selected. Now we have to choose the patient that what exactly, which anti-VEGF he needs. And second comes the cost factor actually. The first priority always remains that what the actually patient chooses. Now there is another study which is carried out in the United States, which shows in 10 years, the total budget of the US will go into $54 billion, which is almost half the budget of the Indian economy actually. So how do we select? The selection of the biosimilar will be based on that is the therapeutic cost, the affordability which continue to remain, the patient going to remain compliant, the shelf life of the biosimilar so that when it is transported, the shelf life is there and it is effective, the cold chain has to be maintained, and increase the patient compliance. At the same time, we need more publications, authentic data from the biosimilars so that we are safe to give them into the various patients. So now the various studies has also been conducted, like Resumab, we also the part of the next study, Dr. Chadu remember that we were the first one to start that in 2013, and now the phase 3 trials has been complete and almost more than 10 million vials of dose has been injected worldwide. In fact, the Resumab was the first biosimilar in the world. So we can be very proud of us that that is our Indian company which is actually showed to the world the way to the biosimilars and to reduce the cost of the, and this is the, and if you see the composition of it, it is almost similar to the ranibizumab, the same molecular weight of 48 kilodalton, and it is sourced from the recombinant DNA technology in the E. coli. So the efficacy and the effectivity has been proven over the various setups. And if you compare the cost, it costs about $125 as compared to the $320 and $760 of Eylea, with the maintaining with the same efficacy. Thank you very much.
So thank you very much for such an elaborative talk on biosimilars.
Just
basically.
an insight.
But it was very much into economy of the country. That
See,
was
as a
more
doctor,
concerned.
we always have to see. I personally feel that this is the duty of a doctor to look at the overall profile of the patient and give him the treatment. If you don't look at that, his background, he might take one injection. I remember the days when I was giving the PDTs and the Lucentis, and it was costing 75,000, 1 lakh, and people used to sell their houses and come to us to give that injection. And so, you know, if you person lose his livelihood, what he will do with the vision?
So I have witnessed those cases with you.
Yeah, it is that. So, as a doctor, we have a responsibility to choose the, because the patient is always relying on the doctor to choose the treatment for him. So we should be looking over the overall aspect of the patient rather than only at the disease. That is what
So I think at the end of the day, we all want a good compliance.
Correct.
And for compliance, affordability is a very important factor.
Yes.
So I totally agree that, you know, but having said that, if the affordability is there, then we have to make a choice.
Yeah, I made the statement like that. My always the first choice is is the best for the patient, which drug, and then second comes the cost. If the patient can affordable and this disease demands that molecule, it should be given. But only because you are adamant that no, I want to give you the cheapest and the best, no, that should not be the case. Yes, because aflibercept and Pagenex, they have this now set indications of the patient, which we are going to now slowly discuss in the forums, that these are the indications, you should go for this, and this are indication, you should go for this.
Thank you, sir. Thank you very much. I invite Dr. Amit Arora for intravitreal injections in DME and how to go about.
At the outset, I would like to thank the Uttara Eyecon Society and Dr. Saurav for inviting me. My job has been done easy by previous two speakers. Mostly the topics are covered. I'll just highlight few points. See, incidence, as told by Dr. RP, we are number 1, 10 crore plus. It's a huge number. 1 in 10 is diabetic. So all around, see in the hall, we must be diabetic above 50, 60. Diabetes is like epidemic. And mind you, pre-diabetics are 13 crore, which will turn to diabetics in next 4 to 5 years, which is a huge number. And DM incidence being 5 to 6%, so it's more than 60 lakh. So I think it's really huge. So risk factors, I need not go into details: sugar, blood pressure, lipidemia, nephropathy, anemia. Anemia we have to look purposefully if it's not treated well. Treatment, first the systemic control, it's very important. And this is the harsh reality. The intravitreal injection is the most frequently performed eye procedure in the world. So cataract is being surpassed by us. So simple classification, DME we should follow for the injections. It's a center involving or non-center involving. So anti-VEGF is the gold standard for the DME. First came the bevacizumab, but it was off-label, fell into dispute, but still people are giving in Punjab and all. So it's in compounding pharmacies, but you don't stand in the court of law. But it's cheaper option, but we have to have the reality, as Dr. RP said. If the patient can't afford, if we can have the drug in 4 to 5,000, I think it's still we are preventing blindness. So it's the hard reality in India. So second came the ranibizumab, eccentrics, it's the gold standard. FDA is 2006. Single dose vial, we have to dry the macula. It works very good. Then came aflibercept, Eylea 2012, equally or better as given by the Dr. Manisha, the trial. It's better, little better, but real world I find it is similar. Like personal experience, it is similar. Then came brolucizumab, Pagenex. So in this, the compliance is better because it's a 8 weekly dosing. So if the patient can afford, I think this is the way to go next. So it's a smaller molecule, so penetration is better, the efficacy is better. And studies have shown similar results with Eylea as compared to with brolucizumab, and the aflibercept is similar. The safety profile as done by Indian our study, which is a beautiful study done by the Indian retina surgeons. The incidence of intraocular inflammation is less than 2%, but the Western studies, they had given 4%, so it was a little scary. So we can go ahead with the new drug and it's very safe. And the good part is the 2 monthly dosing, which compliance, if the patient is from far off and he can afford, I think this is the drug to go. This is a new drug in the Western market, Vabysmo. It works in the twin pathway, approved in 2022 FDA. So it's coming to Indian market. And the good part will be it's a 12 to 16 weekly dosing. So if you reduce the intervals, then the compliance is better, if the cost is not an issue. And the studies have shown, like the Yosemite and the Rhine study, the efficacy of faricimab 16 weekly dosing is comparable to the Eylea. The next a new drug, new kid in the block is Eylea HD. It has recently got approved in August 2023, and the good part will be a 16 weekly or 20 weekly dosing. So patient doesn't have to come back every month, which is a huge respite for compliance if the patient is very ill and he can't come in every month, so it's good to give this drug. So disadvantage is, yes, we are not reached the goal. Effect goes off in 1 to 2 months. We are not curing it. Definitely the expense, as told by Dr. RP, is very high. Half of the budget of like health budget, it's alarming actually. And 1 month we are back at the same stage. Compliance definitely fall off. So counseling is very important. When you are starting a anti-VEGF, you have to give 5 to 10 minutes. See boss, you have to have, it's a long haul. First year will be hard, 8 to 10 injections. Then second year might be you come down to 4 or 5 injections, and then treat an extent type of situation when if the vision or the OCT goes down, then you have to inject again. Next, if the anti-VEGFs fail, we have second line, but first line, yes, a recent onset MI or stroke you have to give, vitrectomized eyes, yes. Chronic DMEs, they do respond. If it is like a patient has not turned up, he didn't know, especially if one eye is normal, patients sometimes turn up with a chronic DME in the other eye. So that's a good candidate to give a shot of Ozurdex. But do look for like IOP responders. So I usually give predecetate drops initially, or other eye pseudophakia, you are assured that he is not a steroid responder. So check for steroid responding, it is very important in Ozurdex. So when to switch, less than 10% reduction is the benchmark. If after minimum 2 injections, the OCT, it is less than 10 microns, like 10% microns, then you have to switch. Look for recurrence, especially in cases like uncontrolled diabetics. Yes, biosimilar is the way to go. If you can't afford, then switch over to a biosimilar. Again, look for metabolic control. Non-responders, back to physician, handhold the patient to physician. Do look for like anemia, it is very important. Sometimes you're giving injection is still not controlled. Especially if the vision is not corresponding, look for ischemia, do an FFA. So this is the road we have traveled so far. This is the treatment algorithm to summarize. If it's a center involving DME, go for anti-VEGF. Non-responder after 2 doses, switch to Eylea or Pagenex. And if like contraindicated cases, go for Ozurdex. And if center sparing, focal and grid works best. So if it is not center involving, immediate laser I think is best. To summarize the thing, anti-VEGF is the still first line. Focal or grid should be done. So all retina surgeon or non-retina surgeon should learn laser, I think, because we are surpassing cataract. So it's the need of the hour. So laser has to be done in non-center involving. Ozurdex in chronic recalcitrant cases, and long-acting drugs are in the pipeline, so future holds. Thank you.
Thank you, Dr. Amit. You also summarized very well. Dr. Manisha, any question?
Very nice talk, Dr. Amit, but I'll just beg to differ on the last slide where you have summarized that give 2 injections of anti-VEGF and then subsequent to that shift to Pagenex or Eylea. I think all the recommendations do say that you have to persist with the same anti-VEGF for at least 3 to 4 injections. So it will be too soon a shift to another anti-VEGF.
When we evaluate the entire gamut of the patient, so there will be approximately 25 to 30% patient who will be late or slow responder. So what is recommended is that at least you should give 3 to 4 injections or wait for 4 to 6 months before they do not show any response. Or meanwhile you look for any associated factor, the reason for that. Shifting too soon you may miss those who start responding late actually, and there could be the immunogenicity problem, because the immune reaction can play. If you switch from a original molecule to the biosimilar, there is a chance of immune reaction to also develop. So generally the recommendation is that we should be doing the 3 to 4 injection and look for the scientific. And second is that you mentioned like non-center involving DME laser. So I think is any good which is very will agree with that, or the anti-VEGF still remains the first choice of medicine in that also, in a non-center involving DME. Dr. Manisha?
You're asking me?
Yeah.
Yeah, non-center involving DME, I would surely agree that, you know, we don't have patients who are, the government is paying for the injections. They are quite a majority are paying out of their own pocket. So non-center involving DME, I will surely do an FFA and locate the microaneurysms, and if they are laserable, I'll surely add a laser. My anti-VEGFs will not be the first line.
Dr. Saxena, would you like to say something?
Since the central thickness would be more, so as she has also said, I'd like to do laser, but I would like to give in a dose of anti-VEGF first to flatten out the macula a bit, and then supplement it with laser photocoagulation, surely.
So proper FAOCT should be done in such cases, and then we should proceed with that. I think we all agree with that. Now next speaker we have Dr. Sangeeta Jain, who is, I would say, was the first one to start standalone retina practice in Uttarakhand.
Yes.
And you started when, 2004 or?
2011.
2011, okay, that time you were studying. Good. So she'll be talking about the new injections.
New weapon, new rate to quality.
New.
So, good afternoon everyone, and I first of all thank Dr. Saurabh for inviting me here, and Dr. Khanduja also, because he was saying कि पहली बार मैंने देखा है retina session में public is sitting, so I will request sir to be seated there.
Dr. Sanduja.
Dr. Sanduja, that's what I said. Probably if I am not wrong, I will say sorry. So no financial interest. If you look at this elephant, this is the way how we are treating with our anti-VEGFs. So apart from anti-VEGFs, we have tried all other modalities, and about anti-VEGFs, all has been discussed earlier with all our speakers, the treatment burden, the persistence problems of the patients, and the neovascular AMD happening in India. And I would not like to go through all these slides because straight away I would like to go for the cases. 72 years female, 14 biosimilar ranibizumab, 7 ranibizumab, 2 aflibercept, 618 part vision in left eye and right eye, already lost to wet AMD to FCCF. When I looked her, she was having similar kind of OCTs with 660 part. After these many injections, this was the OCT. So we had brolucizumab in our armamentarium by then, and first injection was done. But after the first injection, if you look at even after 1 month, she remained to 660 part. We gave the second injection. As it was a recalcitrant case, and in earlier time we were going through the Hokan-Arya study, the 3 loading dosage we were working on. So in this case, we had given again a third injection. Still the OCT and the vision remained same. But after 2 months of these 3 loading doses, we have gone to 636 parts. Still intrasensory fluid is still remaining there. So she shifted to her son in Mumbai and had 12 injections of ranibizumab and its biosimilar over 1.5 years. And again she went back to 3/60. Again she came back, and again we injected the brolucizumab. For the first time after these many treatments, she improved to 624 part after 8 weeks of the 4th injection of brolucizumab. He is a 52 years male, diabetic, hypertensive, no uveitis and glaucoma, but the patient was having DME, and we have treated with brolucizumab straight away the first injection, and post 3 months the DME settled like this, improved his vision, and we didn't require yet the second injection. The patient is followed up for 6 months till date. 41 years female, post-renal transplant, she developed a DME and reduced her vision to finger count 1 meter since 15 days. If you look at the OCT angioplex, this was the configuration, and on OCT, this was the intraretinal fluid, even the subsensory fluid was given, and we have given a single injection brolucizumab in both eyes 1 by 1. And we have examined the patient even 1 month, 2 months, and this is the last OCT post 3 months of single injection. She improved to 624 part, and 1.5 years now she is maintaining her 624 part with no more edemas. So 62 years female, right eye she has gone to FCCF, no comorbidities. Earlier she was presented to us with dry RMT. This was her clinical presentation when she came. And as the first dose we have given her brolucizumab. She is amongst one of the earlier cases of mine. So I have seen her at 7 day. There was a fluid reduction but vision was not improved. So for finger count half meter, after 1 month she improved to 2 meter, but still there was disfigurement of fovea. We again injected the second injection, but this case taught me something which I really realized while practicing the brolucizumab. After 2 injections, she remained to 2 meters. Again, third injection was given, and the patient came after 6 months of follow-up. Look at the foveal atrophy. Though this is a wonderful drug, but this is a long-acting drug, and after this case, I left the loading dosage, and then again I started to as and when required. So she remained to finger count 4 meters and foveal atrophy occurred. So we have to look into while giving injections, when to stop, when to give the next dose, and when to increase the gap in between. So this is 55 years male, practicing physician. He had 660 vision with metamorphopsia. If you look at the PED, it was a huge PED. He has gone through the multiple options of anti-VEGF and got his first injection done at this OCT, and when he came for the next follow-up, he hardly improved to 660 part 636. And then he asked, ma'am, OCT to same hi dikh raha hai, why should I get injected? But I have lost my faith that time with brolucizumab, how to explain being physician. But if you look at the OCT parameters over here and here, there was a break in this red rim. Somehow I tried at my heart and given him a second injection, but at 3 months follow-up, like before giving the third injection, this was his OCT. He improved from 660 part to 69 part, and this is the follow-up of 6 months, 9 months, 12 months, and now 15 months. He is a physician still practicing in nearby, somewhere Bijnor or somewhere, and he is maintaining his 6-9 part with 3 injections. And this is after 24 months, the same patient. 2-year follow-up has gone with this patient and maintaining 6-9 part. 76 years male, pseudophakic, best corrected visual acuity 636, left eye already scarred. OCTs of right eye, I am treating the patient last 8 years. Left eye we have already lost. Right eye with multiple anti-VEGFs over 8 years, he remained to be only 660, at times 4/60. Left eye is having scarred CNVM with 1 meter vision. And when we had a brolucizumab, post 13 ranibizumab, 2 bevacizumab and 2 aflibercept, this patient has been injected for the first time brolucizumab and he improved to 624. Look at the OCT. There is a huge difference between the fluid consistency which I had seen last 8 years and post first injection. But the patient didn't turn up for 3 months, and after 3 months he came up again with the fluid. We gave him the second injection, but he maintained to 636 part. The vision was not declined. And at this point, after 3 months of second injection, we gave him a third injection. And this is after 6 months of last injection, that is 1.5 year. He remained to 624 part with the best corrected visual acuity and no fluid. So again, these are the similar cases which are improving with brolucizumab. Instead of going into much details of these many OCTs, this was one interesting case. A brother of my OT technician getting treated for CSR in Banaras and even given anti-VEGFs in between, he had a PED and he improved with 1 injection from 660 to 612 and remained so for last 2 years till date. Till date, we have given nearly 235 injections and I haven't gone through any IOI, so I really trusted the molecule. And this is the last case I would like to discuss here. A glaucoma patient, 65 years female, finger count 1 meter and other eye is FCCF, already had 4 ranibizumab with me. And I had similar kind of OCTs every now and then, and every time she used to come and say कि डॉक्टर मैंने पैसे तो पूरे दे दिए आपको, ट्रीटमेंट भी करा लिया पर मुझे कुछ दिखता ही नहीं है. एंड दिस इज़ अ रियल डिसअपॉइंटमेंट आई थिंक फॉर द VR surgeon or a medical retina person to listen these complaints of patient. So by this time I had brolucizumab when I injected, and post 15 days for the first time she improved to 4 meters. And after one injection, after we have given a second injection, after 4 months she was still at 3 months. And then she had the third injection, and post 6 months of 3 injections, this is at 9 months, she remained to 624 part. Still, whenever she comes, now she don't complain of कि doctor मैंने पैसे तो दे दिए and I am not getting treated. So it was quite satisfying to me कि at least patient कह रहा है कुछ तो दिखता है, and that is the beauty of the drug, that our patients are stabilized with minimal number of injections and with a better visual acuity. So as we know about the geographic atrophy, which is the destiny of all our multiple anti-VEGF, so we have to look into all these patients so that we did not develop this GA. And as we already discussed the treatment of DME as it is causing multiple hospital visit, IOI was definitely our concern with this injection. So it was an unwanted nightmare, while simple promising procedure can cause a nuisance to us. So we have to select a patient very properly, like pre and pre-op uveitis, whether there are any infections locally or systemically, post-active infections in ENT, and even the complicated cataract surgeries might cause IOIs at times. So while taking precautions, we need to put on a pre-op antibiotic or NSAID eye drops if any case requires systemic antibiotics, proper OT cleaning and asepsis. Sterilization of trolley. At times, few things are missed in our OT by OT assistant. Proper cleaning and draping of eye. Do not use single or old paraffin, which our normally staff keeps. The old paraffin or anything which is kept over there in the OT, they use that drop with multiple patients, and we can have the cross reactions in our simple procedures. We have seen few of the OT staff, especially the female staff, nails are not cut properly, and the hand sanitization to be taken care of. Single use anti-VEGFs, definitely they take care of all IOIs. We have already talked about these all burdens to our patients. Thank you very much. So brolucizumab resulted highly effective in restoring the anatomy of eyes affected by NAMD or DME in stabilizing the visual acuity, both treatment naive and even refractory to other anti-VEGFs intravitreal agents. Thank you very much for your patience and time.
Thank you, Sangeeta. Nice presentation. Any questions? What interval you take between the 2 injections?
Earlier I used to follow Hawk and Harrier. Now I have stopped. I take 2 months interval, 8 weeks.
8 weeks.
8 weeks.
It
So
also depends on
we
the
are
type
talking about brolucizumab, so it is 8 weeks.
Because if you give earlier, like in a month gap, so it creates the immunogenic reaction, and you can have the end-of-life picture. So that is the cause of concern.
Yes.
But in real-world scenario, it is much less at what we have discussed.
Yes.
Just one question for all the retina people: brolucizumab or Eylea, which one will you prefer?
It totally depend on patient's affordability first thing.
Yeah, so both are giving a good results actually.
But both are good.
But if you compare between to the number of indication and the response, the Eylea fares better above the. Basically the IPCV particularly in that case, and brolucizumab is basically the ranibizumab, which is a higher molecular weight with the deeper penetration and the higher affinity and much stronger response initially. So that's why it is acting on the PCBs also and to the subretinal plates as well. But if you see the Eylea versus Pejnex, we need lot of studies now, but that fares definitely better. Yeah, it is better. But it is definitely scores above the ranibizumab or the biosimilar.
Thank you.
Thank you, sir.
So, do we?
He wanted to click a photo. Yeah, I wanted to, but he forgot it.
Thank you very much to all the retina colleagues, and we have to start the cornea session, and we start with Dr. Abagor. And meanwhile, I would just like to call upon all the chairpersons. Do we have Dr. Rohit Shetty here? No. Dr. Govind Tityal, Dr. Geeta Iyer. Okay, Dr. Abha will on a way. Okay. Okay. Gaurav Luthra, Stanshu Mathur, Bandana. तो सेशन ही स्टार्ट करूं? हाँ, तो इसलिए 1:30 to 2 के बीच में कर लिया. Dr. Neelima has come or not? No, Dr. Neelima Mehrotra. She hasn't come. And Dr. Ruchika? Yeah. You come over.
Aya.
Thank you, Dr. Rajesh. And after this interesting lunch, I would be talking upon vanquishing the stubborn itch, which is VKC, the corneal complications. So I start with this case, which is of a young 13 years old male who presented with the chief complaints of diminished vision, history of allergies, itch, etc. And on examination, which was not done previously, he was found to have a high cylinder in one eye with a vision of 2/60, and he was put on treatment regular with anti-allergics as well as steroids. And on slit lamp, we saw Vaux striae and a thinned out cone. The pentacam showed a cone and was then diagnosed as keratoconus. His BCVA significantly improved with scleral contact lenses to 6/9 in both eyes. He was advised against eye rubbing, and his treatment for VKC was started. So at 1 month, he significantly improved. He was opening his eye better, but under treatment. But then at 3 months, he presented with a recurrence because he did not follow up on treatment. Once he was happy, he did not continue further. Another child, an 8-year-old male, again presenting with itching, pain and photophobia in both eyes. And he came with a shield ulcer. So he underwent a plaque removal along with an amniotic membrane grafting. Again at 3 weeks, he was much better. The defect had healed with minimal scarring, though his BCVA remained 6/18. So the third case is of a 22 years old male with more of a burnt out form of a VKC. He presented to one of our peripheral centers with very poor vision in both eyes, 1/60 and 2/60. He did not have active disease, but he definitely had gelatinous hypertrophy at the limbus and had very poor vision at this age. He underwent an alloslet in both eyes, though vision improved to around 6/18 in both eyes, but then he's not somebody who would come to us for regular follow-up. This one again, gelatinous hypertrophy, 28 years old female, again presenting with a significant cylinder because of the limbus involving disease. So she was put on systemic treatment, and then at 1 month significantly became better, though her vision still remains hampered. So it's not just an itch, it's not something which can just be treated with topical medications. It needs long-term follow-up as well, and the complications of which can also be disease induced as well as treatment induced. Most common corneal complications are shield ulcer, keratoconus significantly high in studies between 6% to 26%, dry eye too, limbal stem cell deficiency is not less, again 1 to 2%, and also lid complications. This is a study, a data of over 400 patients from India, which show that over 10% of VKC had poor vision, and most significant were being corneal scarring, keratoconus, and medication-related complications. We have undertaken a similar data analysis where we have over 1200 patients now in the duration of 2 years, and we have taken different centers that are taking part in this study as well. And if you see the complications, the vision greater than 618 is significant, but then at least over 76 patients in different areas of northern India have significant complications, the most common again being corneal scarring. Coming to management, there are multiple clinical gradings available in literature based on which the disease can be treated. The investigations have been advised as well. Just most important out of which is early detection of keratoconus. It is important to follow the patient up with refractions as well. Dry eye, this is a paper that we published wherein we studied the patients of VKC, dry eye in patients of VKC, and we realized that there is significant shortening of the TBUT and meibomian glands dropout as well, and on confocal we noticed there was a reduction in corneal nerve density. The management, like most of us at our centers do, is mast cell stabilizers, topical antihistaminics, dual acting agents, and NSAIDs. And this is the first line of management which becomes important. Also, the role of topical steroids. It is important for the patient to be put on topical steroids and then kept on follow-up as well. It is the most potent anti-inflammatory drug that we presently have and can be indicated in persistent severe symptoms, thick mucus discharge. We have both the high potency and low potency steroids. Also, supratarsal injection of steroid is something that is being tried, though the follow-up of the patient again remains important, and steroid-induced glaucoma is also a major concern. Both cyclosporine and tacrolimus have been used. Cyclosporine, though off-label use, blocks the T2 lymphocyte proliferation and IL-2 production. Cyclosporine is genuinely useful, but the concentration that it is available in is very minimal, and the child mostly complains of stinging. Tacrolimus is most easily acceptable and can be used at once nightly. Systemic immunosuppression also has a role in the data that we have collected of around 1200 patients. We have around 22 patients that are on systemic immunosuppression as well, and the variation that you see presenting to a tertiary care center is very variable. So it is indicated in severe recurrent disease which does not respond to topical steroid, and low dose oral steroids can be given at 5 to 10 mg per day. Also, oral cyclosporine can be tried. Surgical management is indicated in a giant papillae by shave excision or carbon dioxide laser, and also for shield ulcer. So there are multiple treatment algorithms for VKC as well, but it is most important to prevent the complications. Thank you. Any questions?
Any sort of ptosis, dehiscence of LPS aponeurosis?
No,
or
none.
because it has been reported in the literature.
Yes, so most common complication that has been reported is steroid-induced glaucoma. So we are very careful. We haven't done a lot of supratarsal as well. We have around 12 patients that we have given. The most common complication that we have seen out of this 1233 data that we have, there are 12 who got supratarsal steroid. But the most common complication was horizon eye.
Till date, you have not encountered.
And it can be easily removed if it is causing a problem. The depot can be removed as well.
Okay, thanks.
Very nice presentation, Dr. Abha. Actually, like we already mentioned in sealed ulcer, we normally go for the surgical management, but sometimes what happens, sealed ulcers are present with infiltrate also. Yes. So in those conditions, like topical steroid is also difficult. So I think oral steroid used to start in those cases.
Yeah, but generally the infiltrate that comes with a shield ulcer would be sterile once scraped. If it is sterile, if it on scraping, it is better to still remove it and put an amniotic membrane there. If you get some infective pathology, then yes, that needs to be treated first with systemic steroids.
And once you start the oral steroid, like what should be the duration? How long will you continue this?
So I have seen follow-up for at least 6 months on very small 2 mg kind of dosage as well.
Another thing is like counseling part is also very important for those patients because it is a chronic process. So we should take a time to counsel the patient like about the what is the actual mechanism, pathogenesis of this particular condition, because lots of patients are present to us with PSC also, like complicated cataract also with prolonged use of topical steroids. Thank you.
Thank you.
Dr. Abha, one more question. Any experience with MMG for giant papilla?
I haven't personally done that. But yes, I know MMG has also been used for like the cases of SLET that I have shown. MMG has also been used for ocular surface reconstruction in VKC. But I don't have experience.
And it works well for giant papilla as well.
Yes,
and I think we can avoid all these steroid related complications.
Actually, what I have done is shaving off and covering it with amniotic membrane. I probably haven't seen a case which needed an MMG, but yes, it can be.
Okay, thank you. May I invite our next speaker, please? Dr. Rajesh Sinha, who will be speaking on keratoconus advances in management.
Thank you very much. At the outset, I would like to thank the organizers, the Uttarakhand Ophthalmic Society, Dr. Saurav Luthra, Dr. Ashok, Dr. Stanshu, and one and all involved in organizing this wonderful event at such a wonderful place, which of course everybody would like to visit. And I'll be talking over here about keratoconus, some advancements that have happened over time in management. So keratoconus, as we all know, it's a progressive ectatic disorder of cornea, results in corneal irregularity, which results in blurring of vision, and many times it's not fully correctable by glasses. So the aim of management is to arrest the progression because it's a progressive disorder and provide visual rehabilitation. As far as progression parameters are concerned, there are a lot. So people always kept on thinking that which one should be considered, and then there was a global consensus that was done in 2015, and they decided that at least 2 of the following parameters should be there to call it a progressive keratoconus. That is progressive steepening of anterior corneal surface, progressive steepening of posterior corneal surface, and progressive thinning. And if there is progressive keratoconus, corneal cross-linking is something which is an established modality. The standard resident protocol is the one wherein we debride the central 7 mm of epithelium, put riboflavin every 2 minutes for 30 minutes, and then focus UV rays and keep putting riboflavin for another 30 minutes. And it has shown to be of great use and now considered as an established modality for arresting the progression of keratoconus, and the efficacy is judged. One of the parameters to judge the efficacy is the nice demarcation line that you can see here, which is normally seen at the junction of 2/3 to 1/3, 2/3 anterior stroma to 1/3 posterior stroma of the cornea. So it is an established modality, but then there are some issues, like patient does have pain because you debride epithelium, nerve endings are exposed. It's a long duration procedure, 1 hour duration, and in thin corneas which are less than 400 microns minus epithelium, the risk of endothelial damage is there. So a lot of modifications are being done, like in order to reduce pain, people have done transepithelial CXL. Initial 1 or 2 studies showed some response, but then later on people felt that epithelial removal is required. Even some partial removal of epithelium was done, and it was found that the demarcation line that was formed was absent in the area where epithelium was not formed. So that suggests that epithelium has to be debrided. The next issue was long duration. So again, advancements were done in that, and accelerated cross-linking came into practice based on Bunsen-Roscoe principle. The conventional CXL works on 3 milliwatt per centimeter square for 30 minutes. accelerated cross-linking went up to 30 milliwatt per centimeter square for 3 minutes, which initially people were very much excited to do, but a lot of studies were done. One of studies was done at Narayan Nethralaya and Dr. Rohit Shetty as well, and people started feeling that it's the 9 milliwatt per centimeter square for 10 minutes, which is comparable to the conventional cross-linking, and that can be considered as an alternative. In thin corneas, again, people thought that the first time Farhad Hafeezi group they started swelling the cornea by using hypoosmolar riboflavin, so that the separation of UV rays from the endothelium increases to more than 400 microns. Up to 330 microns of cornea was used, and people started working on it, but the result is not as good as conventional cross-linking. It is said that the effect is nearly 1/5 of what we get in conventional cross-linking. Then there are certain other studies which try to separate the UV rays from the endothelium, use of bandage contact lens, use of smile lenticule. But in all these, what happens that you discard the anterior part, which is the bandage contact lens and the smile lenticule, which also is a part when you are doing cross-linking, and as we know that cross-linking works only in anterior 2/3 of cornea, so the effect may not be as great. In bandage contact lens used CXL, again the precorneal tear film acts as it prevents the passage, the penetration of riboflavin, so the riboflavin penetration is not as great, and that's why it's considered as less efficacious. We at RP Center, I've done 2 studies like that. At RP Center, we did a study wherein we created intrastromal pocket with the help of femtosecond laser, and used a negative meniscus lenticule, which was introduced intrastromally. So we create a pocket, inject riboflavin into the pocket, and then use a riboflavin soaked lenticule into the pocket, and then do cross-linking. So we created a negative meniscus lenticule from a donor lenticule. So we created a stromal lenticule of 200 microns, ablated central 4 millimeter by 75 microns by excimer laser, and then used that lenticule, created that hyperopic kind of a lenticule. And then we thought that probably the peripheral thicker part will act as arc shortening, will have some arc shortening effect as well. Now initially we created a pocket of 7.8 millimeters with Visumax. Beyond that it was not possible at that time, and we used a 7 millimeter lenticule. But now we are creating a 9 millimeter pocket and putting a lenticule of 8.5 millimeters, and then doing cross-linking. So once the lenticule is in position, it is spread all around, and then you focus the UV rays onto the cornea and do cross-linking. On day 1, the lenticule appears a little swollen because of the inflammation and all that, but at 6 months the central part of the lenticule in this case is 98. The average thickness was 89 in our series of patients. So it reduced from 125 to 89 at 6 months. One thing that we have learned over time, that we need to put topical steroid on a long term basis, because we create 2 interfaces and it creates a haze. So we had haze in the cornea, in the lenticule as well, in the interface as well, in these cases when we stopped steroid early. So now we are using steroid for a longer period, and this is the appearance. The cornea appears clear, and with the 8.5 millimeter lenticule, the topography is also nice. This is a nice regular bow tie pattern that is seen after in the post-op period. Another advancement is the customized CXL in the treatment of keratoconus, wherein greater energy, greater power of UV rays is used in the area which is weaker, and that was from the Theo Seiler group. Study is being done still. It's on, and we cannot, it hasn't come into general practice. I'll just take a couple of minutes. Then another thing was use of oxygen supplementation, because with use of UV rays the oxygen concentration reduces to goes down to 0. So people started using these oxygen goggles. We created our own indigenous oxygen goggles, which has been, now this has been published in the European Journal of Ophthalmology. So the goggles that was commercially available cost 3,000 euros. We created from a PPE kit and we also use an anesthesia machine to measure, to supply oxygen as well as measure the periocular oxygen concentration. So this is the tube through which the oxygen is being put in the periocular area, and the rate is 5 liter per minute, and then the tubing that is attached to the this is coming like this, and this is the hole through which the UV rays are focused. You put riboflavin, and this is the tube through which you measure the oxygen saturation in the periocular area with the help of an anesthesia machine, and the oxygen saturation in most of the cases was nearly 84-85%, and then this was done. So we found out that the Kmax reduced more than the cases wherein oxygen was not used. Still a lot of cases are being recruited. Just a few words about visual rehabilitation. The RGP contact lens is the mainstay. Initially the bicurve super design was used, now rose K multi-curve design is being used. If the patient is not tolerant to RGP contact lens, we can use a piggyback contact lens, we can use a hybrid contact lens, and in very large cones we can use a mini scleral contact lens. And in early keratoconus we can use Intacs. I just skipped the video because of paucity of time. So we can use Intacs to regularize the cornea, to reduce the cylinder, and then we can also use a toric ICL to correct the refractive correction if the patient is not willing for contact lens. And topo guided custom ablation treatment is done in early keratoconus to make it regular, and then cross linking can be done and you can fit a contact lens nicely. Keratoplasty is the last thing to do. Penetrating keratoplasty was done earlier in all the cases of keratoconus. Now in most of the cases we do this DALK, there is a deep anterior laminar keratoplasty. The big bubble DALK is the preferred technique, wherein we do a descemetic DALK, but sometimes in a case of heel hydrops you have to do a manual layer by layer dissection, and use of microscope integrated OCT has really helped. That is also an advancement in the field of microsurgery of cornea. So you can create a nice regular bed for the lenticule. So in conclusion, keratoconus, yes, of course, it's a mysterious disease because a lot of things are being done, a lot of studies, a lot of concepts are coming up, and the main aim is to mask the irregularity, and the advancements are being done in this area. A lot of studies will be done in future as well in order to improve the outcome of the treatment. Thank you very much for your patient listening. Any question or suggestion?
Use any, like, have you come out with some nomogram or something to plate the lenticule?
No,
that
right now it is not for a refractive purpose. It is basically for tectonic purpose, so that we can create a good tectonic strength of the cornea. You stiffen it by use of cross-linking, and with some degree of arc shortening effect you get some regularization of the corneal topography as well. So that is the basic aim. Once we succeed in that and we can defer and we don't have too much of interface hazes, which of course you require a lot of topical steroid, long duration topical steroid in these, then we will start working on the refractive outcome of it, that how much refractive correction or what will be the nomogram for the thickness of the lenticule.
So just continuing with that, what was the thickness in the patients that you took for smile lenticule insertion? Like creating a pocket?
It was not a smile lenticule, it was basically a donor tissue lenticule. Okay. We had initially thought of smile lenticule only, but then you have to wait for such thickness of smile lenticule to come, and so we started doing it with donor lenticule. So we use 200 microns, we take 200 microns of thickness. In order to create the pocket, we create it at the level of 150 microns. So you also need something about 160, 170 beneath that, so as to sustain all that dissection and everything. So anything, and plus creation of a lenticule also requires that much of pocket, also requires that much of thickness.
Suction
so
also.
Anything, yeah, suction also. So anything beyond 320, 330, the minimum that I have used is I think 330 only. So anything beyond 330, above 330, we do it. The patient should not have a scar. That is also a criteria. So we select cases and then do it. And as I said, long-term topical steroid is very essential. Otherwise, you have two interfaces and the haze will be quite significant. We had it in a couple of patients, and that's how we learned that we have to give long-term topical steroid.
Thank you. Another question, just because, so these tissue additive procedures, though they add tectonic support to the cornea, all those that have been published, like basement stromal inlays, etc., the keratometry on pentacam is very haywire. I mean, you cannot say that the keratometry stabilized. Any thoughts on that?
No, keratometry in a large majority of patients, it becomes better than before. If you take a smaller lenticule, like earlier I used to take 7mm lenticule, in that what happened that when you create a hyperopic lenticule, the thicker part sometimes comes over the cone, and that even worsens the topography. So after taking 8.5mm lenticule, larger size, things have become much better, and topography has started becoming regular.
Thank you, sir.
I now invite our next keynote speaker, Dr. Umang Mathur, who will be speaking on HSV keratitis.
Good afternoon. I come to Corbett quite often, but this is the first time I'm inside a hall and trying to study, and it's nice to have some audience after lunch while you have a choice of seeing the tiger. So I'll be talking on herpes simplex keratitis. It's commoner than what we always think, and here's a case, 70-year-old, one-eyed, presented with pain, redness, watering in the left eye of 2 months duration with diminution of vision. The patient is on antibiotics and some lubricants. Corneal scraping shows a gram-positive cocci. I think some people decided to go hunt a tiger. So what's the diagnosis? There's an epithelial defect, there's infiltration, there's thinning, and about 2 months history. So let's park this for some time. So HSV is estimated to be 50,000 new or recurrent cases in the US. We don't really have data from India, but it's not uncommon at all. And we know it's classified as congenital and neonatal, primary ocular herpes, and the more common, what we see in the clinics, is recurrent ocular herpes. This was a full-term normal delivery, 5 days old. He was admitted in an ICU with a diagnosis of septicemia. Presented a few weeks later to us with watering and opacification seen in both eyes. Once we stained, we could see these geographic patterns, dendritic patterns, stain positive patterns even on the conjunctiva. The patient's PCR, blood and CSF were HSV negative, but the maternal IgG, HSV were positive, and the patient actually, it's common to get encephalopathy and septicemia, and they get misdiagnosed very often. But you may be dealing with HSV. The congenital neonatal herpes is generally by HSV2. What is below the waist is HSV2, while what is above the waist is HSV1. Primary ocular herpes, a lot of people have it and it passes over and we don't realize it. Only 6% of those who are infected actually get any kind of signs. It may manifest as conjunctivitis, keratoconjunctivitis, SPKs, and of course skin vesicles. But what we see in the clinic more often is recurrent HSV, which we classify as epithelial disease, which may present as vesicles, dendrite, geographic, and marginal ulcers. Then you have a neurotrophic keratitis, which is neither immune nor infected. It is basically a basement membrane problem that occurs, and often a sequelae of an epithelial disease where you get a non-healing ulcer. Stromal keratitis is of two types, necrotizing stromal keratitis and the immune-mediated stromal keratitis. The necrotizing keratitis presents with an epithelial defect and thinning, while the immune stromal usually has a blood vessel with interstitial kind of infiltration. Endothelitis, which is very common, I think after the dendritic geographic ulcer, what you see commonly is the endothelitis, which could be disciform, linear, or diffuse. This is immune mediated. And you may have trabeculitis associated, which causes a spike in IOP and uveitis. So coming back to our patient, he was KOH negative, gram positive, cocci present with an epithelial defect, and very often these patients would get treated as bacterial ulcers. Now if you dig a little deeper into the history, and you'll find that the patient had a history of similar episodes of redness in the past, and the patient walks into your clinic with a red eye, something on the cornea that you could see even with naked eye, but the patient is opening his eye widely. And that is because they have poor corneal sensations. They may have pain, which could be because of uveitis, but not having photophobia. So it's an angry looking ulcer. However, there's no discharge and there's no slough. There's a whitish infiltrate. But what is common with the bacterial ulcers, there's epithelial defect, there's infiltration, and there's thinning. So oftentimes they get misdiagnosed as bacterial ulcers, but we are dealing with a stromal necrotizing keratitis. So this patient was treated with both topical and oral acyclovir, and slowly the infiltrate starts to reduce. After 2 weeks we add steroids. So although we saw the classification, there is a mixture of immune mediation as well as an infected part in some of these. It's not clear-cut demarcation. And over a period of 4 weeks, the patient starts healing and eventually heals with a scar. Another such patient presents with this epithelial defect, infiltration, thinning. At a glance, it may look like it's any kind of a suppurative infection, but if you look at the blood vessels, which are common in HSV, not so common in fungal, and most bacterial don't give you time enough for blood vessels to come. And of course, sensations are poor, and this is a diagnosis of viral stromal necrotizing keratitis. They often would need a tarsorrhaphy because the sensations are poor and patients respond well to treatment. Now, if you look at the herpes eye disease study, the HEAD study, it said that topical corticosteroids regime used in HEADs was significantly better than placebo in reducing the persistence or progression of stromal inflammation and shortening the duration of herpes simplex stromal keratitis. So this is the HEAD study where it showed that steroids have a beneficial effect in stromal keratitis. They also showed that there was no statistical or clinically significant benefit of using oral acyclovir in treating HSV stromal keratitis in patients receiving corticosteroids and topical trifluridine. Of course, in the US, they were using trifluridine, and we are fortunate we have acyclovir available there. Now, according to this, one would think that stromal keratitis requires only topical steroids, if at all some topical antiviral. Now, the trouble with the HEAD study is, the HEAD study, how did they describe stromal keratitis? Stromal keratitis was defined as an area of 2.5 millimeter square of active stromal inflammation with diffuse or disciform inflammatory stromal edema or dense opaque inflammatory infiltration. So this does not, the second part may have some necrotizing element. However, this is what we today classify as disciform keratitis or endothelitis. So the definition of stromal disease in heads is very confusing. It is not the stromal necrotizing that we are talking of. They actually just put a note that they could not recruit enough patients of stromal necrotizing keratitis. So what they were dealing with was endothelitis, for which we know the treatment is topical steroids. So we had done our own study and we found that of these 13 patients of stromal necrotizing keratitis, we gave 10 weeks of oral acyclovir 400 milligrams 5 times a day and 2 weeks of topical acyclovir ointment, and we added topical steroids only after 2 weeks. 70% of these patients were PCR positive for HSV, and we found a beneficial effect just of topical and systemic acyclovir, and the topical steroids helped in reducing the inflammation further. So this is a separate entity, and if you look at which are the ones that have live virus, the dendritic geographic ulcers have live virus. Because there is access on the surface, we give topical acyclovir. Necrotizing stromal keratitis again has live virus. Because it's much deeper, we need to give both topical and systemic acyclovir. And uveitis again would require systemic acyclovir. I think it's time, right? So prophylaxis, we know 41% reduction with systemic acyclovir, and that is a problem. And we know recurrences are a huge issue with HSV, and we are currently studying in our basic science lab why do we get recurrences, can a biomarker predict recurrences, how efficacious is acyclovir, and can we find a biomarker which can track and assess the efficacy of treatment. To cut the long story short, we find that while we were giving this patient of necrotizing keratitis presents, we find that in the tears and scrape, IL interleukin 6 levels are high. We give oral and topical acyclovir. In the second visit, it comes down. The patient is lost to follow-up and does not take treatment, comes again with a recurrence. We again see a spike. On giving treatment, again this with prophylaxis, the IL-6 levels come down. And this could maybe help in prognostication and knowing what levels will keep the patient in remission. Also looking at if exosomes can be used to downregulate these inflammatory markers and would help in treatment beyond just giving our systemic prophylaxis. Thank you.
Thank you so much, sir, for this elaborate presentation. So, I have a question like, if a patient with HSV keratitis, we treat the HSV keratitis, and after how many, what should be the duration for cataract surgery for that particular patient?
Yeah, so I think if the patient should, yes, continue to remain on prophylaxis, and if the patient has been quiet for 6 months, I think it should be okay to do the cataract surgery.
Yes, sir. So, actually, as you mentioned, the clinical presentation is very important for diagnosis, because advanced cases, it is very difficult to diagnose. Yes. Early stage, it is easy. So, like corneal transplant is contraindicated in particular case. So, clinical presentation is very important. So, thank you so much for this presentation.
Thank you.
Our next presentation is Dr. Ruchika.
Good afternoon, everyone. So my topic is inflammatory diseases of the peripheral cornea. Now let's understand why the peripheral cornea is a target of all these diseases. It's because of certain anatomic, physiological and immunologic predilections, like the loosely arranged collagen fibrils in the periphery compared to the center, less neural innervation, proximity to the conjunctival and the lymphatic blood vessels, and higher concentration of Langerhans cells, the C1 complement factor and IgM antibodies. Now, this entity can be broadly divided into those that result from hypersensitivity reaction to exogenous antigens resulting in catarrhal infiltrates and flectinules, and those that result from autoimmune reaction to the corneal antigen causing PUK and Murins. Now, the catarrhal infiltrates and flectinular keratoconjunctivitis are the most commonly encountered and easily recognized entity, but sometimes confused. Let's see how you can differentiate these. Now, the catarrhal infiltrates usually develop at a lucid interval of 1 to 2 millimeters from the limbus, and mostly are self-limiting, but sometimes they may progress circumferentially and form marginal ulcers. Flectinular keratoconjunctivitis, on the other hand, develops first and most prominently on the limbus and has a tendency to progress centrally across the cornea. The blood vessels which follow also have a more straight course. Catarrhal infiltrates are more commonly seen in the adults who present with mild to moderate symptoms, and it results from a type 3 hypersensitivity reaction, most commonly against the staphylococcal antigens. Flectinular keratoconjunctivitis, on the other hand, is seen more commonly in children and young adults who present with a little more severe photophobia, and it results from a type 4 hypersensitivity reaction. Most commonly implicated antigens are tuberculoprotein and staphylococcal products. The flectin is composed predominantly of monocytes and T lymphocytes, which results in the formation of a nodule or a blister, which forms a microabscess and eventually ulcerates and heals over a period of 10 to 14 days. Now, both these entities respond very well to standard treatment of lid hygiene, lid scrubs, topical antibiotic ointment at bedtime like azithromycin, chloramphenicol, along with a short course of oral antibiotics like tetracycline and doxycycline for 4 to 6 weeks, and a short course of topical steroids to control the inflammation. However, patients with flectins which are not lid margin related and which are recurrent need to be investigated for underlying etiologies like tuberculosis or helminthic infections. Now, there is a subgroup of patients who, despite long-term treatment with lid hygiene and oral doxycycline, keep coming back to us with recurrent blepharoconjunctivitis, recurrent chalasia, and it's quite frustrating for the treating doctor as well as the patient. So this is where you need to keep Demodex in mind. Demodex is a mite which is a part of the normal lid flora and basically helps in the lid cleaning process. But sometimes when the lid ecosystem is disturbed, there might be an overpopulation and patients become symptomatic. So it's in two forms. Demodex folliculorum is usually found in the follicles of the lashes and is responsible for causing anterior blepharitis, trichiasis and madrosis. Demodex brevis is found in the sebaceous units which are attached to these follicles and causes posterior blepharitis and MGD. And the spillover of this inflammation can cause inflammation in the conjunctiva and the cornea. Now, the hallmark feature in this is the collarettes, or the classical cylindrical dandruff which is found at the base of the lashes, and the diagnosis is made by sampling these lashes. So basically, two non-adjacent lashes, especially the ones containing the cylindrical dandruff, are pulled out from each of the four lids, mounted on a slide with a drop of fluorescein and examined under the microscope at a magnification of under 100x, and this is what you would see. So the fluorescein basically helps to disintegrate the debris around the lashes and helps release the mites and also provides a good contrast. In vivo confocal microscopy also allows for a non-invasive view of these mites. So this is a short video. You can see this cluster of mites at the base of the follicles and also one piggybacking over his friend. Why it is important to diagnose this is because the tea tree oil is the treatment of choice, and that's what they respond to, which contains terpenin 4-ol. That's the active ingredient, and it has acetylcholinesterase inhibiting effects that basically leads the mite to exit the hair follicle. So these patients don't respond to the standard treatment of lid hygiene, etc. So the tea tree oil that is commercially available from various brands like Himalaya, Kama, etc., they are 100%, and they need to be diluted with another oil like olive oil or castor oil in a 1:1 ratio to prepare the 50% tea tree oil, which is used for in-office lid cleaning, maybe once a week in severe cases. But now we have brands which provide lid wipes and lid cleansers with a lower concentration of tea tree oil, around 2 to 5%, which can be used at home by the patients on a once or twice daily basis, but the treatment needs to be continued at least for 6 to 8 weeks. Ivermectin at a dose of 200 micrograms per kg, 2 doses 1 week apart, is also known to work well in these patients. Slides are not moving. Yeah, sorry. So another entity which is frequently missed and under-diagnosed is ocular rosacea. So rosacea is a chronic cutaneous disorder which primarily affects the blood vessels and pilosebaceous units of the central part of the face. You can see this patient with the classic erythema affecting the central part of the face, and many times these changes are easily missed, especially in pigmented individuals. Among Indians, these changes may be difficult to detect, and the classic phymatous changes are rare and mostly seen in males. So the rosacea consensus panel has laid down certain criteria for diagnosis. The presence of at least one diagnostic feature or 2 major features is required for diagnosing rosacea. And there are many pathophysiological mechanisms involved. There have been found elevated levels of inflammatory cytokines in the tears of ocular rosacea patients. There can be neurovascular dysregulation and increased expression of toll-like receptor 2 on the epidermal keratocytes with environmental triggers. And Demodex is also found to be more prevalent in patients of rosacea. The ocular rosacea can be very variable. It can vary from 60 to 70%, and environmental triggers like exposure to sun, spicy foods, consumption of alcohol, and extremes of temperature can trigger exacerbations. Corneal involvement is seen in up to a third of these patients. Now you can see the classic lid margin telangiectasia in these patients and MGD, which may be seen in the milder cases. The most severe forms can present with marginal keratitis, which can also lead to thinning and perforation if the inflammation is severe. They can also present with flictin-like lesions where the infiltrates tend to migrate centrally. So the management consists of avoiding trigger factors, using a broad spectrum sunscreen, management of MGD. IPL is known to work very well in these patients, a course of topical steroids, and cyclosporine for maintenance. Doxycycline needs to be given at a low dose for a longer duration in these patients, sometimes even for 6 to 8 months. And severe cases need to be managed by dermatologists. Often they may need isotretinoin. Another differential, as discussed by Dr. Umang Mathur in detail, HSV stromal keratitis can also present as a marginal keratitis, but there are few clinical features that need to be kept in mind. These patients are often less symptomatic because of associated corneal hypoesthesia, and they may have telltale signs of previous attacks of HSV keratitis in the form of scars. And the blood vessels are usually, you will see a frond of deep vessels, and ulceration usually precedes infiltration. These patients need to be managed with systemic antivirals, and sometimes even a tarsorrhaphy may be required, and the perforation can be managed either with a TABCL or patch graft in larger perforations. Now the more aggressive forms of marginal keratitis include PUK, and here you can see a classic crescent shaped ulceration with an overlying defect. These tend to spread circumferentially as well as with progressive thinning, and may have adjacent scleritis or episcleritis, which usually indicates a poor prognosis. They need to be thoroughly evaluated to rule out underlying collagen vascular disorders. And the pathophysiology basically is an interplay of both the humoral and the cell-mediated response. And they need to be managed in conjunction with a rheumatologist for systemic immunomodulation, which can be with systemic steroids, cytotoxic agents, or biologics. And the corneal perforation, of course, requires a surgical management if severe. A close differential is Murren's, and the clincher here is the pain is usually disproportionate to the lesion, and this also tends to spread circumferentially as well as causes severe thinning. But the classical feature here is the overhanging edges. This is also known as the Rodin's ulcer because of the burrowing nature, and this is usually a diagnosis of exclusion. However, there have been associations with hepatitis C and hookworm infestation. So they also this is a stepwise treatment protocol where the milder cases can be managed with topical steroids and conjunctival resection. The severe cases definitely need systemic immunosuppression and surgical management. This slide basically sums up my presentation, and so it's important to basically have a thorough ocular and systemic history in these patients and look for subtle signs to detect the more uncommon and less recognized causes so that we can have a targeted approach to treating them. And definitely, when in doubt, corneal scraping to rule out infection is a must. I'd like to thank Dr. Jaya Gupta for contributing the Demodex video and photograph. Thank you.
Thank you, Dr. Ruchika. You have very nicely elaborated all the peripheral infections. So you spoke about Demodex. Would you elaborate on how long do you continue treatment, and what would you advise for the refractory cases?
So basically, most of these cases, once they are diagnosed with, I give them these lid wipes which contain tea tree oil either from Oculeaf or Ecotears, and they generally keep them on 6 to 8 weeks, and maybe once in a week or once in 2 weeks I do in-office cleaning with a higher concentration tea tree oil of 50%. I personally don't have any experience with ivermectin, but reports say that ivermectin works well. Does anyone have any experience with ivermectin?
Yeah, so I think we also don't use ivermectin very routinely, not used it. Demodex responds very well to the use of tea tree oil itself. Like she mentioned, either in office and you need to continue with the management using the wipes at home. So that's one important differential for these recurrent inflammatory episodes in the eye. You also brought out, this is something that I always mention, you also brought out the importance of co-managing with a rheumatologist for PUK. So PUK and necrotizing scleritis are both indicators of a systemic vasculitis. So we always need to have what we term as a knee-jerk reaction in these patients and ensure that the onus is on us to get back to the rheumatologist, asking them to step up the immunomodulation, because not only are we dealing with ocular morbidity here, but we are also dealing with an increased risk of systemic mortality.
Ma'am, I just want to ask one question. Like in our clinical practice, I have like few patients who presented as perforated, like they were PUK, not they are not typical Murans. And the systemic investigation is all negative. Now, what should we do in these cases? Because those rheumatologists will never agree to start immunosuppression in those cases.
So, Murans is anyway a diagnosis of exclusion, but Murans also needs that the patient should be kept on systemic immunosuppression, and the only thing which immediately acts in order to protect the tectonic graft that you're doing is IVMP. So that is something that you will have to administer to these patients after ruling out an infection. And you need to have a rapport with at least one rheumatologist in the place where you practice, so that in these kind of situations you are able to emphasize upon the need to start systemic immunosuppression, though the systemic investigations are normal. But if you don't start systemic steroids and or IVMP, your graft is also going to melt.
Sir, I think you have a publication on Demodex, and I think you use ivermectin, if I'm not wrong.
I think we're pretty happy with the tea tree oil and not using as much of ivermectin.
Way back in 2006 that when I spent time with Dr. Sheffer Singh, where he used to keep looking for Demodex, that I actually came back and started looking for Demodex and started propagating the fact that one needs to look for Demodex in these patients. Demodex, we all need to understand, is a commensal. So the presence of Demodex is not always causative, but if there are multiple Demodex that you see in the eyelashes, then it is essential to treat it if the patient has recurrent episodes of inflammation, and TTO works very well in these eyes.
Especially, I think, when you see in young patients meibomian gland disease, you should suspect it. And also, rosacea is something on an Indian skin is not so easy to discern. But a lot of them, if you look carefully, have actually a rosacea-like pattern.
I think that's very important point that you made, Dr. Umang. because rosacea patients, in fact, you will not even appreciate this classical cylindrical dandruff that is mentioned to be present when you have Demodex infestation, because the Demodex in this is Demodex brevis and not the folliculorum. So it's actually present in the shaft. So you will not really see the cylindrical dandruff outside unless and until you epilate the lash and check under the microscope. That's only when you will be able to make out.
Cause a little more corneal inflammation, and when I didn't recognize this condition, I have some patients who in front of me
deteriorated.
They've deteriorated with those blood vessels coming right into the visual axis, scarring. They're needing scleral lenses, and many of those now without treatment. We were used to give some steroids and manage them. But I think ever since we've understood about Demodex, a lot of those patients actually are now under control.
So you would have experience with pulse laser for Demodex as well?
Not too many, but if you look at from a mechanistic point of view, the Demodex brevis is one which is in the meibomian glands. And it's not those Demodex which is your fault. It's what it works on your body, which is what it faults. For example, one of our slides had all those markers she showed, and the IPL works on those markers: ICAMP1, interleukin beta, IL-6, IL-2, and some of them. And so that's why for brevis it works very well. Personally, I feel instead of people putting efforts on bringing Liftigrast Zedra drops to market, they should make a Zedra ointment, because Zedra ointment should work very well, because it has the same band of what it's showing, and that's exactly the same band for a lot of other necrotizing work.
Thank you so much.
I now invite our next speaker, Dr. Bandana A, who's going to speak on management of corneal perforations.
Very good afternoon to all. First of all, I want to thank the organizing committee and Uttarakhand Ophthalmology Society for giving me this opportunity. My topic is management of corneal perforation. As we all know, corneal perforation is an ocular emergency. So if you don't treat it in early stage, then it may lead to early complications like endophthalmitis or late complications like a secondary glaucoma. It's very important to also know what is the underlying etiology of the perforation, because there are a few conditions where corneal transplant is contraindicated. As I mentioned, like Stevens-Johnson syndrome, sequelae like autoimmune conditions with poor ocular surface and dry eye, neurotrophic keratopathy, or chemical induced limbal stem cell deficiency. So there are various modalities for management of corneal perforation like cyanoacrylate glue, Tenon's patch graft, lamellar corneal patch graft, multi-layered amniotic membrane graft, and penetrating corneal transplant. When a patient presents to us with corneal perforation, we should look for the size of the perforation and what is the site of the perforation, and most important, what is the underlying etiology. So if the size is less than 2 mm, then we can go for tissue adhesive and BCL. If it is more than 2 to 4, then we can go for either Tenon's patch graft or amniotic membrane graft. If it is more than 4 mm, then we can go for patch graft if it is in peripheral part, or we can go for full thickness penetrating keratoplasty if it is involving the central part. So in our OT, we use Optica glue. So it is a ester of cyanoacrylic acid for tissue adhesive and BCL. It can be stored in cold storage. It has antibacterial and anti-inflammatory property. So this is a case of recurrent HSV keratitis which presented to us with central corneal perforation. As we in this case normally we try to remove the corneal epithelium surrounding the perforation, but we have to be very careful while removing it, and we are checking for this leakage, because if it is aqueous is leaking from this particular area, tissue adhesive will not work. So it's very important to block the leakage with putting air bubble in their anterior chamber. Then again, after properly checking for the leakage, we can use this tissue adhesive. Now this tissue adhesive which you use is Optica. Here we can see there is the solution is in the central part of the tube. So we have to just squeeze it, and then the solution, then put the solution in a sterile surface. Then before applying the tissue adhesive, again we should look for any leakage, and we should apply the tissue adhesive in adequate amount. It should not be it should not be much, or it should not be too less. If it is too less, it will not serve the purpose, and if it is like too much, then it will form a heap, and it will be difficult to place the BCL. So we can remove the tissue adhesive after 3 months. At that time, the epithelium will grow under the tissue adhesive, and once the epithelium grows, the tissue adhesive will fall off itself. During that period, we should look for toxicity. The main disadvantage is corneal vascularization. So this is a 65-year-old patient with best corrected visual acuity of hand movement. It is a case of recurrent HSV keratitis with central corneal perforation, flat SC, and on B scan there is choroidal detachment. So we planned the patient for corneal scraping with tissue adhesive and BCL in OR. After 3 months, tissue adhesive was removed. Then SICS with optical iridectomy done was after 10 months. And this is 2 months post-cataract surgery where the best corrected visual acuity becomes 618. This is another case of HSV keratitis with secondary infection where we applied the tissue adhesive. This is another case where the patient is one-eyed, where he presented to us with hand movement vision. There is a history of recurrent attack of HSV keratitis. There is PED with secondary infection with central impending perforation. So we planned the patient for tissue adhesive, and this is after 1 year. The patient is doing well. The next option is Tenon's patch graft. If the corneal perforation is more than 2 mm, then we can go for Tenon's patch graft, but the main contraindication is infective etiology. So this is a case of this is a male patient, 45-year-old with best corrected visual acuity PLPR. Here we can see 3 into 4 mm corneal thinning with impending perforation and complicated cataract. So in this particular case, I did Tenon's patch graft. In all Tenon's graft, I use fibrin glue. So first I removed the surrounding corneal epithelium. The Tenon's graft is obtained from the inferonasal part. It's in all cases I make a tunnel because it is easy to handle the Tenon's graft. If we make a tunnel 360 degree, then after that I put the graft on the tunnel, and so that it will snug into that particular thinning particular area properly. Then after that, fibrin glue is used, first the thick component followed by the thin component. Normally all cases of Tenon's patch graft, I use 2 infinity sutures, and the central part of the cross should be in the central part of the graft, so that it will be it will support the graft properly. Obviously the donor area should be closed properly with fibrin glue, and the BCL is placed. So this is first post-op day. As we can see, the AC is well formed, and then graft is in place. So we can remove the suture after 6 to 8 weeks. In between, we can replace the BCL. Another option is lamellar corneal patch graft. If the corneal perforation is more than 4 mm, then if it is a mid-peripheral or peripheral location, then we can go for lamellar corneal patch graft. So this is another case, 45-year-old female who presented to us with corneal foreign body injury. There is deep infiltrated central corneal perforation. As we can see in this slit lamp photography, the shadal test was positive. Posterior segment was within normal limit. So this in particular case, I did lamellar corneal patch graft. First I removed the foreign body and sent it for microbiological examination. Then I used a 3 mm Trifine, and the AC was formed with viscoelastic. After that, the necrotic tissue is removed carefully, and I try to secure the descent membrane as far as possible, and only try to remove the infected part. Then the donor tissue is used, which is of 3 mm. Then I remove the descent membrane from the donor tissue. Then 4 suture is applied, and which is followed by 8 suture. The graft is well apposed, and the AC is well formed. BCL is applied. This is the first post-op day. As we can see, the AC is well formed. The graft host junction is well apposed. The sutures are intact. If the another option is amniotic membrane graft. Amniotic membrane graft, it has anti-inflammatory property, and we can use it if the site of perforation is in the peripheral part, and the main contraindication is infective etiology, and normally actually it helps the stromal cells to grow, and it incorporated into the tissue, so it gives volume to the tissue. So I'm not going to discuss the method much, because Dr. Neeti ma'am, she will be discussing it in her presentation. Another case is like sometime we need to use combined procedures. Like this is a case of 60-year-old male, known case of rheumatoid arthritis. He was on treatment with rheumatologist, but presented to us with peripheral corneal perforation as iris prolapse. So I did banana patch graft for this particular case. The patient was doing well for 1 month, but after 1 month there was graft infiltrate and melting was there. So I did wet amniotic membrane graft for this particular case, and after 3 months following AMG, the patient is doing stable. The last option is penetrating keratoplasty. If the corneal perforation is more than 5 mm and it is of central location, then we can, like in this particular case where there is corneal meltwell perforation, we should go for full thickness corneal transplant. So in conclusion, it's very important to treat these conditions as early as possible, and there are various modalities to treat this condition, but it's important to know what is the underlying etiology, so that if we treat all those conditions in a timely manner, it can evade the doom. Thank you so much. Any questions? Thank you, ma'am. Thank you, ma'am.
Chemical injuries. She will be talking on a newer grading system for acute chemical injuries, the EPICS.
Thank you, Ruchika, and thanks to all the organizers for this wonderful session. I'm going to be speaking on EPICS, a new grading for acute ocular burns. So first, let's take a look at what the existing grading of chemical injury incorporates. It basically takes into consideration the epithelial defect, where in the limbus, so the limbal involvement and the conjunctival epithelial defect, especially only the bulbar surface. So these are the two parameters that are taken into consideration in the current grading of chemical injury. And the question that we need to ask ourselves is epithelial defect the only parameter that affects outcome in these eyes? The answer to that would be no, because we do know that there are several other factors that have an impact on the final outcome as well as on the healing of the epithelial defect, which includes the inciting agent, the inflammation, the ischemia, the intraocular pressure, and the exposure because of the lid changes. And all these constitute together what we have proposed as the I's and E's in the management of acute chemical injury. And we've also proposed an algorithmic approach to the management of each of these I's and E's, because we know that effective management in the acute stage is the only thing that determines the long-term prognosis in these eyes. And for effective management in the acute stage, we need to have an effective grading system. How does addressing each of these I's and E's improve the outcome? Well, to answer that question, we need to ask ourselves another question as to what are the most common complications in chemical injury, both short-term as well as long-term. On the left-hand side are the problems that we usually see and encounter in these eyes in the short as well as in the long term, and on the right-hand side are the causes that lead to each of these problems. And when you look at what exactly causes the damage that occurs in the acute stage, it is not just the limbal damage and the conjunctival epithelial defect that is currently graded, but also the extent of ischemia, the exposure, and the intraocular pressure that has an impact on the problems that we face in the long term. And as far as the non-healing epithelial defect is concerned, which is what ultimately gets affected when none of these are addressed appropriately, you might end up requiring a lamellar or a penetrating keratoplasty in either the acute or the chronic stage because of the stromal scarring, the stromal melt, or a perforation that could occur in the acute or the chronic stage in these eyes. And any of these procedures
worsens the long-term prognosis in these eyes. So I think it's time that we need a more robust grading system to prevent these complications from occurring. And towards this, we first need to understand what a classification system should provide. It should include the direct effects of the disease. It should provide us with prognostic information, guide us with respect to treatment, have the option of assessment for risk and potential complications, and help us to monitor and manage these eyes. Do the current systems provide us with an option for each of these criteria? The answer to that is no. In fact, even for the direct effects of the disease, the current classifications only cover just a part of what actually involve the direct effects of the chemical injury. So what are the direct effects of a chemical injury on the eye in the acute stage? Of all the I's and E's that we mentioned, if you have to look at what the direct effects of the injury are, it is the epithelial defect, the pressure, the ischemia, and the exposure, which is what we have given the acronym as EPICS. And when you look at the current classification system, all that it incorporates is only the E, and even in the E, only the limbal and the conjunctival aspect of the epithelial defect, and not the corneal and the tarsal. So with this background, we proposed the enhanced grade generator for acute ocular chemical injuries, or EPICS, which clearly explains how each of these parameters need to be graded, and with respect to all the four parameters. And this is a very short video which takes you through the online grade generator, which is freely accessible to one and all, where you enter the demographics of the patient, choose the agent of injury. You also have the option of mentioning whether it is the first time that you're seeing the patient or it's a follow-up, whether it's a unilateral or a bilateral injury, and then which eye, and then choose the grading for each of the parameters that I just mentioned. And once you have populated each of these cells, you will be able to generate, evaluate and generate a diagnostic number, which will tell you what the E, P, I and X in that particular eye or in both the eyes are. And the goal in the management of acute chemical injury is to arrive at E0, P0, I0, X0. So you have an endpoint that you need to reach to, and this classification system helps us to more comprehensively grade these eyes. Like in this eye, with the existing classification, all that we know is it's an acid injury with a limbal involvement of 3 clock hours, conjunctival involvement of 25%, which is a grade 3 injury. Whereas with the EPICS, you will be able to say that it's okay, acid, unilateral on day 2, E3, P plus, I1, X0. So you know what each of these parameters are and what needs to be addressed, so that you come down to E0, P0, I0, X0. These are two eyes which, according to the existing classification, can both be graded as grade 6. This is the outcome of the eye on the right hand side with a 6/9 vision, which underwent only an alloslet in the acute stage, which was a unilateral injury. And this was the outcome in this eye, which required a keratoprosthesis with a 0.7 cup disc, where the glaucoma had to be managed aggressively. A type 1 K-Pro was done. So when you look at the EPICS classification for both these eyes, you can see that it actually tells you what is happening to each of the parameters, what needs to be addressed, and also tells you whether it is a unilateral or a bilateral injury, because that again changes how you would manage these eyes in the acute stage. So EPICS is, we believe, a comprehensive grade generator. It's dynamic. It can be printed and uploaded as a PDF to your EMR. It includes the laterality, the agent, the day of presentation, and all the components are clearly graded, gives you a very clear endpoint, and helps you to avoid unwanted complications that occur from non-addressal of crucial factors, because there are still several primary caregivers who don't know that these are issues that need to be addressed, and all that is done is an amniotic membrane or sometimes just topical medications, till ultimately the patient ends up with a perforation and you end up losing the eye. So when you compare the EPICS to the current classification with respect to all the parameters that a classification system should provide, the answer to most of the criteria for EPICS is a yes, though we still really do not know what we are prognosticating at this point in time. So we would not go into that aspect of it, but EPICS is probably the next logical step to the existing classification systems, which has been indigenously designed and conceptualized. It's dynamic, it's very user friendly, and it is freely accessible to one and all at the ocular surface portal. I'll just quickly illustrate this case, a very severe chemical injury, where you can see what the grading is for the right as well as the left eye, where what we did for the E was an alloslet, for the I was tenonplasty, for the X was a skin graft. What did we do for the P? Because this was a low pressure eye over here. Despite systemic steroids, the pressure did not improve. An axial length of 15 millimeters, a soft globe. We went ahead, removed the lens and did a vitrectomy with the insertion of silicone oil. The left eye was very severely damaged and could not be salvaged. She underwent a Boston type 2 K-Pro with oil in the right eye and ultimately has a vision of 660 in that eye over a period of follow-up of 1.5 years. So it clearly tells you what all needs to be addressed so that you get the eye quickly to E0, P0, I0, X0, so that you have a globe that you can salvage and give back vision even in a very severe chemical injury such as this, because sometimes these eyes just perforate if you do not address them appropriately in the acute stage. So this is what we had published in the Indian Journal of Ophthalmology. I would like to acknowledge our technology partner as well as the entire team back home at SN. Thank you.
I have a question. I mean, we've seen this presentation and paper in I think it's a landmark work. I have one question which is little deviation from the classification itself. I mean, with your and your previous team having such a vast data, I have a strong belief that the reaction to a chemical on a body anywhere is dependent on his or her status of how the body responds. That means the state of immune response it generates. That's why, you know, there are people who survive acid attacks without having any damage. There are people with little goes into a melt and other things, alkali and other things. So can we look at taking this same data, add the systemic profiling, or in future add some like basic things like IG, asthma, smoking, or anything which brings down the immune profile, and add the data onto an AI kind of a big data thing? I think it will create a bigger landmark because it will give you a prediction from a patient host factors. For example, I know that if somebody is taking oral contraceptive pills, that itself is a slow immune deviation because it's changing the hormonal process. So somebody who's not taking, somebody who is on treatment for asthma. So I think my thing is with such beautiful data, it can add more value from a patient stratification point of view as a risk factor, if it's already not been done.
No, it's not being done. It's an absolutely utopian thought and would be wonderful if we could get there. The hurdles that we are facing to even get this into implementation is huge. So the first step would be to try and see if we could have everybody on board to make sure that, you know, some kind of uniform classification is used. But I completely agree with what you say, that there are factors beyond the eye which are going to have an impact on how the chemical injury responds and heals. And if we could zero in on a few factors which we think are extremely important with respect to healing, because otherwise we would just be looking at several factors. So we would have to zero in on some of the key issues in the systemic aspect which would have an impact on the healing in the eye. Yes, so we will have to collect the data and have another column which will tell us what are the systemic factors that are present in the patient, and then see whether similar grade injuries healed in a different manner. So that would definitely be probably the next step that we could take this to. Thank you.
Or firecracker injuries where there's a thermal component, a chemical component, as well as the effect of the blast itself. Like, does this grading apply to them? And
yes, to everybody. In fact, that's the reason why we have included and incorporated a multiple choice as far as the agent is concerned, to include both acid and thermal, or the mechanical aspect of it also. Now, what happens with a mechanical injury is it could lead to stromal edema. What happens with a fire trigger injury is it causes more ischemia. But the basic underlying parameters that need to be addressed in the acute stage still continue to remain the same, probably a little more aggressively when it is a thermal injury in addition to a chemical injury, and maybe a little less aggressive when it's just a chemical injury causing ischemia. But otherwise, the 4 parameters which have to be addressed, irrespective of whether it is a combination of factors or a single factor, remains the same.
Thank you, ma'am. I invite our next speaker, Dr. Neeti Gupta, who will be speaking on the management of acute chemical injuries.
So at the outset, I would like to thank Dr. Saurabh for giving me this opportunity. So I'll be talking on management of acute chemical injury. So we all know that chemical injuries are because of exposure of irritants, acids and alkali, and the severity of the disease depend on the type of the causative chemical substance, concentration and its physical form, the duration of contact, ocular surface area affected, and the delay in the medical attention. And worldwide it's been seen that 2.2% to 13% of all the ocular injuries comprises of chemical injuries, and the highest incidence is in children younger than 5 years because of the domestic accidents with household cleaning products, and in adults in context to both domestic and work accidents. Till now we had a lot of classifications where we used to follow Roper Hall and Dua's classification, and just now Dr. Geeta told us about the EPICS classification, which is like we all are now like understanding that, and we all are registering to that. And the management protocol basically depends on the immediate or the acute phase, which is from the first second to the first week. And the objective is to re-epithelialize the surface, control the inflammation and prevent early complications like infections and glaucoma, etc. So the first thing to do is to irrigate the surface. Just before the examination also we need to first irrigate for at least half an hour with whatever neutral fluid we have, and we can then give topical treatment like corticosteroids to prevent inflammation, and antibiotics for infections and artificial tears, oral doxycycline on vitamin C for prevent the collagenolisis. Then tarsorrhaphy or a BCL can be used for the initial phase. Then intermediate or early reparative phase comprises of first week to 3 weeks, and the objective here is again to focus on promoting the corneal re-epithelialization, inflammation and preventing the complications. So here we can consider amniotic membrane grafting, tenons advancement flaps for scleral melting and ischemias, and topical steroids and antibiotics and lubricants, and also we can do a yellow slit for early epithelialization of the surface. In the late phase, which comprises of 3 weeks to months or years, then again we have to address the dry eye issues in these cases by lubricants. Then total or partial limbal stem cell deficiency can be addressed by alloslits or conjunctival autografts. Then corneal transplants can be done in cases where there is endothelial damage along with the surface damage, and lid malformations, and also to treat glaucoma in this phase. So I'll be just showing a spectrum of diseases, presentations of chemical injury. So here you can see in the first picture, number 1, you can see an eye which appears to be quiet. This is post-Chuna injury, and the patient presented within 3 to 4 days to us, and after staining you can see the actual picture of the epithelial defect. And this patient healed within 3 weeks on topical steroids and antibiotics and lubricants. This is another case with again a tuna injury. She presented to us after 1 week of chemical injury, and this patient, by looking to the picture, it appears as if it is a very severe injury by seeing the corneal haze. Limbal ischemia was not much, and here also we gave only topical treatment, and there was an impacted tuna in the superior fornix. So we removed that during the irrigation, and then we started only on topical steroids and antibiotics and tears. Here I gave the patient oral steroids also. So you can see the epithelial started healing, and by 3 months the cornea was absolutely clear without any damage. This is another case of again an impacted tuna injury. This was a small 6 years old girl, and there was in the second picture in the left side you can see there was again an impacted tuna. So we removed that, and since this patient presented after 10 days, so we went ahead and did a Tenon's advancement flap with an AMG, and this is the 9th-month-old picture where the corneal epithelium healed, but there was a lot of vascularization still present on the surface, and we continued on tears in this case. So the visual acuity was 612. This is another case of tuna injury with moderate, it appeared to be moderate. There was total epithelial defect, but around 3 clock hours of limbal ischemia. Both the eyes were like this, and we did an AMG in both the eyes with tarsorrhaphy, and you can see after this picture is 3 months old, best corrected visual acuity in the right eye was 6.9 and the left eye was 6/6. Another case with a very severe chemical burn, and this is again a child with tuna injury, and this was a grade 6 chemical injury. This was the right eye of the patient, and this the left eye of the same patient. So in this case, I did an allo slit with AMG with total tarsorrhaphy in the right eye, and we continued with topical eye drops in the left eye. And the outcome of the right eye was a total conjunctivalization of the whole surface with the tarsorrhaphy intact, and later on we did a slit in this case. In the left eye, the best corrected visual acuity was 6/6. This is not a chemical injury but a thermal injury where you can see limbal ischemia with scleral melt, and also the lid was also charred. So here we did a Tenon's advancement with an AMG, and this was during the COVID time. So the patient was on steroids and he couldn't come for the follow-up, and you can see that at 7 months, in the 5th picture, there was the lid was adhered to the cornea. The patient could not move the eye also when he came to us. So in this case, we did a conjunctival autograft and an MMG, partial MMG in the medial side with an AMG, and this is the 3rd and 4th picture are the 1-year-old picture after the surgery, where the vision is 6/12 and the lid is well epithelialized. Now this case is this is a chronic case. He came after 2 years of chemical injury with partial limbal stem cell deficiency. He was giving a history of some allo slit done in some procedure like slit done in the eye, but there was you can see a small part of the cornea is still clear. So in this case, I just did a 360-degree conjunctival autograft, and you can see the last follow-up, the post-op 3-month picture, the cornea is relatively clear. There was a high astigmatism, so we gave a scleral contact lens to this patient. Another chemical injury with partial limbal stem cell deficiency with severe dry eye. Here also we just did a superior conjunctival autograft, and the patient is doing very well. Another girl with a partial limbal stem cell deficiency post-tuna injury. She presented 1 year later. Here also we did a 360-degree conjunctival autograft, and the last picture you can see the cornea, central cornea is clear, and the patient had 6/9 vision. So we just wait until and unless there is no problem in the cornea or the vessels come again, then we can plan a slit in this eye. This is a patient of total limbal stem cell deficiency, again a tuna injury, and this patient came after 3 years, and he still had a persistent epithelial defect. So we did an AMG with tarsorrhaphy, stabilized the surface, and then we did a slit in this case. And since the endothelium was also damaged in this eye, so later on we planned a keratoplasty, and this is a 10 months old picture. The BCVA was 6/6 with a normal IOP and posterior segment. So this is the overall picture, and if you can see, the top row shows all the patients who were not managed in the way they should have been managed in the acute phase, and the lower down pictures are our patients where we treated with either AMG or advancement flap and MMG, so they all have a good vision. So just to emphasize the fact that the initial treatment of these patients are very, very important for the long-term management, long-term result. Thank you.
Very challenging cases and beautiful outcomes, Dr. Neeti. I'll just take a quick comment from Dr. Geeta on this. We are running quite late.
I think you very rightfully brought out all the important aspects of managing these patients, and I think one of the cases you also mentioned that there is some amount of conjunctivalization that you see, and in these cases we don't rush in and do anything immediately as long as the central corneal clarity is maintained, and only if there is a failure then you go in for a top-up slit or a re-slit in these eyes. But otherwise management, I think that's the bottom line, that management in the acute stage is what determines the long-term prognosis.
Thank you, Dr. Geeta. Our next speaker is Dr. Prafulla Maharana, and he'll be speaking on DSEC in challenging situations.
Thank you. Good afternoon all. So I'll be speaking on DSEC in special situations like it's not moving. आगे नहीं जा रहा. So okay, so nowadays DMEC is the treatment of choice for endothelial dysfunction. However, there are some special cases where I think you'll have to resort to DSEC. I'll be going few of through those videos now, but you have to remember, although when it comes to visual outcomes, DMEC is much better than DSEC, but there are few things where DSEC scores over DMEC. So most important is learning curve. DSEC, the learning curve is not that steep. Tissue manipulation, endothelial loss, immediate post-op graft detachment, all these things are less with DSEC compared to DMEC. And one important advantage even that we realize at RP center is donor age. The DMEC, you have a very narrow age group. You have to have a tissue between 50 to 70 years. But DSEC, you can take young tissue as young as 10-year-old tissues. Primary graft failure is again little bit high in cases of DMEC. And whenever there is difficult situation like media age or intersegment abnormalities, DSEC is always better to go for compared to DMEC. So this is one case. It was a 60-year-old lady with pseudophakic corneal edema. She had some ACL which was fixed to angle, and some it was tucked inside the iris. So I did the diphtheral debridement, and I'll not go through the each and every step of DSEC. So that will increase little bit of my visibility. I prefer corneoscleral tunnel for all my DSEC patients, except where the patient may need a trab in future. So as you can see, the Desmet, now I'm doing the Desmet scoring. I do a standard 8 mm scoring. This was the mark put on cornea. The IOL is too huge, so it had to be cut because I need a 3.5 incision for my Bushin glide. So I didn't want to make a bigger incision than that. So the IOL was removed, and as you can see, some vitreous was there when I was trying to get it remove that. And after that, as for Ang et al., if your AC depth is more than 2.5, you can always go ahead with a ACL and then do a DSEC. The results are excellent. So I did an ACL in that patient, and then this is the classic bimanual push and pull approach using Bushin glide as a crocodile forceps. The advantage of DSEC is once your tissue is inside the antechamber and you have appeared little centration and you have injected air, it is very rarely that the graft will not stick or it will displace. The same thing is not true for DMEC. If you do a DMEC when vitreous is there in AC and you have done some iris manipulation, there is a lot of fibrin release, the graft tend to fold on itself, and the flap they becomes very sticky, and it's very difficult to unfold and reattach the graft. This is just to show you the predictability of graft. In DMEC, when especially in India, nowadays people have started preparing the pre-peeled DMEC tissue, especially LBP. However, the DMEC peeling of the tissue, there may be a loss of tissue. But if you have a microkeratome, as I'm highlighting here, I'm using a 400 micron head. So ultra thin DSEK, where the thickness of graft, as you can see here in the microscope integrated OCT, if it is less than 100, the visual outcome are as good as DMEC. So if you have a microkeratome, again you can go for ultra thin DSEK. It was a 90-year-old lady. She had a lot of systemic ailment, and the other was thysis bulbi. She was one-eyed, she was aphakic with some corneal edema and haze. So my goal here was that just to give her some cornea clarity so that she has some ambulatory vision, and the systemic condition never allowed me to go for repeated 2 or 3 procedure. It was only one time under cardiac monitoring we did the case. So in such cases where you don't have the option to take the patient to OR again and again, it's better to go for a DSEK. Here I am putting a stay suture in my graft, because in aphakic patient, there is, especially when there is media haze and iris is defective for cis loci, there is a risk that the DSEK graft may drop into vitreous cavity, and that would have made my life difficult. So I put a stay suture. Once my graft is inside and I have injected little bit air and I have got my desired centration, then I can take out that stay suture out of the tissue. So it's quite easy, just cut it and pull it out. This is a microscope integrated OCT. As you can see, DSEK, the graft is quite well attached inside of a lot of a pass in the periphery. Still you can manage. So in such cases, it's often impossible to do DMEC. This is the third case. It was a case of xeroderma pigmentosa with a failed therapeutic graft. As you can see, there is massive vascularization all around. So doing regraft or PKP was not easy. DMEC, again, it was difficult because there are 360 pass at the graft host junction. So again, the procedure to go for in such situation is DSEK. Here I have little bit stain the tip of the graft because the media was very hazy, so I might have struggled with identification of the side of the DSEK. So I have just put a mark at the tip of the graft. But again, as I said, in DSEK, once you have inserted the graft, centering the graft and getting that attachment is quite easy. As you can see here, microscope OCT, I am screening all around. My DSEK is inside the posterior graft host junction, and you can see here a lot of adhesion between iris and the graft host junction. So I did not to release anything. I just put a graft and came out, and the patient is still doing well. So this is the last video. This was a video of CHED, and this was quite early in 2012 when we were just starting doing DSEK in CHED, and there was only one report by Busin of DSEK in CHED patients. So here again the same technique of corneoscleral tunnel, and that time we were not sure that whether to score the DM or not, but nowadays it is clear in CHED don't strip the descemet membrane. So again the same technique with Busin glide push and pull technique. But here I would like to highlight the media is so hazy. In such patients, performing DMEC is next to impossible. With DSEK also, the tissue visibility is very poor, but the moment you inject some air into entire chamber, as you can see this 2 ring. And the moment you see this 360-degree double ring, then you are sure that my graft is well attached. That time we didn't have MIOCT with us, so it was all based on clinical judgment. So to conclude, there are few special cases where a DSEK is preferred over DMEC, except probably those surgeons who have done more than 1000 DMECs. So like complicated intersegment situation, poor visualization, aphakic patient, or patient is having glaucoma implants, or this large iris defect, or hypotonic eye where PPV has been done previously. We get a lot of such cases at RP center with operated PP with PBK, or in cases where you have only one chance to operate. Okay, so in all this situation, it's always better to go for DSEK rather than DMEC. With this, I'll conclude here. Thank you very much. DSEK, if you allow me 1 minute, I'll tell you our experience. It was Dr. Rasik Bihari Bajpayee who started DSEK in CHD at RP center, and I was his SR. So the first graft that we did, the next day cornea was massively edematous, and sir got really frustrated कि क्या कर दिया हमने. Then we sent the patient back. The patient was from Indore, and we asked him to follow up there only. After 3 months, when he came to our OPD, both of us were surprised. The cornea was absolutely clear. You know? So in CHD, if you do DSEK, immediately the result may appear disappointing. but give it some time. Within 2-3 months, the corneal thickness, the haze, everything comes down. So visual vision is as good as PKP.
Thank you, sir, for these beautiful videos. So another, I think, challenging situation is the floppy iris, because it's very difficult to manage the air bubble if the iris is very floppy. So what are the surgical pulse for those cases?
Doing DSEC or DMEC?
DSEC.
DSEC. See, DSEC there is no problem at all. I am telling you, if you have done more than 10 DSEC, even if it is a floppy iris, if you have injected air and you could achieve some tamponade, let it be 2 minutes, then the graft is not going to move at all. So even if it's a floppy iris, the only thing that you may face the problem is when you make a full thickness entry to insert the graft, the iris tend to come out from the wound. For that, what you can do is you can ask your assistant to put a Sinsky or anything like that over the iris, or you can use sheet glide. Sheet glide, although we don't use it at RPC, LVP, I think most commonly they use sheet glide. Sheet glide is quite useful in Indian eyes because it is above the iris and you are pushing the graft onto it. The floppy iris is never going to come out from the main one.
So sometimes it comes up from the side port, from where we have to push the...
then you have to check for your AC maintenance parameters. It's very unlikely that if you are not increasing pressure too much into chamber, the iris should not be coming out. Even if it is coming out, don't worry. Once you have centered the graft, inject some pilocarpine, do some tap movement and try to push the iris behind. Usually the iris goes behind once your graft is well centered.
Thank you, sir.
Just one comment, last Saturday I did a DSEC for a nanophthalmic kind of eye, and I just cut a 7.5 mm graft, and the moment I put it inside the eye, it was very surprising. The graft was reaching, almost up to the limbus. So somehow I did manage to complete the surgery, and I was pretty satisfied कि चलो हो गया. And next day I see malignant glaucoma. So any tips in such cases?
So I haven't done DSEC in nanophthalmic eyes, but I have done it in eyes with IFC. Okay, so IFC with small cornea. So in such cases you have to take a small graft. You cannot take a large graft. Your graft and between the angle there should be a gap of at least 1.5.
But that's not actually the cause for the malignant glaucoma.
Malignant glaucoma, it has its own causes. Yeah. So intra factor that plays the primary role in
Probably,
that.
You can do a iridectomy
be
and go
careful
back.
if you are using
and do
AC
a
maintenance, so be careful about the direction of fluid where it is going. If it is continuously going behind,
I generally never use an AC maintainer for a DSEC. That was just a big. Yeah, you can't expect some things.
I'm sorry, but we are really
You have
running
every
late.
right
Can
to
we
interrupt
quickly
us.
just?
Thank you.
I'm sorry. Thank you for the talk. Really challenging situation, sir. Next we have Dr. Devesh. He's going to be speaking on rheumatoid arthritis and dry eye.
So it's not playing here. It's just playing on my laptop. Screen on screen too. Yeah, okay. So I'll be presenting on rheumatoid arthritis and its various anterior segment manifestations, dry eye and others. So it is the commonest, by far the commonest autoimmune disorder that affects the anterior segment of the eye. And patients, you generally have a patient who is a female in her 30s, 40s or 50s, coming in, with stiff joints, particularly the small joints of the hands and feet. And it is now generally well accepted that upon diagnosis, rheumatoid arthritis has to be treated aggressively without appropriate effective DMARD therapy. About half of these patients, particularly those who have a vasculitis, would be dead within 5 years of onset. So I'll be skipping the systemic features. Just in short, it is the typical, the small joints of the hands and feet that are affected, and the patient would generally complain of early morning stiffness and painful movements. This is a clinical, the classification for the clinical diagnosis of rheumatoid arthritis. 6 out of 10 of these criteria have to be positive, and they take into account the number of joints, the types of joints involved, the serology, acute phase reactants, and the duration of symptoms. So these extra-articular manifestations these days are less commonly seen with early and aggressive treatment of rheumatoid arthritis, but it is particularly important to remember factors that indicate the presence of systemic vasculitis, necrotizing scleritis, PUK, a vasculitic skin rash, skin ulceration, neuropathy, and cryoglobulinemia. These are basically poor prognostic factors for life, and without treatment, as I said, 50% of these would be dead within 5 years of onset. So by far the commonest ocular feature of rheumatoid arthritis is dry eye, which would affect up to 1/4 of patients. And usually most patients who develop ocular complications of rheumatoid arthritis, be it dry eye or scleritis or keratitis, tend to have the disease for a slightly long duration with high titers of rheumatoid factor. So you would have the salivary and the lacrimal glands infiltrated with lymphocytes and other inflammatory cells, and these histologic changes tend to progress as the duration of the disease progresses, leading to hyposecretion with other downstream events like hyperosmolarity and tear film instability. So apart from the usual signs and symptoms of dry eye, which are usually found in other cases, RA-associated dry eye tends generally to be a little severe with low Schirmer values and punctate staining of the interpalpebral ocular surface, often with filamentary keratitis and mucus plaques. Long duration, you may have a limbal stem cell deficiency as well. So apart from the usual management of dry eye cases, punctal occlusion, particularly punctal cauterization and scleral contact lenses, are particularly useful in these cases. Punctal cauterization is particularly a cheap and quick procedure. You can do the lower lid or the lower and the upper lid, and the patients usually find significant improvement in symptoms. After dry eye, scleritis is the next most common entity associated with rheumatoid arthritis, and the moment you find a patient with a scleritis or with a keratitis, it is important to communicate with the rheumatologist that the patient is consulting to control the systemic vasculitis. You just don't have to treat these things topically, locally. So there is granulomatous inflammation and vasculitis that you find in association with scleritis. All forms, clinical forms of episcleritis or scleritis can be found in association with RA. You may have a nodular or a diffuse episcleritis, scleritis. It may be anterior or posterior. You may have necrotizing scleritis with or without inflammation. So this is not basically RA scleritis. This patient was ANCA positive. So generally speaking, vasculitic syndromes like Wegener's granulomatosis tend to have much more severe scleritis clinically. The collagenosis like SLE tend to be associated with lesser severity of scleritis, and RA-associated scleritis falls somewhere in between the two. So Dr. Ruchika has already spoken on peripheral ulcerative keratitis, and the peripheral cornea is particularly prone to get involved in these collagen vascular disorders because of its proximity to the immune system, to the perilimbal capillaries. And these different forms of keratitis have been described in association with RA. You may have a peripheral, peripheral keratitis in association with a scleritis called sclerosing keratitis, or you may have a typical crescent-shaped epithelial defect with infiltration, a typical PUK which heals, leaving this kind of a picture. Sometimes, you may need to resort to a corneal patch graft if you come across a perforation. This was a patient with PUK, was on immunosuppression, and came up with HSV keratitis. This was another one with RA, severe dry eye, and this acute peripheral stromal melt. We had to do a punctal occlusion, and this patient had got an IVMP for her condition. So, necrotizing scleritis, PUK, basically highlight the presence of systemic vasculitis. It is an urgent medical condition. Communicate with the rheumatologist. Topical treatment is not the end of the therapy. You have to start with systemic steroids, IV methylpred sometimes, and the rheumatologist has to step up the immunosuppressive therapy. In cases of actual threatened or actual perforations, you may need to do a TABCL or a corneal scleral patch graft. So maintain a good communication with a rheumatologist while treating all of these patients. Thank you.
Thank you so much, Dr. Devesh, and I'm sorry to cut short. We can take the discussion over tea or outside because the next session is waiting and we've just taken some extra time. Thank you so much, and we can have a quick photograph outside, please. I've been given warnings by Dr. Saurabh, so.
I was a bit told many times that this is our session.
Good evening, all the delegates. Now our next session is on pediatric ophthalmology. First, I would like to invite chairpersons, Dr. Sandeep Mittal, Dr. Amit, Dr. Smita Mehra, and the panelist, Dr. Arun. I think no one is here. So, we will start with our first topic, that is on the pediatric retinoplasty by the Dr. Abha Gaur.
Thank you so much. I am privileged to be speaking in between pediatric ophthalmologists. Generally, I am delivering this talk amongst cornea specialists, but then I think it's a topic relevant to all of us. Yeah. So I will start with this case. He's a 3-year-old child with dubious history on treatment from elsewhere with topical antibiotics and antifungals. And we did some scraping and we found there were some pus cells, but the child was not very symptomatic and was also quite cooperative for examination. We did find that sensations were reduced. So we diagnosed him as herpes stromal keratitis and he was put on treatment for the same. In 3 days, he showed symptoms of healing, and 7 days healed better. At 2 weeks, he had healed with a scar, but the vision was 2/60. Now, at his age, this is something that needs an intervention, and it cannot be left as such. So, ultimately, at 6 months, the scar had lightened more, but then he did need a keratoplasty. So some special considerations for keratoplasty are the timing of surgery, that is, when do you operate and how soon can you operate to prevent amblyopia, infections, risk of infections on the graft, and also rejections. The most common problem that we face in our country especially is follow-up and compliance to treatment, and amblyopia management as well, because then again that is a major factor of compliance which comes into it. The most common indications are, at least in our setup, are acquired non-traumatic, that is healed infectious keratitis with a corneal scar. At times we also see ice or extensive iridocorneal adhesions. In this case, the image has been taken very well because there is central clarity still, but then this does not remain over a longer period of time. There are also multiple case scenarios with coexisting pathologies that most commonly seen are keratoiridolenticular dysgenesis, some post-trauma scars, post-infectious keratitis, congenital glaucoma, and CHED. So here a significant percentage of these indicators have no to minimal visualization of the anterior chamber, and hence the problem in the planning of the case as well. There are multiple preoperative issues like complete pre-op evaluation of the corneal pathology is usually not possible. There's also need for multiple specialized investigations such as UBM, etc., which warrant an examination under anesthesia. The IOP evaluation may not be very accurate in these opaque corneas, and the patient has to also be evaluated for multiple systemic associations because you will need repeated EUAs in these cases as well. Intraop is definitely the small size of the palpebral fissure. Putting a speculum in them at times is a problem. Lowering of the intraocular pressure, hypotony to have optimal definition of the recipient cornea. This happens if once general anesthesia is adequate. Also, it is caution to be excised when there is performing scleral fixation. Because of the thinness of the sclera, there may be a higher risk of perforation. Fleringa's ring is a must. And also need for performing associated procedures such as lensectomy, vitrectomy. These need to be assessed in the beginning as such. There is increased positive pressure of vitreous because with a forward shift of the lens iris diaphragm, and there may be difficulty in suturing as well because of the tissue structure at that point of time. Post-op management definitely need a lot of EUAs, and it is very dedicated both for the parents and the treating doctor. Also, post-operative medications need to be checked very frequently by the parent. Also, appropriate management of sutures, close watch for rejection, and frequent correction of refractive errors is needed in them to prevent amblyopia. There are still multiple complications that you have, like graft infiltrates, loose sutures which have been neglected, multiple suture related problems as such, like leaving loose sutures on the cornea, And then when to remove these sutures becomes important as well. The child needs multiple EUAs during the first 2 months after a keratoplasty in children less than 6 months of age, and generally all sutures are usually removed within 3 months in a child who's less than 6 months of age. Rejection again becomes important. So graft rejection is thought to occur more quickly in children due to an amplified wound healing response, and endothelial immune rejection leading to graft failure is one of the most common causes of graft failure in children. Then post the surgery, considering you have a clear graft, refractive correction in children is also important with spectacles or contact lenses. This is generally not acceptable. Contact lenses have not been very well accepted by the parents, and it is difficult to get their compliance in using them. And even post that, patching and amblyopia management still is something which is not discussed. Pediatric EK again for CHED is now very common, and cataract formation though is definitely a concern. There is increased possibility of iatrogenic damage to the crystalline lens while either inserting the tissue or with air bubble management, and prolonged exposure to the lens to air tamponade to keep the donor lenticule in place is important. So this is a small video of a child who had presented to us with congenital glaucoma in both eyes. He underwent trap plus trab in both eyes followed by a tube, and then underwent a keratoplasty in one eye followed by the other. With his right eye, he continued to do well, though the left eye had an infection and endophthalmitis, because when you have a tube in place, it is difficult. There is a communicating chamber, communicating channel which allows for infection to enter. Though he manages very well with his one eye, but then definitely this is not a very desirable outcome. So it's definitely a long road ahead. Thank you.
Thank you, ma'am, for such a wonderful talk. Any comments?
Excellent presentation.
Thank you.
Thank you. Any comments? Any corners? Dr. Davis, maybe.
Thank you, Dr. Abha. Actually, it's like very challenging to do keratoplasty in small children, but it's very difficult to actually to remove the sutures. So it will require repeated EUA, but very nicely presented. Thank you.
So I know it is definitely a major challenge, but then it is very rewarding to see the outcome as well.
Exactly.
So even though this child had not a good outcome in one eye, but at least he's seeing something. So it's just follow up.
Yes. And another thing is amblyopia management is also important after the surgery. Yes. Okay. Thank you.
So our next speaker is Dr. Mrinal. He will talk on the management of pediatric traumatic cataract.
Thank you. Since we're already running late, I'll try to finish up early. Basically, I'll be talking on the management of the post-traumatic pediatric cataracts. As we all know, in India, the childhood blindness, almost 15% is due to cataract, and incidence is about 1.8 to 3.6 per 10,000 per year. But here, mostly it's some congenital or developmental or other metabolic causes, and trauma is a known factor of all of this. So there are some particular challenges in management of a pediatric cataract, like increased post-op inflammation, capsular opacification, which occurs in almost 100%, growth of the eye, which will constantly change the refraction, then tendency towards developing amblyopia if it is not treated well, difficulty in documenting the anatomic and the refractive changes also due to the poor compliance of the patient. You have to take the patients again and again to for UA or even other type of investigations. In particular challenges in a traumatic cataract is, if I say it's the time of presentation from the trauma associated any other injuries like corneal or lid or even retinal or annexal injuries, inability to obtain the IL power to be implanted, retinal evolution usually is inadequate because of the corneal or other involvements, and any history, anything done earlier will lead to a better bad outcome. So basically there are some advances also which gives you some improved outcomes, like early surgery to prevent amblyopia, traumatic surgery, complete removal of the lens filter, and benefit of in the bag IOL implantation with titration of the IOL power. And we should educate the patients attendance for some prudent follow-ups. So I kept this slide like this populated just to show that the etiology of the trauma in case of a pediatric cataract might be anything which is in the environment. It might be anything like a stick or any sharp object which the child is playing with, stone, or bow and arrow, thorn, anything. So the etiology might be unknown, but you might just from this slide we can know that it might be anything in the environment of the child. So just a picture of a classification of a congenital cataracts. I'll just go to the some pictures from our image library. This is the anterior subcapsular type. There is one associated with a localized corneal opacity. A job type with associated lead injury, and you can see superiorly there is a corneal opacity. Then it's associated with a firecracker injury, associated corneal opacity is also there. A flocculated lens matter with free cortex in the AC associated with a corneal tear. It's an intimation type, total, almost total. There is a post-C tear. You can see the corneal scar and even the suture marks, and it's a membranous type absorbed cataract. This is a post-scleral tear repair with a primary PC defect. It is again a post-corneal tear repair associated with vitreous hemorrhage. You can see inferiorly. There is one a lens coloboma and a typical rosette type. Just to show that post-traumatic the cataract presentation may be very varied. So we know we all know this workup of a congenital or a developmental cataract. We have some particular questions, like we know, just to confirm whether it's a unilateral, exactly unilateral or a bilateral. Then we have some particular plan of action. We know that exactly how to go about it, and some investigations that needs to be done. But in case of a traumatic cataract, there are some particular questions, like we just have to first confirm the mode of injury, the time of presentation associated with any ocular or systemic comorbs or any other systemic injuries, whether any previous consultation, treatment and surgery has been done. And in investigation, usually we do a ultrasound V-scan routinely and radiology to rule out foreign bodies. Slit lamp photographs definitely has to be done for documentation purposes also in education, and routine PAC for fitness. When we come to management, in case of a congenital or a developmental cataract, we know that the operative procedure for psoriasis, now it's a lens aspiration with primary PCCC with limited entry vitrectomy. We take in the bag with or without optic capsular IOL. The challenges are AC instability, increased capsular elasticity, these are all known to us. But in case of a traumatic cataract, you need to have a plan B, plan C, even a plan D with you, not just a plan A will do. So usually we go ahead with a lens matter aspiration with without partial entry vitrectomy, optic capsular plus minus anecholysis plus minus corneal tear also sometimes, and ID repair or pupilloplasty. So it is usually complicated by poor visibility due to the corneal opacity. Pre-existing PC defect will lead to a poor outcome, and if there is a vitreous prolapse, you need to on table decide and even change the surgical plan. So just to this is a normal developmental cataract. I just wanted to show a few states. So anterior lens capsular policing, posterior PC policing also, and PCCC is done. For these, we routinely use strip and glue to stain the PC, do a PCCC, and a limited tricart assisted, triamcinolone assisted vitrectomy. This is again traumatic with a primary PC defect. The cataract has been done actually. I'm just showing the PCCC done. So we first do a initial nick and with a vitrectomy cutter cut inside the PSC. It's actually I'm not sure whether it's clear there. So we are trying to remove the PC opacity and block, but it's not happening. So we are trying to stay inside the opacity itself. Then we'll use a cutter from the limbal root itself and do a limited vitrectomy. Okay, if it is associated with such a PC opacity, it's very easy to remove it with the cutter itself. So one problem is the IOL power calculations in trauma. So usually we calculate for emmetropy taking into account the age of the child to matching the fellow eye, and usually we follow the rule of 7. I'll just go quickly to some cases. This is developmental cataract only. So this guy presented with a penetrating ocular injury, corneal injury with cataract formation. Primary repair has been done by a cornea colleague and cataract surgery was done later. As you can see, there was a big general defect here, and we had to do a sulcus fixation only with a optic capsule. Later on, he had to undergo a YAG cap also. He is doing well, but myopic shift has occurred now. There is again a pre and post-op photograph of a traumatic PSC, and this video I have already shown. This is another one. It's a pre and post of an intumation cataract when he already had a PC defect here. This use, so we had to do a sulcus fixation only with an optic capsule. Another one post CTR membranous cataract. So again, we just had to do a sulcus fixation with a optic capsule with an optical iridotomy inferiorly. This one is a post-lateral tear. So this guy gradually, progressively started having an optic capsule of the IOL. So we had to take him for another surgery, and actually it was a sulcus fixated IOL. Later on, we had to go ahead and do a PCCC sort of thing and capture the IOL. He's doing well. So I'll just skip this. So basically, the visual prognosis depends on the age of the child at the time of presentation, severity of the opacity, the degree of adherence to the effective correction and amblyopia therapy, and advancements of the surgical techniques and use of IOLs. And the major obstacles which we encounter the implant power calculation, post-op inflammation, associated comobs, axial growth of the cataract extraction leading to deciduophakic myopic shift, and visual excess opacification and PSA formulation. So it's always a team effort. The parents' role are the highest, biggest role. So basically, the take to clinic is the timing of the surgery, from the initial injury repair, comprehensive evaluation before planning the surgery, counseling to the caregivers, and amblyopia management. It must be hammered on their head that the glass is a must. You must use glass correction at all times, and close and prudent follow-ups. Thank you.
Thank you, sir, for such a nice presentation.
Okay.
And so my question is regarding the IOL power calculation. Yeah. Do you follow the same formula just like for the pediatric cataract, or are there any modifications regarding especially the corneal power?
Yeah, exactly. That actually depends on whether we are getting a good corneal reading also. If it is not, then we usually take the other eye.
Other eye.
Other eye.
Normally, in case of post-corneal tear repair, first we should remove the corneal sutures. Once we remove the corneal sutures, then we can go for pentacam and try to find out the K reading. Then after that, we can go for IOL power calculation.
Thank you, ma'am. So our next presentation is a management of the pediatric glaucoma by Dr. Ajay Agrawal.
Very good afternoon to all of you, and because we are short of time, I'll try to be fast. I'll be talking about management of pediatric glaucoma. So these are the patients who come to us with excessive blinking and watering. They have large corneas, many of them with hazy corneas. So we need to remember that glaucoma surgery is the primary option, except when the prognosis for the child's life or that of the eye is very poor. and there are a number of restrictions for medical management of glaucoma in children, as well as the efficacy is comparatively less as you compare with the adults. So this is how we go about managing the patient's goniotomy or trabeculotomy depending on the clarity of the cornea. Trab on trab is a very good option. Modified trab, glaucoma drainage implants, and cyclodestructive procedures. So this is the approach to management, and we need to realize that it is the first surgery which is the most important for the patient. So I usually prefer a trab on trab because of its success rates, and you look at the surgical outcome, examination under anesthesia after 3 to 4 weeks, and check for various parameters including the IOP at periodic intervals. And if it is still not controlled, one might need to do a modified trabeculectomy, but still in very certain cases where the prognosis is very poor, we might need to go in for drainage implants or cyclodestruction. And the thing which is very important about children is that visual rehabilitation is a must in all cases. The goniotomy is safe when performed skillfully for clear corneas. It does not disturb the conjunctiva and incises only the superficial trabecular tissue and is effective in certain cases. Trabeculotomy also has good success rates. Now we have a purse string 360-degree capsulotomy also which can be done. But trab on trab is the most commonly performed surgery in India because of its safety and the success. It is also suitable for compromised corneas and has success rates as high as 90%. So this was a video, but I'll skip it due to lack of time. And the role of antimetabolites in pediatric glaucoma, we need to be very careful when we are using antimetabolites in pediatric glaucoma because it can lead to thin blebs, leakage from the wounds, and sometimes bleb related endophthalmitis as well. Now there was a study which compared the outcome of trab with and without mitomycin C, and they found that neither the intraocular pressure levels nor success rates at 2 years differed between the two groups. In fact, in the mitomycin C group, one patient developed bleb-related endophthalmitis in both eyes, and that is probably one of the reasons why Dr. Mandal, who is a congenital glaucoma specialist, does not use mitomycin C in his patients. Now, for refractory glaucoma, we have drainage devices and cyclodestruction, and you need to be careful when you're using drainage devices, as was shown in the earlier presentation also, that the patient ended up with endophthalmitis. So only when you have failed glaucoma surgeries or complicated cases or neovascular glaucoma do you consider a drainage device in these patients. You have a number of options including your Molteno implants, Krupin and Ahmed, and the Barwelt implants. The only thing to remember is obviously one size will not fit all. So for pediatric patients, this 96 square millimeter FP8 is the one which is preferred by many people as compared to the FP8 which is 7 which is used in adults. So there are various techniques for glaucoma drainage devices including a scleral or a pericardial tube cover, partial thickness scleral flap, or the tunnel technique which works best in your hands is the best technique for you. So GDDs in refractory glaucoma, there are more complications, small eyes, thin sclera. So there was a comparative study between trabeculectomy with MMC versus these implants, and they found that the post-operative complications requiring surgical revision were much more in the implant group as compared to the MMC group. However, the success rates were higher in the implant group after 1 and 6 years as compared to mitomycin C group. So when nothing else works, you have to deal with the ciliary processes and you come to cycloablation, either cyclocryotherapy or cyclophotocoagulation. Cyclocryotherapy is accessible to almost every hospital, so it can be done anywhere. But lasers of course have a safer delivery and direct application to the ciliary epithelium. Transpupillary route needs a widely dilated pupil,
and you need a 530 nanometer frequency double laser for that. The transscleral route is 810 nanometers diode laser, and it causes a more targeted destruction with less of inflammation. Now we also have the endoscopic cyclophotocoagulation, which can be used in a more targeted fashion, and this has minimal collateral damage and less tissue disruption. There are complications like pain, uveitis and hyphema in these cases. And the most important, of course, in all these cases is visual rehabilitation, where you correct the refractive error, manage media opacities and amblyopia therapy to achieve binocular stereoscopic vision. The use of low vision aids extremely important in these cases. So in conclusion, an early diagnosis and prompt treatment can preserve vision. The responsibility of the surgeon does not stop with the surgery. Visual rehab is as important as controlling the intraocular pressure, and you need to make the patient's child understand that it is something which is lifelong and not a one-time surgery which is there. And thank you for a patient hearing.
Thank you, sir. So our next speaker is Dr. Anupam. She will talk on the management of the third nerve palsy with aberrant degenerations.
Good evening, everyone. I will be talking about the management of third nerve palsy with aberrant regeneration. As we all know, third nerve supplies 4 out of 6 extraocular muscles, and third nerve palsy is very commonly associated with ptosis as well and aberrant regeneration. And as it involves 4 out of 6 extraocular muscles, we have as a surgeon we have very limited options, because only 2 normal extraocular muscles are there, and when aberrant regeneration comes into play, the surgical management becomes more difficult. So it is also known as ocular synkinesis, and it is not very uncommon but well described phenomenon. It can happen in both congenital and acquired cases, and it can also occur primarily without any preceding nerve dysfunction, which is also known as primary aberrant regeneration. And sometimes it may be only sign of some tumor, cavernous sinus tumor or posterior communicating artery aneurysms. Most common etiologies are trauma, tumor, aneurysm, hemorrhage, and congenital condition, and some other miscellaneous causes. So pathophysiology starts from it is thought to be the peripheral misdirection of the regenerating axons, and histological evidence suggests that it typically occurs when damage results into transition or subsequent disruption of the endoneural integrity, and the bridging matrix of the Schwann cells, fibroblasts and macrophages is thus formed that regenerate the several neuronal sprouts, and these sprouts then innervate multiple end organs, and which leads to co-contraction. It is a result of persistent partial ocular motor third nerve dysfunction, which fails to recover completely due to disruption of the nerve. It may be many causes. The nerve that grows supplies muscles other than their original terminal muscle, leading to co-contraction of these 2 muscles, both original muscle and the other one, which is being aberrantly supplied by the firing nerve. And the primary oculomotor synkinesis or regeneration is seen in tumors when the third nerve palsy is not clinically present, but aberrant innervation comes into play before the clinical evidence of third nerve palsy. And the secondary condition when it is due to trauma, tumor or aneurysm or any surgery. In trauma, the more common etiology is hematoma formation and compression rather than the direct transition of the endoneural integrity. And the clinical types are lid gaze synkinesis or dyskinesis. In this condition, the eyelid elevates with the eye movement. In this condition, we can appreciate on adduction the eyelid opens. So there is aberrant innervation between the MR and LPS, which is called inverse Duane sign. If lid elevates with down gaze, it is called pseudo Van Graaff sign. The another one is pupil gaze synkinesis. This is a video. You can appreciate on adduction. This is a larger pupil size. You won't be able to appreciate from distance, but the pupil constricts on adduction. This is called pupil gaze dyskinesis. So the pupillary fibers are supplied by the fibers which are supposed to supply the medial rectus, and sometimes the pupillary constriction occurs on constriction, convergence. This is called pseudo agile Robertson pupil sign. When we come to treatment, the treatment options are primarily depending upon the muscles which are having relatively recovered supply, or the lateral rectus muscle or superior oblique muscle. But in 1980, O'Donnell and et al. Suggested a new approach by using contralateral, the recessed resect procedure on the better eye, the normal eye, to correct the both strabismus and ptosis in cases of aberrant regeneration. So in cases of aberrant regeneration, they suggested if we operate the aberrant innervation, normal eye having aberrant innervation, we can utilize this aberrant innervation to improve the ptosis by making the fixing eye in esotropic condition. Like by making the fixing eye in esotropia, that right, if MR is going to supply the LPS, we create the esotropia in the affected eye by operating on the other eye, and due to esotropia and more innervation to the medial rectus, the lid elevates. Advantages are simultaneous correction of both strabismus and ptosis in a single procedure, and it reduces the patient discomfort and expenses of two surgeries, and complications of ptosis surgery can be reduced. But disadvantages are performing in the sound eye, which may not be feasible in all cases, and sometimes patients refuse to undergo these kind of surgeries, and required surgery on uninvolved eye might lead to unacceptable restriction of the normal eye, restriction of the extraocular movement. This is a case of partially recovered post-traumatic third nerve palsy, having that the video I have shown is the pupil gaze synkinesis. We can see that pupil is constricted on adduction and pupil is much bigger on abduction. This is a primary stage post-op condition, post-op photograph with residual exodeviation per near vision recovered on from N36 to N18 after doing contralateral resect procedure. Again, this is a patient of lid gaze synkinesis and with inverse Duane sign. We did resect procedure on the other eye, and the ptosis improved a lot. We can appreciate from these 9 gaze photographs. So take home message is the contralateral surgery can be done in third nerve palsy with aberrant innervation, and this allows simultaneous correction of the both ptosis and horizontal position deviation. It improves the near vision in some cases of pupil gaze synkinesis and avoids complication of the ptosis surgery. Thank you.
Thank you, ma'am. Any comments or questions from the experts?
Thank you. I think the most complicated part would be the counseling of the patient and explaining how it works and how it will help in operating in the other eye, right? So, are you doing anything for the anisometric pupils, the dilated pupils?
So
any
we are
drops?
Giving some in case there are various people not having aberrant elevation and poor near vision because of dilatation of pupil, we are prescribing presbyopic correction.
Right. Okay.
Yeah.
Thank you.
Thank you.
Thank you, ma'am. So our 2 docs are left. One is by the Dr. Yusuf Rizvi. Is he present here? And another tag is by the Dr. Smita Mehra. I think both speakers are absent. So with this, we end our session on the pediatric ophthalmology. Thank you for all the delegates. Next. I think we should have a group photograph.
I think we can hand over the dice. Next.
So, good evening, and we are going to have a very interesting session, 2 minutes to win. So, basically 2 minutes to win is like sharing your tip this year. So, it's going to be very interesting. The tip will be presented in 2 minutes, and we will have discussion time around 5 minutes on that tip. So, I'll request Vishali ma'am to come here. Dr. R.S. Chauhan is there, Dr. Praful is there, Dr. Sanjeev Mishra, Dr. Manisha Agarwal. भाई 2 मिनट से ज़्यादा मत लो.
Pencils. AV team. AV team. We need pencils here. Pencils or pen.
Okay, we got it there.
Sound
four. Is open. Right. So we are going to have Uttarakhand State Ophthalmic Society's 2 minutes to win. It's a sort of intro, you can say. The first presentation is by Dr. Ajay Arora. I'll request to come here. He's going to present large asymmetrical macular hole, novel closure with differential ILM inverted flaps. Let us see what Dr. Ajay has to tell.
Large macular hole needs inverted ILM flaps to close. We call it a cabbage leaf inverted flap technique. Like in this case, we have angle alpha and beta similar. Hence, symmetrical flaps would close such a hole, as is demonstrated in this particular case, where 3 flaps close the macular hole by the conventional technique. You can see here beautiful closure with symmetrical flaps. When you have shelving edges and the hole is asymmetrical, we need to have a new technique. If we follow the conventional technique of symmetrical flaps, the hole will probably not close. Here the angle alpha beta are different, hence we decided that we'll forego the temporal flaps and cover the macular hole with nasal flaps. The technique followed is standard. Eyelid is removed, the ILM is stained with BBG, and then 2 flaps are created from the nasal to the temporal slide, and they cover the macular hole. The superior and the temporal eye limb is removed. Standard fluid gas exchange, and we were lucky to get good pictures on post-op day 1, day 7 and 8 weeks with a beautiful closure of macular hole, and patient's visual acuity improved to 6/9. So symmetrical hole, symmetrical flaps, asymmetrical hole, asymmetrical flaps. Do not stuff the flaps into the hole because they will close by Velcro mechanism. Thank you for your kind attention.
So any comments from you, Ajay? 30 seconds. And the questions from panelists and audience, please.
So the reason the macular holes close is because of the tangential force exerted by the ILM when they cover the macula, and this forms a closed compartment, and this compartment activates the RPE pump, which keeps this the ILM flaps together, and that probably helps in the inward movement and closure of the macular hole. If you look at the scanning electron microscopy picture of the ILM, the vitreal surface and the retinal surface of ILM are different. Therefore, if you put the vitreal surface onto the retinal surface of the ILM, it appears to me that they will close by a Velcro mechanism, and if you are able to get it right, they will close.
Any questions from the panelists or audience? All right, thank you, Dr. Ajay, for such a wonderful presentation. Our next speaker is Dr. Anil Saha. Please come here. The MYX technique is fast, novel and economic technique for scleral-fixated IOLs.
Modified Yamane X-Knit technique for SFIOLs. 1.5 mm horizontal from the limbus and 1.5 mm vertical marks are taken. A bent 26 gauge needle is introduced into the eye and then brought out through the corneoscleral tunnel. The leading haptic of a rigid 3-piece PMMA is fed into the needle and then brought out from the insertion point as seen here. The haptic is secured with a lock. At 180 degree opposite, in a similar fashion, a bent 26 gauge needle is introduced and then maneuvered out of the corneoscleral tunnel, and the trailing haptic is fed into the needle and exteriorized. A heat cautery is used to create the flange, and then similarly the heat cautery creates a flange on the other haptic, and both of them are then buried intrascleral. This patient had undergone an eventful cataract surgery in which there was a dropped lens for which vitrectomy was performed, and after that the scleral fixated IOL has been implanted. One can see that the IOL is very well centered . And now the case is being closed. Fast and effective. MYX.
So how it's different from the classical manic?
Good evening, everyone. So Occam's razor says when you have multiple options to you, the simplest is the best. So we know SFILs have various techniques. There is glued SFILs, there's Yamanes, there is these foldables ones from the house of Appa Swami, the C-Flex. We choose this method, which we found works very well in our hands. As cataract surgery, the bulk is too many, and surgical aphakia, we all know the numbers are pretty huge. When you have such cases with minimum tissue handling, as you see, there is minimal conjunctival dissection, there is no scleral flap created. We maneuver the lens. It's a rigid haptic, so it's very easy to bring it out from the either way, create a flange, put it back intrascleral,
and we have a well-placed IOL with good visual results where we see visions ranging between 6.9 to 6.6 depending upon, yes, the posterior segment. Economical because these lenses are very cheap and with no financial interest, and they help us do this surgery in a very quick time. It's just 2 minutes, just like as much as the video is. So these that we are using are the Orolab ones, sir. No, sir, they are the Orolab teams outside.
It's available on the trade?
Yes, sir.
It's available on the trade.
I mean, the Orolab stall is there, the whole team is there, sir.
So
and yesterday only, day before yesterday, prior to coming, we have done 2 such cases more, sir.
Is this a foldable IOL?
No, sir. This is the rigid.
Rigid.
So that is the like we've been doing the foldable ones also from the other companies.
So for rigid lenses, you have to make a 5.5 to 6 mm entry,
yes,
right?
Sir.
So, but if you use a foldable one, you can get away with 2.2.
True.
So, don't you think this is a limitation of this technique?
Yes, sir. The difference between the two is like we do the foldable ones also. The first thing is the cost of the lens, sir. The foldables ones come a little more expensive. To the haptic in the foldable ones, they are not as rigid or sturdy compared to the rigid ones here. So when you are maneuvering and bringing the haptics out, sometimes they bend or they might fracture, which might then need you to get a new lens inside. Those possibilities in this one are not there.
Can you have the mic, please?
Ma'am, haptic extrusion, yes, so the haptic extrusion, so that's why we advise whenever to make the flange is to not to be too enthusiastic and try to create a big flange. If you create just a little heat cautery there, it will just makes it blunt. It easily goes intrascleral, and that's the reason why we want you. The next question which many times we get asked is, then won't it slip into the vitreous cavity? Because we have made a biplanar, we have made a 2-plane entry, and once that flange is created, it goes right inside the sclera, and we have placed the conjunctiva also over it, because the conjunctiva was displaced initially while putting the needles in. So that forms a seal over the wound, and till now we have not seen any of these cases where the haptic has come out, which we used to see in the ones in the previous glued IOLs when we were putting into the scleral small tunnel that we were creating. We used to see many a times the haptic getting a little dislocated and some having complications regarding to that.
Well, every technique has their own limitation.
Definitely.
So, but in this technique, one concern, maybe long-term concern, is you are just tucking it into the sclera, and there is a simple thin conjunctiva overlying it. So risk of end-off is definitely there, although it hasn't been reported till now.
No, sir.
But that theoretically that risk is there. And in your video, I saw once you suture the main wound, then you created a side port. What was the reason for that?
That was intracameral moxifloxacin sensor.
So for that you need to create a side port. You could have injected with simple 30 gauge, 26 gauge.
Okay, yes.
You created a new incision for that, so yes, that is what I was little concerned. Why?
Directly inside the chamber.
Directly inside.
Yeah.
Sure,
slightly maneuvering ureter.
Sir.
Slightly maneuvering ureter, you can go directly inside without creating a port. Thank you.
Thank you, sir.
Very much. So next presentation is by Dr. Megha Agarwal. Suprachoroidal hemorrhage. You want to comment?
Yeah.
There's no voice here.
Yeah. So in the video here we can see that we have hooked the muscles, and at the inferonasal quadrant where it was the most, the choroidal hemorrhage was the most dependent, we have made a linear circumferential incision 8 mm away from the limbus, and once the incision is made, then we will just with the help of the tip of the bud we can just do the drainage here. In this case, already we had waited 4 weeks, but the clot lysis did not occur that well in this patient because he had multiple other eye issues. So here we can still see that the clotted blood is trying to come out, and in this patient also we had performed a vitrectomy because there was a retinal detachment along with a massive suprachoroidal hemorrhage.
So post the drainage, after visualizing from the indirect, we went inside, did a vitrectomy, followed with PFCL injection, endolaser along with silicone oil implantation. And then after that, because of the PFCL injection, the remaining blood that was still not being able to be drained started to come out properly. And then after that, an encircling bandage was done, endolaser, and then a silicone oil implant was done.
Any comments from the ma'am, please? Mike.
So Megha, we all deal with suprachoroidal.
A CT scan revealed a foreign body in the anterior ciliary body region. In surgery, cataract was removed using phacoemulsification. An attempt was made to visualize the foreign body through the conventional microscope, but it could not be located. So endoscope was inserted through one of the ports. Now you can see the cuttage of the vitreous, ciliary body area and anterior sleeve body. This is optic nerve and the posterior pole area. I am trying to locate the foreign body, but I am not. Here you can see the cut wedge of the vitreous, ciliary body area. Now you can see the foreign body iron chip is lying at the anterior ciliary body area. This is the foreign body. Now with the help of intraocular magnet, I will try to lift this foreign body from the surface of ciliary body. But because of the adhesion, the foreign body is not coming with the magnet. Now with the help of cutter, the adhesions will be removed and then the magnet is again used to lift the foreign body. Now the foreign body comes with the magnet, but it gets stuck at the sclerotomy size because of the smaller opening. Now with the help of MVR, the opening is enlarged, but in this process the foreign body falls again on the posterior pole. But with this magnet, again with an enlarged opening, the foreign body can be removed outside the eye. Endoscopy allows procedures that are not possible with microscopic view because of various reasons. Endoscope is a useful equipment in vitreoretinal armamentarium alone or as an adjunct to conventional methods. Thank you.
So Dr. Puneet, why this ping pong you picked up and dropped and please?
Why this was, because when I was lifting it under endoscopic view with the help of the magnetic probe, because of the size of the sclerotomy was small, that's why it got stuck on the sclerotomy side and it fall again.
Thank you, Dr. Puneet. I have a question. You had clear cornea, so once the lens was out, so why did you prefer endoscopy over the conventional,
Because the foreign body was not, I was not able to visualize the foreign body even with the reasonable depression. And since I have an on-endoscope, it is an easier technique to do if you are doing it less traumatic, faster, and you can do it in a much controlled way if you are removing under endoscopic view.
Okay.
So it was not visible with the indirect.
No, it is visible with indirect, but
it should
it is not
be because
visible
it's
with
a large foreign body. It's too large a foreign body not to be seen.
No, it was, I think.
Yeah.
No, it was not 4 to 5 millimeters, less than that. But see, if it is lying on the anterior ciliary body, sometimes you are not able to localize it. And if you have an endoscope, then why would you not use it?
Which viewing system you use?
So I have Hawksflight and this IBOS.
You can come in the front if you like. There are chairs.
But with such a large phone body, you didn't do it before surgery. I mean before going for surgery.
I totally agree. The issue here is not whether the foreign body is large or small. The issue is we can use endoscope for these kind of procedures where visualization may be difficult. That is all.
Yes, but I wanted to know that before going for surgery, CT scans should have been done to find out.
It was done.
But if once you know where is the foreign body, you can easily locate it.
But during the surgery, sometimes you are not able to localize it. You can see it on the CT scan, but actually when you are performing the surgery, you may not be able to visualize it. And even if you are visualizing, you have to depress it with
I think we'll have to give it to the operating surgeon. That time there are situations where the surgeon feels this is right and he does that, and I think we'll have to give it to you, sir.
This is a different technique which you can utilize. I'm not saying this is the only technique, but this is another way of doing things.
Thank you very much for this wonderful information.
Point is well taken. You do what you see actually.
So the next one is by Dr. Rajendra Prasad. Prick is the trick. Okay, you can just.
So I'm going to talk about the prick is the trick in the prevention of Argentinian flag sign. So how you prick the intumescent cataract capsule before you start the capsular access is important. So as you can see here, once you prick the anterior capsule, the fluid start and see the waves. This is what happens. The intraocular pressure is going to release through that prick, and it's going to produce a tension at the edges of the prick. And if you do not take care, that prick is going to extend to the periphery and it's going to lead to the Argentinian flag sign. So as you can see here. And it depends how you prick, and how to prevent this Argentinian flag sign is if you prick with a circular hole formation on the anterior capsule. So you have to have a device which can produce a circular hole on the anterior surface of the capsule, so which could release the fluid. And because if you have made a circular hole, it will have a much higher resistance against these forces, the intralenticular forces, which is going to act on the edges. See the kind of prick, and if you have this kind of prick, then your pressure is going to release and you can start the capsular access. Your capsule is going to decompress. So this is the device which is called as the microcapsulotomy prick forceps, and this has a tip which is round and circular tip like a needle, what we use, the saving needle, not like a 26 gauge needle which has a sharp tip. And once you prick, you get a fluid which is coming out of the capsular bag, and this fluid which is coming has a lot of pressure actually, and if you produce a linear prick on the anterior surface, it's going to extend to the periphery. And if you make a round circular prick on the capsule, it's going to release the pressure and capsular bag is going to decompress. Once your capsular bag is decompressed, then you can very easily and very comfortably start your capsular access without the threat of extension to the periphery, because your capsular bag is already decompressed. So this is the way to do the capsular access in intumescent white cataract. Thank you. Voice, not here.
Can you use sharp chopper instead of this?
If we don't have this instrument, can you, because we don't have it,
See,
so can you use?
So that is the point, because you see the capsular bag has a pressure, intumescent cataract. There is a lot of fluid and also the vacuum pressure which is there inside. So when you prick, the pressure is released and it produces a disruptive force, the point where you have punctured it. Now it depends how you puncture. If you use a 26 gauge needle, it's a sharp tip, it's like a knife. You puncture, you get a cut. You will produce a cut on the capsule. If you use a sharp chopper, it will also produce a cut. If you use a capsular access forceps, what do? You tear and then you start the capsular access. So you're making a cut. So you know very well, if you make a cut, linear cut, and if you have a high pressure, what is going to happen? That linear cut is going to open up easily and it will extend to the periphery into the Argentinian flag sign. But if you make a microcapsulotomy, like we make a small capsular access before starting. So if you have a device which makes a microcapsulotomy, you just prick it with a needle which is round tip, you prick it, you make a small hole. Now that hole is going to evacuate the fluid and the pressure, and since it has a very high resistance against any kind of disruptive force, it will not extend to the periphery.
So with the Bandana, the point is you have to buy one.
With the Ortoli machine, they give the RF cautery, that capsulotomy needle. So that is very useful. With the Ortoli system, there is a system which they give the pencil to make the capsulotomy.
That's more for pharmaceutic.
So that can also be used for this.
It has
because that makes a with the electric sharp cut and the round
it has
and
to be a
edges get sealed itself, so it doesn't extend.
Yeah,
because
yeah,
it is,
that's right. So this is the tip has to be a needle kind of sieving needle.
It has to be round and
it should be round and pointed
seal.
tip. Like we have a ball pen tip and
should not be linear.
sieving needle tip.
So sewing needle is not causing any damage to cloth nearby.
Yeah.
It's just giving a small puncture on the center. It's probably like that.
It's not disrupting the fibers also. Yeah.
One thing, Dr. Zandar, actually when you give the prick, you don't have to come out, because if you come out, it will the pressure will go toward that opening side and it may extend. You should stay there, prick and stay.
You can't stay because you see, because the capsule, structurally it's so, like if you keep it inside, you cannot, then it will start extending. You have to prick and come out.
No, prick
and come out.
Prick and remove, but don't come out.
No, you have to prick and come out. See, actually, because the idea is you make a hole, circular hole. Idea is making a circular hole. And you know very well that if you have a circular hole, it's not going to extend. It has a much higher resistance. एक circle जो hole है, ये तो extend नहीं करेगा ना. Extend क्या करेगा? अगर आप cut कर रहे हैं, अगर capsule को cut कर रहे हैं, तब extend करेगा. Circular hole will not extend. आपने circular hole बना दिया, you come out. अब ये hole जो है एक बना सकते हैं. You can make multiple also in some cases with the multiple fluid pockets are. कुछ cases में होता है multiple fluid pockets are there. So you can prick multiple prick. Or if it's a complete liquefied intumescent cataract, then you make it just single prick and come out. The fluid will come out from that.
Which instrument is used for this?
This instrument is called as the sieving needle microcapsulotome, and a lot of these trade people are making it now.
Good.
So it's called the RP sieving needle?
Yeah, this is called as a Rajendra Prasad sieving needle microcapsulotome. And this sieving needle was last year the maximum sold instrument in the whole of the trade in AIS Kochi.
Are there some financial interest?
No, I don't have any financial interest because I have just said sell it at the cheapest rate possible because I am not taking anything out of that.
Okay, thank you so much. So we have next presentation by Dr. Ritu Jain. Yeah, she is going to speak on tips and tricks to analyze perimetry.
So good evening one and all. Myself Dr. Ritu Jain from Rohilkhand Medical College and Hospital. So we'll be discussing on the tips and tricks to analyze perimetry. As you all know, the visual fields, the superior, the inferior and the temporal. We can go for the perimetry when there is a glaucoma progression in the chorioretinal lesions. The kinetic perimetry is there. There are the static perimetry. What we are doing is a static perimetry. The central 30 degree we are seeing, or the 24 degree, that is a Jerem screen. The 30-2, the suspicious cases. The 24-2 we do in the established cases. And also we know the 15 degree is the blind spot from the central fixation point. The selection strategy, we all know the Sita standard and the threshold strategy. This is what we get in the perimetry. These are the different zones. The most important is you should put the correct data of the patient because it compares it with a normal patient. So the correct data, the age of the patient is very important. The size of the pupil, it should not be more than 3 to 4 mm. The reliability indices again are very important. The fixation losses, the false positive and the false negative. This is the raw data, which is the first zone which you get it. The lighter the shades, the more good the perimetry is. That is how it is, you explain it to the patient. The zone 5 indicates the total deviation numerical pattern. That is the aim of the field chart, is to show the field loss in the scotomatous forms. The more darker the areas, the more the difficult the field is. The zone 7 is the pattern deviation numerical plot that is comparable with the cataract vision of the same age. The zone 8 is again the pattern deviation. The gaze monitoring is again important. If it is a poor fixation, you get a small spikes. These are the certain perimetry forms which we get. The double arcuate scotoma, which is almost the advanced case of a glaucoma. This is, to summarize, the glaucomatous field defects can be the specific and the non-specific defects. So you should see the specific defects in the glaucoma. The early non-specific defects can be the isopter contraction. The early significant defects are the paracentral scotoma, which typically affects the arcuate fibers. So thank you very much. The eyes are priceless and the eye protection is cheap. So always, if you suspect a glaucomatous patient, you should always go for a perimetry. And the take-home message for this, I think, is that the patient age should be properly be filled, and the reliability indices you should see whether the field is reliable or not. That is the take-home message.
Any questions to Dr. Ritu?
Thank you, ma'am.
Okay,
This
thank
often
you.
takes
Thank you so
1 hour.
much.
It takes minimum 1 hour to interpret. You combine that
I
in
think
2 minutes.
Explaining perimetry in 2 minutes is.
But residents, please don't carry this concept.
It's too much.
So resident, please don't try to read in 2 minutes. Huh?
So next is Dr. Rohan Mehra. He is going to speak on tips and tricks to analyze perimetry. Oh, I'm so sorry. Basically, it was a computer copying, so I copied the topic, but the topic is there. Lenticular extraction in hydrocannula in smile procedure. Sorry.
Here, we demonstrate the separation of the lenticule and its extraction by pulling it out with the help of a microforceps. If we take a look at this particular case, there is a marked resistance in the separation of the lenticule, which leads to a tear of the hinge in the tunnel incision. This resulted due to improper dissection followed by a tugging movement to retrieve the lenticule. Such complications are not uncommon. So where did the idea originate? One day, I had a severe earache and I went to my ENT friend. He told me that wax is the culprit for the earache and removed it by irrigating my ear cavity and not pulling it out, which got me thinking. If the ENT can do it, then why not use it in ophthalmology? So I took this idea to my mentor, Dr. Gaurav Luthra, and we developed a hydrocannula to extract the lenticule, making smile surgery further less invasive and extracting the complete lenticule without any cuts and tears. The hydrocannula is of 23 gauge and it bends to facilitate its movement over the contour of the cornea. Here are a few demonstrations which show how a simple idea can make a huge difference in the reduction of complications in smile surgery. The hydrocannula is introduced and the saline is injected, which aids in smooth retrieval of the lenticule. This lenticule is now placed on the cornea to show the intact edges of the lenticule. Another example of the same technique, which is simple and reproducible, leading to the extraction of the lenticule in totality without any cuts or tears, making it imperative that we retrieve each lenticule in totality without any tears and cuts, and we store it for possible future use, hence making our innovation extremely important and one that could possibly help many individuals for restoration of sight, leading us to call this lenticule my precious.
The idea behind this actually is that each and every of these lenticule has gained more and more importance with tissue addition surgeries, and we must take out each and every lenticule in totality rather than trying to pull it out and cut it in the middle.
Yeah, but Rohan, see, you can just flush out the lenticle once it is completely dissected and free. And once it is dissected, you don't need to irrigate then, because it's going to cause the unnecessary edema next day. Dr. Gaurav, I know when he started the LASIK Smile, he was doing this. I don't think he is doing it anymore. But because the slide which you started with, those were the stuck lenticle, which the dissections were difficult. If it is stuck, anyway you can't take out with the hydration. So and once you know that it completely has been dissected, you don't need to irrigate it. It just comes out whether itself, or you just introduce the forceps and take it out.
What we noticed is
by adding on the hydration, you are adding on the one more step to the procedure. Right?
No, sir, but you're reducing the step of going in and taking it out. So how is it adding another step?
Yeah, so you don't.
Instead of going in and taking it out, you're going in with the hydrocannula and taking it out.
Yeah, so it's just a matter of.
It's a replacement of a step, not addition of a step.
Yeah, so that's once you have completely dissected, it's just taking it out, and 90% of the time, if your technique of dissection is correct, it comes
here
out
we have had a 99.8% complete retrieval.
Complete, so anyway will come. See. What you started saying that partial which has been stuck there, that means it is the dissection is not complete. If the dissection is not complete, then even with the hydration is not going to come out. Rather is going to create the edema. So once it is free, you have completely separated the anterior and the posterior plane, then anyway it's going to come out, whether you go to came out with the irrigating cannula or with the forceps. Right. So what I am saying, 99% of the time, if your dissection is in a proper manner, the half of it anyway comes out automatically. You don't need to actually go inside with the forceps. There are very rare instances when you have to go inside with the forceps and go, because the forceps doesn't open inside, the opening is very less because the space is less. So anyway, to use the forceps, you need an edge. So your lenticular edge has to be close to your opening. So yes, I would agree with you. When you have the lenticule stuck on the far side, you can just go with the irrigation flushing.
Yeah.
In fact, this is what I was thinking. You were doing all this thing in lenticle which are stuck. So you went inside and injected fluid so that it became free, then you pull it out.
No, sir. So basically, this is actually a 7-minute video. Here I could not show a procedure.
I got your point now. You mean to say you have to detach from all around, then you have to inject fluid.
So either you pick it up with the forceps or you do a cannula.
My concern is, see, that's a closed interface, right?
Yes.
And the fluid that you are injecting, you are not sure what is there. It may have impurities, it may be contaminated. So I feel, for me, it's not a good idea to go and inject some fluid inside a cavity which is going to be like that in post-op stage.
Does it washing
But
some
anyway,
debris also there? So there may be some debris also there. No. Okay.
But when we are learning smile, we were doing all these things. That I completely agree with you.
Right.
It is like hydrating cornea.
Yes.
So if you, in a closed space, if you put fluid, it is like hydrating the cornea and it will become sealed and edema will be there for quite some time.
And the risk of infection goes up. Theoretically, with the fluid.
Anyway, this video also got a award in Oscars also.
No, we are not saying it's a wrong technique. Just discussing that.
So we are discouraging your own. We have the next speaker is Dr. R.P. Singh. He is going to speak on retrieval of IOL from intact posterior capsule.
So this was a case referred to me for the drop IOL management. And when I examined, I slit lamp saw that there is a complete...
50-year-old female patient presented to our center 2 weeks.
So the complete capsule was there. So the surgical challenge was there how to retrieve the... because then I have to remove the capsule and take out put the SF IOL. So that was the plan for the surgery. So after doing the vitrectomy, once the vitrectomy was done, the IOL was picked up with the end gripping faucet. This is the next step. So you can see that the capsule was there. So instead of eating the capsule, first I decided to lift the IOL. Then with the handshake technique, that is what we use in the retrieval of the RIFBB, I stabilized the lens there with the handshake technique with the 2 end gripping forceps. And that time decided to, why not to remove this from the joint dialysis part. So there was a inferior temporal joint dialysis here, how it goes. You can see there. And from there with the anterior, we made a entry and gently took out the IOL from that dialysis. You can see the dialysis there, inferior temporal dialysis, and brought the lens into the anterior chamber and then we stabilized. Now, if you see this lens is upside down, it's in the opposite direction. So what I did was, first now we take out the trailing haptic as well from there without damaging the capsule, stabilizing completely in the anterior chamber. So now I decided to place this bag into the bag because the bag was intact. So we placed the CTR ring. I decided to put a CTR ring to stabilize the joint dialysis. And you can see the lens is free out into the anterior chamber. The viscoelastic was put to minimize the damage to the endothelium. So now I took a CTR ring and that was injected into the bag so that the capsular dialysis part was taken care of. So once it was done, now you see the lens is upside down. This is in the opposite direction. So then I flipped the lens so that it can be placed in the proper side. So it was flipped with the help of 2 sense keys. It is flipped in the 2 sense keys and then the lens was placed into the bag. We can just put the end now. Yeah, last one. Yeah. So you can see the lens is nicely placed into the bag. So the purpose of showing this video is that the idea is to minimally traumatize the eye. Already it has damaged the AZ. So once we plan our surgery, you should think of how minimally you traumatize further and give the best results. So these are the little innovation at the time of the surgery I decided to go for. Otherwise, we would have gone for the removal capsule, take it out and put the SFIL as it is. Thank you.
Thank you. Any question to do?
This is a I don't, yeah, it's a hydrophilic lens, aspheric biconvex aspheric lens, yes. Dialing. You know, once it is opposite, it's difficult to place again. So, you, because already the granular dialysis is there. Yeah, other way. I changed it. I could have placed straight away down again, but then, you know, you can't dilate in the opposite direction. The dialysis is there. So, I didn't want to dilate the lens. Yeah, I will delete that part. Yeah, so my bag was stable, my entire anatomy was stabilized. Well, once you get overconfident, then you start doing, you know. Yeah, and this also I could have left, but then since I was completing the surgery, and when you need to dial the bag properly in the direction of the dialysis, so the dialing in a proper direction is easier in the opposite direction.
Actually, I was thinking that flipping over would damage the endothelium of the cornea. Yes. Flipping over the lens was injuring the endothelium, and then I realized he must be a posterior segment surgeon, not anterior segment surgeon.
No, the message I wanted to convey here, to become a good posterior segment surgeon, you should be a good anterior segment surgeon as well. Otherwise, you won't be able to do such things.
And these type of lenses can be put in the sulcus also, if required.
No, because they are dialysis, so sulcus was not the option. Because from there only it has went into the posterior.
No, it was soft. I mean, it was foldable. So this could not have been placed in the sulcus.
It was probably placed in the sulcus because from the dialysis it went through.
This is what I was about to say.
It's a hydrophilic lens. Yeah.
This is what I was about to say. The kudos must be to the primary operating surgeon who injected an IOL in vitreous cavity without damaging the bag. Right?
Yeah,
the credit must be given to the primary
please
surgeon.
Give me some credit to me also to keep from the same.
Thank you, thank you. So we move on to the next presentation by Dr. Sangeet Mittal. He is going to speak on using C-flex IOL for scleral fixation.
A 26-year male with high hypermetropia gave history of trauma to right eye. There was globe rupture with limbal dehiscence, traumatic aniridia and spontaneous expulsion of lens. He had undergone perforating eye injury repair along with vitrectomy for retinal detachment and vitreous hemorrhage 6 months ago. The patient was planned for secondary IOL using aniridia lens. Aniridia lens was prepared for scleral fixation using the flange technique. Unfortunately, the haptic of lens broke during the procedure. As the patient was already prepared for implantation, it was decided to go ahead and implant a normal IOL and manage the aniridia later. The only available lens for the required power was a C-flex foldable lens. 26 gauge needle was used to pierce the haptic of the IOL and 50 proline suture was threaded into the lumen of the needle. A bulbous flange was created using heat cautery. Similar procedure was repeated on the other haptic. Marks were made 180 degrees apart on the limbus. 5 mm conioscleral tunnel was made superiorly. Bent 26 gauge needle was inserted 1.5 mm from limbus and brought out through the main tunnel. Second end of the proline suture used to flange the haptic was threaded into the lumen of the needle and brought out at the desired point of fixation. Same procedure was repeated on the other end. IOL was inserted inside the eye and centered in place by pulling and adjusting the proline suture. After centering the IOL, the extra suture was cut and another flange was created to hold the lens in place. Again, the same procedure was repeated on the other side. A conjunctiva was used to cover the flanges. Post-operatively, a colored contact lens was given and the patient had best corrected visual acuity of 6/9.
So the point was that you can, sometimes these things happens and you don't have the proper lens in the inventory. And this is the most common lens, I think everybody uses it and they have all the inventory maintained. So you can use it for scleral fixation also.
No, at times patient, he might have done some good work in his life, because if you would have placed that aniridia IOL, our experience says they lead to intractable glaucoma because of that pigment release. So I think for patient benefit, the haptic got broken and you put a hydrophilic lens in the eye. We must have done this aniridia lens in the 8 eyes.
I have done aniridia lenses otherwise also, and the glaucoma is, I don't think, see, it is very, it happens, but it's not in all patients. I think 1 out of 4 patients, 25% may develop glaucoma, and that too is not intractable. It's easily treated with medicines.
I would agree with that. I think we have very long-term follow-up of aniridic SF-IOLs. I have also not come across intractable glaucoma. The only problem sometimes can be that they can have a lot of inflammation inducing CME. So that also is very much treatable, but otherwise the aniridic SF.
Which company aniridia you?
Eyecon.
Okay, maybe our cases were severe enough. But we had a very bad experience.
Sometimes what happens is that these post-traumatic cases already are.
Yes, I agree with you. In post-traumatic cases, it may be the results are good, but if you operate in aniridia, congenital aniridia cases, there the results are not that optimal.
Maybe.
It's big.
You have to make a large 10 millimeter incision.
Yes. Yeah. Thank you.
Thank you. So we move on to the last but not the least, the important talk and with the local flavor by Dr. Vijay Joshi.
नमस्कार, मैं डॉक्टर विजय जोशी बेसबट्टी बोल रही हूँ। ये मरीज पहाड़बट्टी आ रहे थे हील को होगी 1 हफ्ते पहले मेरे आँख में मचमची है रहे अनमनाहट जैसे मतलब गुदगुदी जैसे रहे मील ड्रॉप डालवे जब आँख चेक करी तो भीतर तो वहाँ जौंक छीने जौंक पहाड़न में होने ने जौंक वहाँ भीतर छी बहुत लपलबाल है रहे तो मील का तू स्रोतबती पानी पी तो मरीज ने बताया कि हाँ डॉक्टर साहब मील स्रोतबती 1 हफ्ते पे पानी पी तो मील दवाई डाल फिर ये जौंक बाहर निकाल हल छी तुम देख सकत छा ये जौंक छी के पहले लपलबान जैसे कसर है तो मील यही कहन छी कि तुम जब 100 रुपये पानी पिया तो एक डब्बे में पानी ले भेर पिया डायरेक्ट मुंह लगा भेर स्रोत में पानी ना पिया। धन्यवाद।
Thank you.
पानी नहीं पिया समझ नहीं आया क्या था वो?
So first of all, I would like to thank Dr. Vinod Arora sir to present my video in my regional language, and this was the video I have made for the villages for the education purpose because I used to belong to a place like Haldwani. There is a gateway to Kumaon, and most of the people they does not know even Hindi. So she presented. She was a 16-year-old female that presented with foreign body sensation and some uneasiness. Even she was not about to, in a position to tell me. She is saying uneasiness, and eye conjunctiva was very much pretty, healthy. No redness was there. So I just look into the fornices, upper fornices. I found this vampire inside there, which was, taking the blood away from her. And in the end, I would like to say that whenever we used to get this type of history that patient has come up, from the, we are going to the jungle safaris, trekking, and villages people who used to drink water directly from the natural reservoirs, natural sources of water. When you used to drink, that leech got the opportunity to get into their eyes. What message I used to give them that whenever you used to drink water from this natural reservoir, you can use a tumbler of glass or bottle to drink water indirectly from it, not that. Thank you. Thank you, Chief. Sir, this was my experience. Yeah, you are right. I think you have got experience removing it out. Actually, it has got a sucker. Ma'am, it was not easy for a single surgeon to take it out. We have to, You removed it in toto? Yeah, we have to. Otherwise, it's. Ma'am, sir, one person, you have to pull it from the, press it from the sucker end
and second it takes it from the tail end. Two people were there, and initially I carried it with myself. And for 1-2 minutes, even using proparacaine, 0.5%, I will not get succeeded in immobilizing that leech.
It's a claw which has gone inside.
Vijay, does it help to put some saline in it?
If we are not having this proparacaine or selcergen, we can use this saline. Other things are also
Because they say the salt helps to
Yeah, ma'am is quite right that it is there in
But you cannot put salt in eye.
hypertonic saline. It is written in text that we can use hypertonic saline to take it away.
But pulling it with the process is difficult because one technique very prevalent or I am also going to say and it's a very common problem in hills. People and the leech is very common in our water, the natural water, and people drink that water. Now, what you have to do is, because if you find a leech in any area, you have to take a bowl of water. You have to show the water to the leech. So leech will automatically leave that point and try to come into the water. This technique being used not for the eye area because but other area of the body, like you show the water, the leech will come into the water.
Once it has sucked blood.
I have one personal experience of one of the patient who was IAS officer who was admitted in our department with corneal ulcer, non-healing corneal ulcer. So because he was not allowing anybody to touch the eye, so nobody could evert his upper eyelid. When my HOD told me you have to take care of this patient, so I took him to minority, put paracaine, and told him, listen, your ulcer is not going to be healed unless I touch it. I have to touch it and evert the upper eyelid. When I everted the upper eyelid, to my utter shock, I could see the ring of that eye drop. Eye drop vial has got a ring. That ring was inside that upper eyelid, and that was causing the irritation on the cornea. So, if that can go inside that upper eyelid, leech can very well go.
RP?
Coming into the nose, nasopharynx, but eyes, I think the unusual. Yeah, eyes very unusual.
So Vijay, thank you so much, and for giving a public education in local language again is very important.
He's from which place? He's from which place?
He's from this place only, Kumayu, yeah. Haldwani, yeah. So, can we have the display? So I think we have come to the end of this, and while the result is being prepared, thank you very much for attending this session. And I'll be reading your inputs how to improve it further. And Dr. Vishali, you have to stay here.
It was jam-packed. It was jam-packed. It was jam-packed all today at 6 o'clock, 6:30.
So the winners will be announced shortly. I've got few more videos, but don't think time permits us. Some of the award winners in the earlier sessions. So the excitement is growing up, and we have installation at 6 o'clock. So we're moving from this place to another. We got another 15 minutes.
Inauguration at 6 o'clock, right?
Inauguration means Hall A. Yeah.
6 o'clock.
I'll just show you a small clip by Dr. Dhami.
We describe a novel instrument designed by the author that combines two mechanisms, one iris stretching rod on its one side, and two a curved chopper on the other end. We describe our initial experience with this instrument across a spectrum of small pupil management and eyes with intraoperative meiosis. This is a cataract surgery being performed in grade 4. After completing a capsulohexis, we observe intraoperative meiosis and floppy iris prolapse in main wound. Using viscoelastic, we refill the anterior chamber and...
So we'll skip it here. And can I have the sheet, please? I request Dr. Vishali to please announce the results. Please come here. कौन सा winner कौन है? नाम 271.
टोटल वाला
सबसे ऊपर है ना? 284. 284. Yes.
Thank you, Dr. Vinod, and it's my pleasure to announce the winner, Dr. Rajendra Prasad Prick. But
So-
it was a very close call.
Close.
Yeah.
And the second is, are they tied? I think they're 2 persons.
Yeah. The second is lenticule extracting hydrocannula for smile, Dr. Rohan Mehra, with Dr. Vijay Joshi when inside the eye.
Dr. Vijay Joshi and Rohan, you share the second place. Okay, maybe, yeah.
Third also?
No, there is, sorry, we missed it. Sangeet Mittal is there. We missed it. You should have rounded it. So the second place goes to Dr. Sangeet Mittal.
And the third
And
is
the third is by Dr.
shared
Rohan.
by the two.
Thank you very much. Thank you, ma'am.
Thank you.
Thank you all the judges and panelists.
Comrades, Arif.
He's always
I told you 10 years back, He's Rohtak man. Actually, he came in Rohtak.
Taking a
इधर आ जाइए. Let us try.
Thank you.
एक मोबाइल से ले लो.
So this time it is AI integrated. You have to get a selfie done and after you will be getting a video. Hi.